Liu, are you there, Liu? Liu? Prashant? Rohit? Rohit, Liu has come. Can you make Liu also as a co-host?
Okay, sir.
Yeah.
Hi Sachin, how are you?
Hello, Professor.
Hi, how are you?
Yogasato. How are you? I can't see you.
Nice to see you. Today is Saturday. Are you operating now?
Yes. I am operating. Balamurugan is operating. I have just come out for some time.
Okay. You're very hardworking. Thank you very much.
We have a lot of cases.
Yeah, oh, really? Good. Good
Yes,
for you.
yes.
Thank you.
Yes, ma'am. Yes.
So I think maybe in 5 minutes we will start.
Yes, in 5 minutes we'll start.
Okay.
Yes.
So Liu, are you here?
He just joined. Liu, are you there, Liu?
Yes, Prof. I'm here, Prof.
Okay. Nice to see you.
Yeah.
Thank you so much.
Thanks, Prof. Yeah, thank you, Prof.
He and you doesn't have any time for sleep, I think.
It's okay,
Thank you
Prof.
so much.
No problem.
Thank you. Dr. Liu, so the current flunk president will talk something at the closing remark.
I only invite him for closing, Prof.
Mm-hmm. Yeah.
Because the closing that we're going to use the live telecast after the Zoom presentation.
Yeah.
So then he can be online. Yes.
Yes. Okay. And what about LOHABI? LOHABI is online talk only for African seminar or both?
Yes, on both. Because at night, all from 8 o'clock night till midnight is all both continents. They will stream at the same time.
Okay. I understand.
Yes. Yeah. Thank you.
Thank you. Sachin, it's very complicated because of jet lag. So in between the two continents.
Rohit, are you there? Rohit?
Yes, sir.
Yeah, I think the live streaming is stopped. Why did it stop? Yeah.
Yes, sir. Please show me.
Rohit, first you stop the share. You first या पहले तुम शेयर को स्टॉप करो. हाँ, अभी वो पहले शुरू करो जहाँ पे भी है ना, तुम अपने विंडोज एक्सप्लोर में पहले शुरू करो और फिर उसके बाद उसको शेयर करना है. हो रहा है? क्या हो रहा है? डिले है क्या उसमें शायद से, क्योंकि वहां पे शुरू हो गया.
Also, and
Don't do anything, okay? Let us
one more
start.
very important person from Ecuador, Professor Byron Salazar. And also the African patron, the sponsor and great teacher is Kazate Kalangu from Zimbabwe, and also the Muhammad Freshi from Kenya. So both of them is a very important person from Africa, and a very great leadership for all young neurosurgeons. So one another is no need to introduce, is a Professor Nazir L. Gandhi. So all three, the big, the sponsor and teacher, and also the patron is to support all over your educational activity in the next 2 days. I wish that all of you will have the great the learning, and also this time is not enough for hands-on or live the surgery, but also in the future we can prepare for all of you to have such a nice chance. Please enjoy. Thank you very much.
Dear friends, dear colleagues, ladies and gentlemen, I would like to extend a warm welcome to all of you to this fantastic course organized by the Asian Congress of Neurosurgeons and by the Republic of Zimbabwe and the Democratic Republic of Congo. This course is not only targeting these three entities, it is also targeting all students across Africa and also all the world. I would like to thank Professor Bokato, who had this initiative. This is not the first time she organizes a course in Africa. She has done it before, and she has been all over the world. Because, like all of us, we cherish and we are very happy to share our knowledge with young neurosurgeons, because we all know that young neurosurgeons are our future as human beings, but also they are the future of our specialty. I would like to thank our teachers who are always present and keen to give their time and their knowledge in order to educate our young neurosurgeons, to make sure that the new generation is better than our generation, so that our specialty is always one of the best in the world. Without you, the course wouldn't be a success. Because of you, the course will be a success. It is a pity that we cannot meet personally and discuss. Particularly for young students, they need that, to see you personally and discuss one-on-one, so that that bond between the student and the teacher makes the teacher to become a role model. Unfortunately, you cannot have that. But because of the COVID, which has brought, of course, a lot of misery, but the COVID has also helped us to actually organize these courses through webinars, through Zoom. And there are several advantages. I'm just going to talk about two of them. That we can reach a much bigger audience. And the other thing is that it's more economical and accessible to all students. What do they need is just a very good connection to internet, and they can attend these courses, which was difficult before because people had to travel to pay the air ticket, to pay the hotel accommodation, and also because of the organization itself, which cost money, people had also to contribute to that. And all that has fallen, which is very good. But of course, we are missing our meetings where we can actually talk together, discuss, and share our ideas. And the most important thing is to share our friendship. I miss all of you. This course, I saw the program is very exciting. And I just ask our young colleagues to absorb everything, learn as much as possible. There is also an opportunity to ask questions. And please feel free to ask those questions. This course will be very exciting, and I know it is already a great success. I wish you all very good learning. I wish you all success, and mostly, I wish you all a fantastic webinar. Thank you very much.
Good morning, good afternoon, good evening from wherever you are. I bring you greetings from Nairobi, Kenya, in East Africa. On behalf of the Continental Association of African Neurosurgical Societies, it gives me great pleasure to endorse this superb collaboration with the ACNS. This symposium that has been arranged through the initiative and courtesy of Professor Yoko Kato and her team is testimony to the great emphasis placed by our mutual continental organizations on the importance of education of our members, and in particularly our youth and the young neurosurgeons. Given the superb galaxy of international speakers, I am certain that the coming 2 days will be undoubtedly enjoyable and enlightening. Once again, I thank the organizing committee for this valuable collaboration and offer my best wishes to this initiative. All the best.
Ladies and gentlemen, first of all, I would like to welcome all of you in this important event organized by the Asian Congress of Neurological Surgeons, the ACNS, under the patronage of the World Federation of Neurosurgical Societies, the WFNS. My name is Nasser El-Ghandour. I'm treasurer of the World Federation of Neurosurgical Societies. I'm General Secretary of the Continental Association of African Neurosurgical Societies, and I'm President of the Egyptian Society of Neurological Surgeons. Actually, I'm glad and honored that this important event is organized in collaboration with the Continental Association of African Neurosurgical Societies and with the Egyptian Society of Neurological Surgeons. I'm also glad and honored by the tremendous amount of scientific activities organized by the Asian Congress of Neurological Surgeons under the leadership of Professor Yoko Kato. I'd like to thank Professor Yoko Kato for this opportunity to have such collaboration together. I'd like also to thank all our distinguished speakers. Thanks to all of you for giving much of your time and experience and for sharing your knowledge with young neurosurgeons, especially at this difficult time of COVID-19 pandemic. I'm looking forward to have more collaboration with the Asian Congress of Neurological Surgeons, and I always believe that we have to work hard in order to strengthen the African-Asian collaboration. My best wishes to have a very successful meeting as all previous meetings organized by the Asian Congress of Neurological Surgeons. Thank you.
Today's my title is a treatment of the cerebral AVMs. So this is the typical AVM and direct surgery. And so I will show. This is the right temporal AVM, 51 years old female, associated with a large aneurysm. This is a kind of the pedicle aneurysm on the IC. The AVM located the right temporal. So now we can see already the draining vein and also the nidus, some part of the nidus. So at the beginning we check the ECG. Then we get the main feeding vessels. So then we place the temporary clip and already the reaction of the nidus flow. So followed by we decided to the dissecting the surface and also cut the main obvious feeders. So the step by step, then we remove the nidus from the normal blind tube. Just we decided to which side we need to reflect of the nidus. So the small fragile vessels should be treated, should be coagulated before we cut the final fetus. So the very precise of the parenchymal resection of the nidus is very important. This is almost the end of the surgery, but still some flow we can recognize the draining veins. Most of the cases, final feeding vessels is behind the draining veins. So we coagulated the draining vein. Then we cut the final part, the main draining vein. So this is very ordinary the resection of the nidus. So this is another case, the frontal ABM grade 2, 53 years old female. So this is the angio, and before we cut the dura, the ICG performed. Then this is for 800. Then we can draw the draining vein on the cortex for preventing of the injury of the draining vein at the beginning of the surgery. So then step by step, we cut the feeding vessels. Then we check for 800 how degrees of the flow of the ABM. So getting decrease of the intranidal the flow. So this is a step by step reduction of the nidus flow. Then we can see the onyx, which is very high visible. It's one of the advantage of the onyx. So this is the final stage. So the ABM has so many issues to be discussed. But high grade ABM and also the eloquent ABM is one of the main topics. So as for the eloquent cortex surgery, I want to share with you. So what is eloquent cortex? So those parts is eloquent lesions. So about mapping, so the currently most reliable method is direct cortical and subcortical electrical stimulation by awake craniotomy. So this is the most reliable method to detect the eloquent. So this is a schematic drawing. Is preoperative. We do the functional MRI and DTI. And also, intraoperatively, we can check the neural monitoring, so intraoperative MRI and the neural navigation and the wake direct stimulation. And the functional MRI. And this is the DTI. So DTI is based on the diffusion of protons in direction of the fibers. So this is the clinical aspect. So spectral margin rate 3-4 so-called grade AVM. So if the asymptomatic patient, the observation should be the best. The symptomatic patient, the endovascular embolization by the radiosurgery or direct surgery. So what is a high-grade silver AVM? This is a special margin grade 4-5, the large, deep, involved elegant lesions, substantial surgical morbidity, and the indication of surgery will be following the previous hemorrhage, existing permanent neurological deficit, aneurysm association, and step phenomenon, steal phenomenon, and suggest observation for the young age patient. So there are 5 modalities: endovascular and microsurgical resection, and radiosurgery observation, and also the combination treatment. So multidisciplinary approach is achieving cure of the treatment, endovascular treatment for reduction, neither size before microsurgery or radiosurgery. The open surgery, this is still gold standard of the treatment, especially small nidus. Endovascular treatment, this is the adjunct of the treatment. For surgical nidal reduction, the flow reduction is main purpose of this treatment. Radiosurgical treatment for inoperative or high grade of AVM. So this is how we can treat of the AVM with open surgery. So just we can check MRI, and this is 3D multifusion imaging, so the vein and the nidus, and also the feeding vessels. So how we can embolize these nidus. So this is one feeder, another feeder, and 3 feeders. So this is one very unexpected bleeding case during the embolization. So this is the onyx. Sometimes when we use the onyx, we should be very careful because the onyx is very slow injecting and plug and push vessel. So it's most of the case the onyx comes with a draining vein. So that is a big reason why the nidus bled. The patient had the mild hemorrhages, but it improved completely. So this is we resected the nidus immediately after the bleeding of the nidus with embolization. So high function OR is so many good devices, 800 ICG, navigation, monitoring, function MRI, tractography. Already I am shown. So this is a very perfect hybrid or the high function OR. So this is a Pro 800. So this is exactly the same phase. This is a draining vein. So it can be the orange. The orange means it's the feeder and in between the feeder and the draining veins. So we can see the intensity diagram. So draining vein can be in the middle of the feeder and the draining vein. So elegant lesion already I talked. The risk of the permanent neurological deficit is 40% for highly eloquent AVM, pre-central cortex, basal ganglia, and brainstem. The 18% for less eloquent AVM, also central cortex, occipital lobe, and dominant temporal lobe, and the corpus callosum. The 3% for non-eloquent area. So adjunct items to improve outcome of the eloquent AVM surgery is intraoperative neurophysiological monitoring and the MRI DTI, and the flameless stereotactic navigation. So the monitoring is very important when we do surgery of the eloquent or functioning cortex. So the motor mapping and speech mapping in the MEP. So these are very fundamental, the monitoring for eloquent lesions, the treatment. So this is the motor mapping. Precise detection at the cortical surface. And this is all you know, the MEPs. And also the speech mapping is important. So AVM near Wernicke area, and AVM near Broca area, and AVM near annular gyres. So as for the radiosurgery, they need more marginal dose, and also the volume staged radiosurgery is the newer strategy I will show you. It divides a large AVM into 2 or 3 smaller portions, treated at the separate stage, enabling each portion to receive a higher dose. So this is the staged nidus radiosurgery. So microsurgery is effectively to reduce the mobility as salvage technique after radiosurgery. So firstly, we give the patient the radiosurgery followed by this is one of the new techniques. So this is the first time, and in between the first second is a 3 years, and the second, third, 3-4 years. So then finally the nidus became much smaller compared from the beginning. So this is the new treatment paradigm for high-grade AVM. So the staged embolization and or staged radiosurgery and the reduction of the flow and microsurgical resection. And this is after radiosurgery downgrading the volume of the nidus and followed by the microsurgical resection. So this is a flow treatment of the high-grade AVM. So this is surgery and embolization only, and this is the single or volume stage radiosurgery. So this comes to the cure or incomplete reduction of the spectromartin grade, and followed by the surgery, and followed by the observation. So this is the microsurgery after the radiosurgery. So this is, it has a very good result. Almost disappear of the nidus. We can recognize it with this method. So cure rate is over 80%. Surgical mobility mortality rate is 18.8%. So finally, the future diagnostic and therapeutic strategies for brain AVM. So this is a molecular and cellular biology of the AVMs. So it's a congenital static lesion and the sporadic cause, the growth, remodeling, and the regression, the rupture event. The new genetic, molecular, and cellular factors have been demonstrated to be involved in the process of the formation, growth, and rupture of AVM. How can biology impact the potential future management? So risk of the AVM rupture, one is genetic mutations, intranidal aneurysm, exclusive deep venous drainage, and restrict venous outflow, and the deep or infratentorial location. So this is a schematic drawing. It's the molecular and cellular biology of the AVM. The expose of the abnormal, the high flow, plus shear stress, and smooth muscle cell and brain endothelial cell comes the proliferation and the remodeling. So this is the four cause how the AVM virus become large. So this is genetic, and this is experimental therapeutics and formation and the growth and rupture. So many factors and so many causes can AVM enlargement. So molecular and cellular biology associated with the syndromic AVMs. So we can experience about the HHT or CAMS. So AVM formation. So this is a single nucleotide polymorphism, SNPS, and also the PGF-beta. So, and also the endocrine ENG is a glycoprotein located on the cellular surface, crucial for angiogenesis. So as for the AVM growth and rupture, the role for inflammation and the extracellular matrix remodeling. Macrophage and the neutrophils tend to invade AVM tissue. So matrix metalloproteinase play a key role in the growth and rupture of several AVMs. Brain endothelial cells have a higher proliferation rate with a reduced apoptotic response to inflammatory mediators. Multiple mechanisms, including inflammation, remodeling, and VEC abnormalities, contribute to tendency to rupture. So, about AVM treatment. Kind of the treatment is open surgery and radiosurgery and endovascular treatment. But completeness is endovascular is 30%, and also the radiosurgery is about 40%. So microsurgical resection is currently recommended for spectral Pons class A or spectral Martin grade 1 or 2 AVMs. In combined treatment, spectral Pons class B or spectral Martin grade 3. The palliative treatment, spectral Pons class C or spectral Martin grade 4 and 5 AVMs. So new treatment idea is a new cellular and molecular biological therapies are under development. So aims to radiosensitization and vascular targeting and remodeling therapies. So understanding of the regulatory factors and the pathways is very important. That is, modifying the natural history away from rupture. So experimental therapy, so many drugs is appearing. So tetracyclines and doxycycline and VEGF, the focal hyperstimulation delivered by an adenovirus vector shown in the inhibition of the MMP9 messenger RNA expression. Thrombospondin 1 is another important drug. So this anti-angiogenetic therapy, thrombospondin 1, and also the VEGF-A antagonist, bevacizumab, is a very popular one. So this is pictures how the AVM has a rupture. So in brain AVM, there is a hyperproliferation of the endothelial cells, green, and the focal area of the vascular smooth muscle cell, the blue, the proliferation and the degeneration are also noted. The thinning of the basement membrane, pale yellow, and the vascular smooth muscle cell degeneration and contribute to the destabilization of the vascular wall. So this can be happen as a rupture of the AVM. So in conclusion, in understanding the complex cellular biology, physiology, hemodynamics, and flow-related phenomena of AVMs is critical for defining and predicting their behavior, developing novel drug treatments, and improving the endovascular and surgical techniques. So, of course, for the moment, the main treatment, the tree is 3 categories, but we should think about the very basic research for preventing the increasing of the AVM virus itself. Offers conservative observation for younger patients with ruptured high-grade AVMs and long life expectancy. Once there is a rupture or high risk of rupture, the surgical mobility associated with the downgraded AVMs is reduced to that of post-radio surgical preoperative supplemented testosterone increase. So sometimes we think about the radiosurgery, especially the large or the diffuse type of the nidus. You can give the radiosurgery in Dubai, especially in between the 2-3 years. That is one of the options for such a very difficult type of the AVM. Thank you for your listening.
Hello dear friends of Zimbabwe and Congo. I'm Kazumichi Yoshida from Kyoto, Japan. First, I'd like to show my deep appreciation for Professor Karangu and Kato to give me an opportunity to present my work in this ACNS webinar. I graduated from Kyoto University Medical School in 1994, then started neurosurgical residency. Since 2020, I'm an associate professor. This is the clock tower of Kyoto University, and they are the members of Kyoto University neurosurgical team. Now Tokyo is the capital of Japan, but Kyoto is a former capital of 1,000 years from 794 to 1868. In spring, there are beautiful cherry blossoms along the walkside near the Kyoto University Hospital. This photo shows one of the major summer festivals in Japan. And this is an old temple with beautiful colored leaves in autumn. Kyoto City is covered with snow in winter. Anyway, I'm looking forward to having a chance to welcome you, friends in Zimbabwe and Congo in future after this COVID-19 pandemic. I was requested to give message to my friends, young neurosurgeons in Africa. So I think to become a good neurosurgeon, training for surgical skills and study for surgical anatomy are surely essential. But I think most important point is attitude to your work or your profession. Please always treat your patient as if they were your family. Thank you. So start my presentation. Today, I'd like to talk about carotid endarterectomy CEA technique aiming for zero ischemic complication. First, I will talk about brief history and current guidelines of CEA for carotid artery stenosis. Then, I will show basic procedure for CEA. And finally, I will demonstrate tips of CEA for zero ischemic complication. CEA is a long-established vascular surgery, and this slide shows the first case report by Professor Dovecki, famous vascular surgeon of Baylor College of Medicine in the United States. This case report was published after a 19-year follow-up of no recurrent ischemic stroke due to the left carotid artery stenosis. Then, what patients receive benefits from CEA? Let's see current consensus of indication for CEA. This slide shows the guideline for managing patients with symptomatic carotid artery stenosis, published in 2018 by European Society of Vascular Surgery. CEA is recommended for symptomatic high-grade stenosis. However, perioperative complication rate should be below 6%. And also, CEA should be considered in patients with symptomatic moderate stenosis. Next, let's see the guideline for asymptomatic carotid artery stenosis. The indication of CEA is somewhat different between symptomatic patients and asymptomatic patients because medical treatment for asymptomatic patients have been strikingly improved in the recent 20 years. Therefore, the guideline says indication of CEA for asymptomatic patients should be considered carefully. So, for asymptomatic patients, CEA should be considered if patients not only have moderate to high-grade stenosis, but also have imaging characteristics suggesting high risk for future ischemic stroke. Imaging features suggesting high risk for future ischemic stroke include CT or MRI detected in ipsilateral silent infarction, ultrasound detected stenosis progression, large plaque volume, predominantly echolucent plaques, and MRI detected intraplaque hemorrhage, and so on. I'd like to move on to the next topic. I illustrate basic procedure for CEA in the following slides. Not only CEA, but in all surgeries, securing shallow and wide operative field is a basic point for safe procedure. The skin incision for CEA is demonstrated in the left figure. The dashed line is recommended in the many traditional textbooks for CEA. I prefer solid lines because it is easy to dissect between parotid gland and sternocleidomastoid muscle, SCM. To gain wide operative field, I think it is most important to dissect the SCM along the anterior margin over the entire length of the skin incision in the early stage of CEA. In dissection from the proximal part of the SCM along the anterior margin to the distal portion, pay attention not to cut into parotid gland and dissect precisely between parotid gland and SCM. This is the case with right side carotid artery stenosis. This is SCM, and this is a greater occipital nerve. This is parotid gland. White vessel tape is pulling up the common carotid artery, the yellow vessel tape, external carotid artery. The two-stage lifting method is very useful to gain a shallow and wide operative field. Two-stage lifting method consists of, first, tie between carotid cyst and the skin with surgical sutures. And second, pull up the skin with a surgical retractor. Then carotid artery is lifted and it makes easier for the following CEA procedure. From skin incision to securing of carotid arteries, I perform CEA macroscopically and use the operative microscope for the following steps. I'd like to show macroscopic procedure from skin incision to carotid artery exposure with operative video for left carotid artery stenosis. Approximately 10 cm long skin incision is made. And now cutting platysma muscle with electronic cautery knife. Now you can see sternocleidomastoid muscle SCM. It is very important to dissect SCM along the anterior border over the entire length of skin incision. The greater occipital nerve is dissected to avoid postoperative sensory loss of the auricle of ear. This is parotid gland and this is distal part of SCM. Parotid gland and SCM is also carefully dissected with electronic cautery knife. Then open the proximal part of carotid sheath. And tie carotid sheath and skin with surgical sutures for preparation for two-stage lifting method. This is external carotid arteries. After securing the carotid arteries, the following procedure is performed with operative microscope. This is microscopic procedure. To avoid carotid sinus reflux, infiltration anesthesia with xylocaine is used. And now dissecting the carotid sheath over the distal internal carotid artery. This is internal carotid artery. This is common carotid artery. This is superior thyroid artery. And this is external carotid artery. Also, carotid sheath of ICA, internal carotid artery, and skin is tied with surgical sutures. Finally, now securing the distal internal carotid artery. And the cross clamping is completed. Now you can see the two-stage lifting method is useful to gain a wide operative field. And now cutting the vessel wall and dissect vessel wall and the plaque. Carefully dissected between the plaque and the vessel wall, not to injure the vessel wall itself. And now removing the plaque. The stamp of the plaque is as far and also as neatly as possible. Primary closure of the carotid artery is completed by running sutures from the both sides. And first, the creep of the superior thyroid artery is released, and each cramp is transiently released to wash out possible debris to superior thyroid artery. Finally, ICG video angiography is performed to confirm the good patency. When removing the plaque, the ideal dissection plane is between plaque and media, but part of the plaque often embedded into the media itself. So, in the dissection of the plaque, the point is to keep in mind that media with circular fibers should be preserved in the vessel wall as far as possible. I'd like to demonstrate again the ideal dissecting plane with successive intraplaque pictures. This is the circular fibers of media. When you wonder where to dissect, you should preserve these circular fibers to vessel wall. The stump of the plaque is sharply cut with micro scissors. It is especially important for distal plaque end in the internal carotid artery to avoid post-operative thrombotic complication. Slight difference in the level on the lumen can be eliminated by weak bipolar cautery. If you dissect the plaque in the ideal plane, the plaque is removed with a smooth transition like upper pictures. However, when you go deeply into media, like lower pictures, you will leave somewhat large difference in the level on the lumen. After primary closure of the carotid artery, the following procedure is macroscopically performed. Now closing carotid cyst with absorbable surgical sutures. Then suture the sternocleidomastoid mastoid muscle. And now suturing together the divided platysma muscle. And finally, doing a subcutaneous suture with absorbable surgical sutures. So this is a final view of left carotid endarterectomy. This is a picture obtained 6 months after the surgery, and you can see the obscure skin incision. I'd like to move on to the final topic, surgical tips for zero ischemic complication. The benefit of CEA for carotid artery stenosis has been widely proven by several major clinical trials, but the absolute benefit of CEA is limited by the morbidity and mortality. One of the leading causes of complications is ischemic stroke during CEA. Major causes of ischemic stroke are hypoperfusion during cross-cramping and embolic infarction during surgical procedure. Hypoperfusion in patients with insufficient intracranial collateral circulation can be dealt with by using shunting. Concerning measures against embolism during CA, it is often emphasized that meticulous surgical dissection is very important, but there have been few papers describing concrete risk reduction measures against embolism. Before presenting my thoughts regarding surgical tips against distal embolization, what step during CA carries the highest risk for distal embolization, or when should we take great care for prevention of embolism during CA? Studies of transcranial Doppler monitoring during CA offer valuable insight into this question. Wolf reported that the rate of microembolic signal at each step during CA was 97% during the cramping, 69.7% with shunting, and 45.5% with surgical dissection of the internal carotid artery. But significant correlation between microembolic signal and postoperative diffusion-weighted image regions was found only with dissection. So he described the step of surgical dissection of the internal carotid artery as the most vulnerable stage of CEA. Based on the report about transcranial Doppler monitoring, I thought that early flow control of the carotid artery will be effective for prevention of embolization during internal carotid artery dissection. This slide shows the surgical procedure of conventional CEA and so-called flow control CEA. This gray shaded area illustrates the carotid sheath. In conventional CEA, cross-clamping is established after entire carotid sheath covering common carotid artery, external carotid artery, and internal carotid artery is dissected. On the other hand, in flow control CA technique, proximal common carotid artery, superior thyroid artery, and external carotid artery are carefully dissected then clamped. Special attention is paid not to extend surgical dissection over the internal carotid artery at this stage to avoid great stress on the internal carotid artery enclosing fragile plaque. Then exposure and isolation of distal internal carotid artery was completed under flow control by proximal vessel clamping. This picture shows the setup of CEA for left internal carotid artery stenosis. I use an internal shunt selectively depending on the intraoperative dual monitoring of near-infrared spectroscopy and somatosensory evoked potentials. I'd like to show flow control CA with operative video. First, superior thyroid artery is clamped. Then common carotid artery is clamped. And this is external carotid artery. After flow control by proximal vessel clamping is established, then start internal carotid artery dissection. And now the cross clamping is completed. This is another case of flow control CA with an internal shunt. Now proximal vessel clamp is completed, then start the dissection of the internal carotid artery. During IC dissection, the amplitude of somatosensory evoked potential monitoring reduced to 30% of the control level. Then I decide to use an internal shunt at this point. Now cross-clamping is completed. Then small incision is made on proximal common carotid artery and distal internal carotid artery. And now introducing an internal shunt. Then blood flow in the internal shunt is confirmed by ICG video angiography. Study for post-operative new infarct of my consecutive 67 CEAs, consisting of 29 conventional CEAs and 38 flow control CEAs. There was no symptomatic infarct, and asymptomatic diffusion-weighted image regions were found 7 of 67 CEAs, approximately 10%. As shown in this figure, most of the asymptomatic DWI regions were small high-intensity spots in the ipsilateral hemisphere. Post-operative DWI positive rate in patients with conventional and flow control CA was 20.7% and 2.6% respectively. These results apparently show the benefit of flow control CA against intraoperative embolization. Today, I presented 3 topics for CA. First, the brief history and the current guidelines for CA, and I showed basic procedure for CA. And finally, I demonstrated surgical tips aiming to zero ischemic complication, that is, flow control CA. This is a garden in an old temple in Kyoto City in this season. I hope this chaotic situation by COVID-19 pandemic will end as soon as possible, and I'm looking forward to talking with you African friends in person in near future. Thank you for your attention.
There are many crucial steps for successful clipping surgery for cerebral aneurysm, from preoperative planning by imaging studies to cranioplasty and skin closure. Because of the time constraints, I would like to focus on these steps this time. Number 9. Complete exposure of the aneurysm by detaching adhesions between aneurysm and surrounding structures. Number 10. Appropriate selection of clips for each aneurysm. And number 11, precise clip application to the optimal closure line for each aneurysm. If you have this situation, clip application to the neck of the aneurysm is a straightforward procedure, but it is supposed to be a rare case. Dome of cranial aneurysm adhere to the surrounding structures, including dura mater, cranial nerves, and normal vessels, especially in large or giant aneurysm. For appropriate clip application and avoiding branch stenosis or nerve dysfunction by tension, these adhesions should be detached in many cases if possible. Professor Hadeishi reported how to detach the fibrous adhesion. They are consist of 3 steps. First, dissect the loose adhesion in the center using jeweler's forceps to make space. Second, pinch the tight adhesion at the margin of emboss, the fibrous adhesion. Finally, sharply inside the embossed adhesion with micro scissors. Detaching the adhesion between nerve and aneurysm is also possible by this technique. I will share with you the techniques using my video afterwards. Each aneurysm has an orifice from its parent artery. Clipping of aneurysm is aimed to obliterating the three-dimensional orifice of the aneurysm and recreating a curved or straight line with the base of the aneurysm clip. We call the line ideal or optimal closure line. Professor Ishikawa classified the ideal closure line of MCA aneurysm into three groups: the bifurcation type, the truncal type, and the combined type. The bifurcation type is the most common type in MCA aneurysm. This type originated from the curved linear cleft at the bifurcation of the arteries, with an orifice forming a deeply curved rhombus. In this case, we should apply aneurysm clips in perpendicular fashion to the arteries. Of course, one clip is enough in some cases. The second type is truncal type. This type appears to originate from loss of tunica elastica on one of the afferent arteries, with an orifice forming the flat rhombus on the parent artery. In this case, we should apply aneurysm clip in parallel fashion to the arteries. Of course, one clip is enough in many cases. The third type is the combined type. In this type, the growth of the aneurysm destroys the tunica elastica of the continuous vessels with a subsequent enlargement, with an orifice forming a curved trapezoid. In this case, we should apply clips in cross fashion. We must know the aneurysm clipping closing forces. The most important component of aneurysm clip selection is subjective preference, though objective decisions based on the closing force may be relevant. Professor Hongo reported the closing forces of all of tested clips linearly increased from tip to base of the clip brace. So you should know that an incomplete closure of the first side neck would happen when you use a long clip for a large aneurysm. And you should know not straight clips are weaker than straight clips. We must know those characteristics of each clips and use appropriately considering the closing forces. Clipping for recurrent aneurysm after initial endovascular coembolization is technically challenging. Dissecting and clipping of small aneurysm with sufficiently large neck remnant is a straightforward procedure. On the other hand, in larger aneurysm, the fundus is thrombosed and mechanically enforced by the coil mass and sclerotic wall, rendering manipulation and exploration more difficult. Like case above, despite angiographically sizable neck remnants, collapsing the aneurysm wall at the neck and clip application can be very difficult. Previously coiled aneurysm are difficult to clip, partly because coil loops and mass inside can prevent the clip brace from complete closing. There must be a residual flow in the aneurysm after a single clip is applied. because of inadequate closure of the far side neck by the obstacles. Hence, a tandem clipping method using a fenestrated clip in combination with another type of clips is a useful technique for complete closure. The former can be applied for closure of the far side neck, the latter for the near side. When you apply an aneurysm clip to the neck, you should make a fine adjustment for appropriate application to its optimal closure line. Professor Takanori Fukushima introduced the 5D application technique of the aneurysm clip for me. In this case, D does not mean dimension, but direction. First, you go with clip in and out. Second, left and right. Third, up and down, including blade tip up and blade tip down. And clockwise and counterclockwise rotation around the clip axis. And around the neck of the aneurysm, we should do a fine adjustment with this 5D application using adequate time. I usually spend for 3 minutes or on average for each clip application. Here is a case study. A 57-year-old woman presented with unruptured right MCA aneurysm. Her preoperative CT angiography and intraoperative finding revealed the aneurysm type is a bifurcation type. The first straight standard clip was applied in perpendicular fashion to the parent artery. This results in dog-ear residual neck. Therefore, a second clip was placed under the primary clip. The post-operative imaging studies revealed complete obliteration of the aneurysm and no complication. Here is another case. A 66-year-old woman presented with unruptured right MCA aneurysm. Her preoperative CT angiography and intraoperative finding revealed the aneurysm type, the truncal type. The first standard curved clip was applied in parallel fashion to the afferent artery. In this case, one clip was good enough for complete closure of the neck. The post-operative imaging studies revealed complete obliteration of the aneurysm and no complication. A 65-year-old woman was diagnosed with unruptured ACOM aneurysm. Her preoperative CT angiography and intraoperative finding revealed that the aneurysm originated from right A1-A2 junction. You see hypothalamic artery branching from right posterior of the neck of the aneurysm. The first lateral angle clip was applied in perpendicular fashion to the A1-A2 junction. Visual inspection revealed small residual neck in posterior part, so I performed a fine adjustment using 5D application method. This results in dog-ear residual neck in anterior aspect. Therefore, A second L-shaped clip was applied under the primary clip, result in complete closure of the neck. The post-operative imaging studies revealed complete obliteration of the aneurysm and no complication. This 55-year-old man was diagnosed with ruptured aortic aneurysm. Because his preoperative CT angiography revealed the aneurysm relatively high-positioned one, so we selected anterior interhemispheric approach in this case. You see the hypothalamic artery branching from left side of the neck of the aneurysm, and careful inspection revealed the tight and fibrous adhesion was located between the dome and the perforator. First, we dissect and pinch the fibrous adhesion in the center with microforceps in order to emboss the adhesion and the temporary occlusion of right A1. Then, the embossed adhesion was inserted sharply with microscissors. The first standard straight clip was applied in perpendicular fashion to the right A1-A2 junction. This results in dog-ear residual neck. Therefore, a second angled mini clip was placed under the primary clip, resulted in complete closure of the neck. The post-operative imaging studies revealed complete obliteration of the aneurysm and no complication. A 52-year-old woman presented with unruptured left ICP-com aneurysm. Intraoperative finding revealed the tight adhesion between the dome and the left free edge of the tentorium. Under proximal control of the left ICA, the tight adhesion was dissected by using incising the tentorium side along the edge. The dome was freed from the free edge of the tentorium. Using the micro scissors, after the procedure, the straight standard clip was applied in parallel fashion to the P-com. The post-operative imaging studies revealed complete obliteration of the aneurysm and no complication. A 61-year-old woman presented with unruptured left ICP-com aneurysm. Intraoperative finding revealed that the head of the aneurysm dome moderately compressed the right oculomotor nerve. The dome was carefully detached from the oculomotor nerve by sharp dissection using micro scissors, and the valve was detached by blunt dissection. After the procedure, a standard straight clip was applied in parallel fashion to the P-com. Her post-operative course was uneventful, without oculomotor nerve palsy. The post-operative imaging studies revealed complete obliteration of the aneurysm and no complication. A 70-year-old woman presented with unruptured left BASCA aneurysm. We decided subtemporal approach in this case. We made a stitch between free edge of the tentorium and middle fossa dura. This procedure enabled us to gain a good surgical corridor to the basilar artery for proximal control. The dome was carefully detached from right oculomotor nerve by blunt dissection with microprobe and microforceps. Under temporary occlusion of the basilar artery, the adhesion between dome and perforator was carefully detached. First, we dissect and pinch the fibrous adhesion in the center with microforceps in order to emboss the adhesion. Then the embossed adhesion was incised sharply with micro scissors. After the procedure, the bayonet clip was applied in parallel fashion to the afferent artery. The visual inspection revealed a complete closure of the aneurysm with preservation of perforators and the afferent arteries. She experienced temporary oculomotor palsy, but recovered completely. The post-operative studies revealed complete obliteration of the aneurysm without complication. A 52-year-old woman presented with unruptured left BASCA aneurysm. We decided subtemporal approach in this case as well. The first light curved clip was applied in perpendicular fashion to the afferent artery. And this results in a dog ear residual neck in the posterior aspect. Therefore, a fenestrated right angle clip was placed across the primary clip. Visual inspection revealed small residual neck, so I performed fine adjustment. And this resulted in complete closure of the neck and preservation of perforators and the afferent arteries. Her post-operative course was uneventful without oculomotor nerve palsy. This case has recurrent right PCOM aneurysm after initial coil embolization. Coil mass inside the aneurysm was seen through not only the wall of the dome, but the wall of the neck. First, we applied straight type titanium clip, but the tip of this clip slipped toward to the PCOM, so we removed this clip. Then we applied fenestrated illusory creep in partial occlusion of the neck. ICG video angiography revealed the patency of ICA, PCOM, and anterior choroidal artery, and no filling of the aneurysm dome. We added straight creep in parallel fashion to secure the complete obliteration of the aneurysm. A 48-year-old female was brought to our emergency department with disturbance of consciousness. The computed tomography revealed a diffuse subocular hemorrhage lateralized to left sylvian fissure. The CT angiography showed left anterior wall C2 aneurysm. The patient was diagnosed with ruptured left C2 blister aneurysm. Nowadays, we treat this kind of patient by ECM2 bypass using radial artery graft followed by trapping of the aneurysm, though we decided direct clipping in this case. We thought the clip-on wrapping method would work because the aneurysm projected anteriorly and laterally. We exposed the aneurysm completely and we put Teflon tape around the ICA. And we applied L-shaped clip to the aneurysm together with the Teflon tape which avoids slipping out of the clip and blowing away the blister aneurysm. The Doppler revealed the good preservation of antegrade flow of the ICA. Her post-operative course was uneventful, without symptomatic vasospasm. The post-operative imaging studies revealed the complete obliteration of the aneurysm and no complication. A 62-year-old male presented with our emergency room with right hem paralysis. The diffusion-weighted image revealed a lacunar infarction on left paramedian pons. The MR angiography showed partially thrombosed fusiform basilar trunk aneurysm. We decided to follow up by starting antiplatelet therapy. 3 days after admission, he suddenly fell into coma, and CT at that time showed subarachnoid hemorrhage, which was especially thick in right prepontine cistern. We performed bilateral ventricular drainage as neuroresuscitation. His conscious level gradually recovered. Cerebral angiography at that time revealed fusiform basilar trunk aneurysm, which had a bleb on right superior aspect. So we determined from the imaging studies that subarachnoid hemorrhage was caused by the rupture of the bleb of the aneurysm. We decided to perform direct clipping surgery through anterior petrosal approach aimed to avoiding re-rupture of the aneurysm. We performed drilling right petrous apex, the rhomboid. We exposed the aneurysm right ICA, proximal basilar artery, right SCA, and distal basilar artery. After the temporary occlusion of the basilar artery, we applied the long straight clip in parallel fashion to the basilar artery and occluded the rupture point. And then we applied the fenestrated straight clip parallel to the first clip in order to enforcement of closing force at far side of the closure line. At last, we applied the straight clip in parallel fashion to the previous clip for reinforcement of the closure at the near side. This resulted in occlusion of the rupture point and preservation of parent artery and branches, including important perforators. His post-operative course was uneventful without symptomatic vasospasm. The post-operative imaging studies revealed complete obliteration of the rupture point and no additional complication. As I mentioned at the beginning of my talk, there are many crucial steps for successful clipping surgery for cerebral aneurysm. Today, I presented the steps just around the aneurysm, how to expose the aneurysm completely, appropriate selection of clips, and concept of optimal closure line. I'll be glad if this presentation is of help to anyone. Thank you for your attention.
Hello everyone, my name is Yasushi Takagi from Tokushima University, Tokushima. Kyoto University, and 2017 I moved from Kyoto University to Tokushima University. Tokushima is located in Shikoku Island. Shikoku means 4 districts. Tokushima City is located near Kansai district. This is the landscape of Tokushima. Tokushima City is famous for Bizan Mountain, and summer festival. Our Odori Dance Festival is very famous Japanese summer festivals. In the suburb of Tokushima, Naruto City is famous for fire pools. On the mountainside district, Oboke Valley is very beautiful place. Tokushima is originally famous for Japanese indigo around 100 years ago. So I want to move to my topic. This is a schema of pathology of AVMs. See, this is superficial drainer, and this vessel superficial feeder, and around the needle parallel feeder, and this vessel mean deep drainer. This is historical milestones in the treatment of AVMs. Preoperative embolization is developed from 1950s, and microsurgery developed firstly on 1960s. Stereotactic radiosurgery is started on 1960s. We now using these modalities to treat AVMs. So this is a pathological aspect of surgical treatment for AVMs. See, this is the normal brain. Here is a drainer of the nidus. So we have to dissect these brains, AVMs from brain tissue. Thus, minimum neural injury is required. This yellow line is ideal dissection line. Based on HA scientific statement, surgical indication is described here. The discussion of treatment options with patients should include consideration of these risks weighted carefully against relative risk of different intervention strategies and life expectancy. I think the surgical concept of AVM, that dissection and removal of a very hemorrhagic vascular lesion from normal vascular component using gliotic brain tissue with minimum normal neural injury. We think important points during surgery is one is control of hemorrhage and the other is protection of eloquent area. So we want to focus on pre- and intraoperative imaging assistance in the surgical treatment of AVMs. We use three-dimensional analysis software to assess the three-dimensional component of AVMs. We now use Synapse Vincent softwares. This is a 3D fusion image using Amira software. Using this software, we can make these images from 3D DSA and MRI. So, based on these images, we can realize relationship of hidden nidus. This is a 3D fusion image. preoperatively, we can recognize 3D relationship, feeder, nidus, and drainers. So, using these modalities, we think important points is that location of feeders entering points in the nidus and extent of nidus in the white matter. We usually use preoperative embolization before or nidus removal. We perform preoperative embolization 1 day before direct surgery. We request interventional radiologist to deep feeder should be embolized, and then protection of eloquent areas. About craniotomy, a large craniotomy is necessary because of during surgeries often occurs brain edema, and we have to dissect or define the area of nidus, so large craniotomy is necessary. During surgeries, we prepare non-stick bipolar coagulator. We think secure coagulation of tiny feeders like this in white matter is very important during FBM surgeries. In addition, intraoperative blood flow assessment is important. ICG video angiography, portable DSA. Now we can use hybrid operation room. ICG video angiography using Kinebo microscope. Using these modalities, we can recognize reduced blood flow in the nidus and drainer. Using ICG, intraoperative angiography can confirm complete nidus removal in the deep white matter and ceased blood flow of drainer. This is the steps of FBM surgery. We can seize FBM nidus. Firstly, we dissect arachnoid and confirm drainer and feeder. Firstly, we clip superficial feeders to reduce blood flow in the nidus. Then we confirm using ICG video angiography nidus flow. Then we start to dissect the superior part of the nidus. This is the nidus dissection. And finally, we coagulate drainers. We remove the nidus. So, based on operative findings, we can decide the extent of dissections. In this figure about compact nidus, we can easily set the extent of dissection. But this FEM have diffuse part. We can set the extent of dissection or based on angiography and operative findings. We published several papers about usefulness of ICG video angiography. This paper we published in Neurosurgery Journal 2012 about IV ICG. This is about IA ICG published in Journal of Neurosurgery on 2020. Using IA ICG, we can get several time point of ICG image because of early washout. This is a video of IV ICG. If the nidus is buried in the brain parenchyma, we can assess nidus blood flow or confirming flow speed of drainer here. This image is about transarterial ICG video angiography. From CCA, we can see the feeders from CCA. From VA transarterial ICG video angiography, we can see the feeders from VA. Then we introduce illustrated cases. Case 1, 43 years old unruptured cases. This case is grade 2, non-eloquent or 3 to 6 centimeter of nidus. Firstly, we confirm the nidus flow based on IA ICG. Firstly, we coagulate feeders to reduce the nidus flow of FEMs. Then we started to dissection of nidus. One drainer was coagulated to remove the nidus. Fragile feeders during surgery using IAICG to confirm reduction of nidus flow. We continue to dissect nidus. Almost sees the flow in the nidus. Finally, we removed the nidus without major hemorrhage complications. No flow in the nidus. Case 2 is 19 years old unruptured cases. This is grade 2 AVM. The video of IAHGs of these cases. Nidus flow is gradually slowed and cease during surgeries. This is operative video. Firstly, we clip feeders to reduce blood flow in the nidus. Confirm the nidus flow based on ICG video angiography. Then we started dissection of the nidus. No flow in the nidus. Then we can remove nidus without hemorrhagic complications. Case 3 is 23 years old ruptured case. This is grade 4 AVM. This is operative video. Firstly, we confirm the nidus flow based on ICG video angiography. And we coagulated several feeders to reduce blood flow in the nidus.
Allô? Ok. Tu es en ligne là, j'imagine. Hein?
Then we start to dissect nidus.
Ah, d'accord, ok. C'est très intéressant là. Hein? Ok. Écoute, je te laisse suivre ça.
Ok, merci. Votre micro est ouvert là, par là.
Oui, mon micro est ouvert. Attends, je vais. Oui, c'est vrai, tu as raison.
See, this tiny feeder hematoma cavity was opened. Finally, we clip main drainers and coagulate. Case 4 is 13 years old ruptured cases, grade 3 AVMs. Firstly, we confirmed nidus blood flow or using ICG video angiography. This is the nidus of AVMs. Decreased blood flow in the nidus was confirmed. Finally, main drainer was clipped and removed the nidus. So this is my take-home message. In the surgical treatment of AVMs, control of hemorrhage and protection of eloquent area are essentials. Assessment of blood flow in the nidus and understanding of three-dimensional construction of nidus help us to perform safe surgeries. Thank you for your attention.
My name is Kojiro Wada from National Defense Medical College, Japan. I'm talking about moyamoya disease. It's very popular in Japan and Asian people, and it's bypass surgery today. Moyamoya disease is a cerebrovascular disease in which the carotid artery in the skull becomes blocked or narrowed, reducing blood flow to the brain. Tiny blood vessels then developed at the base of the brain in an attempt to supply the brain with blood. The condition may cause a transient ischemic attack, stroke, or bleeding in the brain. It can also affect how well the brain functions and cause cognitive and developmental delays or disability. Moyamoya disease most commonly affects children, but adults may have the condition. Moyamoya disease is found all over the world, but it's more common in East Asian countries, especially Korea, Japan, and China. This may possibly be due to certain genetic factors in those populations. Moyamoya disease is characterized by diagnostic angiography showing progressive stenosis and/or occlusion in the terminus portion of the intracranial intercarotid artery and development of a network of anastomosic collaterals at the base of the brain. Moyamoya disease was named after the pathognomonic appearance of the angiographic findings. Moyamoya disease occurs at an incidence of 0.54 people per 100,000 population in Japan. The disease is more common in female. The male-female ratio reported 1 to 1.8. As genetic factor, RNF213 or GCCY1A3 are reported. Familial moyamoya disease reported 10%. A bimodal peak consisting of a major peak in the first decade of life and a moderate peak in the late 20s to 30s. In children, ischemic type is more
なんか
popular than
点が出て
hemorrhagic
ない。
type. Different symptoms in adults and children.
ノット
In
ついて出て
children,
きてるよ。パワ
the
ーポイントが。
first symptom is
すべて
usually a
の会議
stroke
とかに
or
ノットつい
recurrent
て見
transient
てる人
ischemic
が
attack,
見えないって言ってきてる。
accompanying signs and symptoms of
スライドが見えないって言ってきてます。ダメダメ、これじゃダメ。
My name is Kojiro Wada from National Defense Medical College, Japan. I'm talking about moyamoya disease. It's very popular in Japan.
Finger place in the center with the mute button effect.
Hello, Professor, can you unshare your screen? Professor Wada, can you unshare your screen?
Side, which was symptomatic, was performed.
青木さん、画面は今やっとなんか出たんだけど、なんかグレーのが入って、こういうの
using 10-0 nylon thread. Five to 6 stitches are sutured between stay suture in one side. Then, opposite side also sutured as the same manner. After sutured, clip was removed. Indocyanin green videography confirmed the patency of the bypass vessel. Then, incised left front temporal dura was anastomosed to the galea with parietal branch of superficial temporal artery. Another frontal craniotomy was performed. The frontal dura was cut as box shape and inserted frontally. The dural defect was anastomosed with periosteum of frontal bone. After second operation, consciousness disturbance has not occurred since the surgery, but the patient is still experiencing the left hand weakness for a few seconds about once a month. MR angiography shows moya-moya stage progression, but more prominent old moya-moya from superficial temporal artery, and MRI does not show any new ischemic lesions. The second case, 5-year female patient referred to our hospital with transient weakness of the left hand while playing the harmonica. Figure A, MRI flare image shows many floboid signs at both basal ganglia. And figure B, MRI flare image shows IV signs in the right hemisphere. Right carotid digital subtraction angiography shows disappearance of the right middle and anterior cerebral arteries and thick and distinct moya-moya vessels. Angiographic findings suggest right-side Suzuki stage is 3. Left carotid angiography shows disappearance of the left middle cerebral artery and thick and distinct moya-moya vessels. Angiographic findings suggest left side stage is Suzuki 3. The right side was considered to be more advanced in stage than the left side. IMP single photon emission CT shows widespread hypoperfusion of the right cerebral hemisphere. First operation was performed both direct and indirect bypass. First, superficial temporal artery to middle cerebral artery anastomosis is performed. Then, Galea with parietal branch of superficial temporal artery anastomosed to the dura. At the frontal bone, another craniotomy was performed, and the dura was inserted to the frontal lobe surface, and the periosteum was anastomosed to the frontal dura. 3 months after first operation, right carotid digital subtraction angiography shows transdural indirect and direct anastomosis from superficial temporal artery and developed. And the number of basal moya-moya, including choroidal moya-moya, is decreased. Lateral view shows bold moya-moya of frontal portion is developed. Angiographic findings suggest right side Suzuki stage is 3, same as preoperative stage. Left carotid angiography shows disappearance of the left middle cerebral artery and thick and distinct moya-moya vessels. Angiographic findings suggest left side stage is still 3, same as preoperative stage. Second operation of left side was performed. Left frontal branch of superficial temporal artery was harvested from the skin and anastomosed to the M4 portion of left middle cerebral artery. The tip of the donor vessel is formed into a fish mouth shape. The tip of the donor vessel marked with a skin marker pen. Frontal dura is cut, arachnoid is cut, and find recipient artery of M4 of middle cerebral artery. Place a rubber seat under the recipient vessel. Mark the recipient vessel with a skin marker pen. Stage sutures are placed on both sides using 10-0 nylon thread. 5 to 6 stitches are sutured between stage suture in one side. Then another side also sutured as same manner. After direct bypass surgery, Doppler ultrasonography, also indocyanine green videography, confirmed the patency of the bypass vessel. Then, inside the left front temporal dura was anastomosed to the galea with parietal branch of superficial temporal artery. Another frontal craniotomy was performed. The frontal dura was cut and anastomosed with periosteum of frontal bone. The patient no longer suffered transient ischemic attack after the bypass surgery. She has been able to go on to regular elementary school and keep up with her studies. The IV sign of flare on postoperative MRI disappeared after 2 years, and there was no new cerebral infarction on MRI after 4 years. Thank you very much for your attention.
It's a good commission, right? Wanafanya hivyo. So,
Hello everyone. My name is Yoshitaka Narita from National Cancer Center in Japan. Today, I will talk about awake surgery for gliomas. Prognostic factors of glioblastoma is age, KPS, neurological function, extent of resection, and as biomarker, MGMT promoter methylation status and IDH1-2 mutation is very important. The first step of the treatment of glioma is maximal safe resection. The gold standard therapy for glioblastoma is still maximal safe resection with radiation therapy with temozolomide. This is a case of thalamic glioma. After emerging temozolomide, some patients with glioblastoma have complete response by radiation therapy with temozolomide. MGMT promoter methylation is the most important favorable biomarkers in glioblastoma. Patients with MGMT promoter methylation is approximately 30 to 40%, and patients with IDH1-2 mutation is less than 10%. As shown in figures, GBM with MGMT promoter methylation have a longer survival than patients with MGMT promoter unmethylation status. Similarly, glioblastoma patients with IDH1-2 mutation have a longer survival. This is a result of AVAGLIO study. This study proved that treatment with bevacizumab prolonged independent time in patients with glioblastoma. This is our treatment strategy of glioblastomas regarding to chemoradiotherapy. After maximal safe resection, the patient with a KPS 80 or greater has radiotherapy with temozolomide, and the patient with a KPS 70 or less has a radiotherapy with temozolomide together with bevacizumab to maintain performance status. This is a classification depending on KPS and MGMT promoter methylation status. Half of patients have a KPS 70 or less. Generally, 30% of patients have MGMT promoter methylation. Finally, only 50% of patients of glioblastoma have favorable prognostic factors with high KPS and MGMT promoter methylation. Actually, 5-year overall survival rate of glioblastoma in temozolomide era in Japan is 16%. Gross total resection is possible in 50 to 60% of glioblastoma patients by intraoperative monitoring, awake surgery, and intraoperative MRI. Actually, from brain tumor registry of Japan, approximately 20% of patients underwent gross total resection, and 40% of patients had resection more than 95%. To achieve maximal safe resection, dissection of tumor, neuronavigation, intraoperative monitoring, awake surgery, and intraoperative MRI are important. (5-ALA) is important for resection of gliomas. 5-ALA is converted into PP9 and the tumor shines red by laser. Resection by 5-ALA prolongs progression-free survival in glioblastoma. Intraoperative MRI is always used for resection of tumors. About 30% of patients had more resection of tumors after first intraoperative MRI. This case is a patient with left frontal oligodendroglioma. After resection of tumor under awake surgery, intraoperative MRI showed a small residual tumor, and then we removed the tumor completely. This paper shows the survival of patients with low-grade glioma, glioblastoma, and brain metastasis. Improvement of extent of resection by awake craniotomy prolongs survival of the patients than under general anesthesia. I will talk about the techniques of awake surgery. Regarding to indication of awake surgery, the tumor location is dominant hemisphere and a motor area. Importantly, a patient's language function is normal. The patient can participate in awake surgery without fear. The patient's function can be assessed correctly by required tasks. Surgeons must understand the anatomical language network in the brain. There are two important streams. As dorsal stream, SLF and arcade fasciculus are very important in phonological processing. As ventral stream, MDLF, ILF, IFOF are important in semantic processing. Frontal afferent tract is important in driving of speech. Assessment of cognitive and language function such as SLTA, WAB, and WAIS are necessary. The patient must have an anticonvulsant such as Keppra, levetiracetam, and classically phenytoin. Consider intraoperative tasks in advance. Preoperative explanation and simulation for a patient in surgical room are also very important. For local anesthesia and nerve block, using 1% xylocaine or 0.2% ropivacaine are subcutaneously injected in supraorbital nerve, auriculotemporal nerve, greater or lesser occipital nerve. Also, local anesthesia are injected into site of pins at head fixation and surgical site of scalp. For anesthesia in craniotomy, propofol and rimfentanil are used using laryngeal mask. Dexmedetomidine is useful for mild sedation in tumor removal. This is our surgical room. Many medical staffs participate in awake surgery to support the patient. Around the patient, surgeons, assistant nurse, anesthesiologist, speech therapist or psychologist, and medical engineer are there. Around the patient, there are many monitoring machines. EEG, video camera, simulator, echo, navigation, and QSAR or Sonopet are there. We have intraoperative MRI here. Extubation is performed under BIS monitor and vital sign monitor. Aspiration from ND tube is important. We prepare a video airway scope for re-intubation just in case. In extubation, compress the brain with your hands to prevent swelling of the brain. You can see blood pressure elevates in extubation. As brain mapping, counting, visual naming test, and auditory comprehension test are used. We usually use 4 mA square wave pulse stimulation with alternative polarity for 5 to 10 seconds. EEG and navigation are also important when mapping.
どうですか？はい、力いこう。はい。1、はい。はい。3、はい。4、はい。5、はい。6、はい。7、はい。8、はい。9、はい。10、はい。10。出ますね。症状出ます。症状出ます。はい、大丈夫よ。ちょっと待ってね。はい、ちょっと一回休みましょうか。はい。今症状。15、はい。16、はい。17、はい。18、はい。19、はい。はい。20、はい。10、はい。出ますね。はい、大丈夫かな？大丈夫ね。ちょっとびっくりしちゃうね。ここは後ろのことだからね。現在がすぐに、カルベさん。あれ、松山さん、はい、今ね、言葉出なくなったところはね、腫瘍がないところだから。はい。バッチリバッチリ。これじゃあこれ何ですか？そうでるし、牛だね。これ何ですか？
ブローカーエリア。
これ何ですか？オッケーオッケーオッケー、大丈夫だ大丈夫だ。これ何ですか？これ何ですか？この辺見れば見えるでしょ。こうか。ねえ、これはこの辺がいいね。そう、それで、オッケー、これ。オッケー、じゃあこの辺だね。オッケー。
Speech therapist shows the card and the patient answer it. Please look. This is examples of questions used to test auditory comprehension. For example, what is your name? What color is snow? What color is sunflower? What color is a crow? This figure shows a brain map for left frontal lobe. This patient with anaplastic astrocytoma underwent gross total resection. This MRI was 1 year from the surgery. We have to mind complications such as pain, seizure, nausea, and GI bleeding. When the patient complains of pain, we have to repeat local anesthesia and use acetaminophen and dexmedetomidine. For GI bleeding or gastric ulcer, proton pump inhibitor is used.
6、8、9、10、11、12、13、14、15、16、17、18、19、20、21、22。これ水？冷水かけて。停電します。右広角。わかる？うん。ねえ、今大丈夫ですからね。これ収まりますからね、今からね。はい。はい、もっとかけてください。はい。まだ停電します。30秒ぐらい今。ノウハウ出てない？見物ない？ノウハウはね、ちょっとわかりづらいですけど、出てます。オッケーオッケー、田村さんいいや。ここのビデオに、大丈夫ですか？落ち着きました。1分以内に回復する。はい、わかります？はい。川内さん、声わかる？はい。自分のお名前言ってみて。はい、川内彦。そうね、お年はおいくつ？72。そうですね。今日何月何日かわかる？5月10。
For nausea and vomiting, metoclopramide, granisetron, serotonin receptor antagonists are used to avoid aspiration pneumonia. When the patient complains of nausea, press the brain with your hands to prevent swelling of the brain during vomiting. I will show the video. The patient complains of nausea. Aspiration is also important.
る。吐きます？
はい。
吐きます川内さん。
はい。
吐きそう？
吐きそう。
そう。つらつらつら。あ、これ当ててるけど。一応ね、ここコートです。いいですよ、入ったっていいですよ。はい、全部入っちゃって。入ってないから。
ちょっとお酒の中入りますよ。
はい、そうです母さんね、大きく深呼吸してごらん。そうです。今、ついどんどん良くなってきて、吐きなくなりますからね。そうです。
For closure of scalp at the end of craniotomy, we have to do local anesthesia again. Sedation using acetaminophen or dexmedetomidine are used. When the patient complains of severe pain, reintubation is sometimes performed under general anesthesia. In closure of scalp, we often see that the patient got hypertension, and control blood pressure is very important to avoid bleeding. Generally, awake surgery is performed for a patient with normal language function. But for the patient with aphasia, second look awake surgery after decompression is performed. This is the case with left frontal glioblastoma with a large cyst. The patient was performed cyst evacuation by local anesthesia. After evacuation of cyst, the patient recovered functional language, and then awake surgery was performed. For a big tumor, we start tumor resection under general anesthesia, and after almost removal of the tumor, we do awake surgery and continue more tumor resection. This case is anaplastic oligodendroglioma with a large frontal region. These are pre-operative MRI. This shows intraoperative MRI after removal of the tumor under general anesthesia. I found residual tumor, and then I continued to remove the tumor. I will show the case of elderly patient. This 19 years old male had a tumor in left temporal lobe. I did awake surgery for him.
お口の中に入ってるもの抜きますからね。わかります？お口を大きく開けますよ。お口あーです。しっかりお口開けて。
今何時
？11時。
1、2、
はい
3、
はい
4、
はい
5、
はいクリスマスは何月
12月。
そうはい今の総理大臣は
菅。
はいここの病院の名前
ダウンセンター。
はい生年月日は
昭和4年12月8日。
今おいくつ
90。
は何
はヘビ。
血液型は
B。
私先生漢字あります漢字これは
野菜。
はい
これは枕。
枕はい
これは八百屋。
おやはい
これは傘。
はい
書くね。
書いてない
怒られるから。
そうかでも奥さんも元気ですね
元気じゃないよ、そんなもの。
だって奥さんがやってくださるんでしょ
台所入っちゃいけないんだよ、うちは。
男性
店によるよ。
なるほどね美味しいラーメン屋さん久我山にありますか
ないね。
ないか外食はしますか
はい。面白い。
面白い障害学習みたいな感じで
あれは酒飲み行くだけ。
酒飲み行くだけ
田村。
はい
あとはこの男。
それ女性じゃないじゃないそれもありですかそれもあり
それもあり。
謝ったりする
しない。
奥様が全て
俺は寝る。ってのはうちの近所にあんね。
それ週に1回ずつそれが励みで頑張れる
綺麗な女性だよみんな。
あ、本当だから頑張れるんでしょってやつ不妊治療ですかそこでやったんですか結婚式
そうそう。
ほらすごいすごいね
喉。
そう喉は潤せないんだけどお口の中だけちょっとぬるいなじゃあ一番小さなお孫さん
男か子だな。
そっか何歳
92ぐらいだ。
5つ下もそっか5人下に
いたんだよ。
はい
それで
でもね
うまいのあるから。
築地
その子供からね。で子供は亡くなったけどもこの間東京で船会社のなんとかっていう
難しいですよね
いや大変なんだねえパソコンで打っていくの。
じゃあそんなことないですお金だけはグランパとか呼ばれたりはし
悪いけども、東大のヤフー
行かない
しばらく経ってからだよ。ああ神社ね。
神社久我山ってどこら辺それもしないあ、本当おせちは出ますか
そうね、いいなうるしたいさ、お線香は終線香は
そっか怒られないでしょうからね怒りたくてもねでもまた大変でしょうね秋人さんですねあ、久人さん
By awake surgery, we can remove the tumor without neurological deficits. But we have to mind deep white matter ischemia after awake surgery for gliomas. This is a case of oligodendroglioma in left parietal lobe. The patient was diagnosed as low-grade glioma incidentally, and the tumor gradually increased in size during 11 years. She complained of dysesthesia and fine movement disturbance of right hand, and then she underwent awake surgery. The tumor locates in mainly a post-central gyrus to angular gyrus. After removal of the tumor, the patient could not calculate by 2 mA of bipolar stimulation, and we stopped removal of the tumor. The patient did not have any complication, but she complained numbness of right hand, dyscalculia, and agraphia at 3 POD. A diffusion weighted image shows the ischemia of deep white matter. She had edaravone and recovered neurologically in 1 week. This figure shows the blood supply in deep white matter. Medullary artery originates from cortical artery, supplies blood in deep white matter, and therefore removal of the cortical tumor with very small medullary artery leads to ischemia in deep white matter. This patient had ischemia of arcuate fasciculus from medullary artery by removal of the tumor. Post-operative management of white matter ischemia, such as enough hydration and edaravone, are very important. Today, I talked about awake surgery. Awake surgery is a basic skill for resection of gliomas for glioma surgeon. Our society published online about the guidelines for awake craniotomy. This describes surgical maneuvers for awake craniotomy, anesthetic management for awake craniotomy, language assessment during awake craniotomy. You can download from website. Finally, I want to address the cure of gliomas. If you are asked from a patient, "Can you cure my glioma?" what will you answer? This case was the longest survivor in Japan and maybe in the world. She started the treatment in 1970. She had right frontal oligodendroglioma, and she has a strong chemoradiation therapy and survived 49 years. MMAC was 26 points and normal, but KPS was 60 because of femoral neck fracture. She finally died of heart failure, not of brain tumor. This case is glioblastoma, which we reported before. This patient also has a normal daily life for more than 25 years. From these patients, it is very important to know glioma patients' cure of disease. This is the staff in my department. Thank you for your attention. I will see you again.
Hello and nice to meet you everyone. I'm Dr. Kishida. Professor Kazadi Kalang, thank you very much for inviting me to your web seminar. I really appreciate the valuable opportunity. I'm a neurosurgeon of Japanese Red Cross Society. My hospital is located within the middle of Japan, between Osaka and capital city Tokyo. I am specialized in neuroendoscopic surgery such as endoscopic transpsphenoidal surgery, endonasal skull-base surgery, endoscopic keyhole surgery, and so on. So I will talk about endoscopic surgery for intracranial tumors and cystic lesions today. You know, there are two types of endoscope, rigid and flexible. Flexible scope is not available in certain countries by virtue of sterilization, though. Our endoscopic surgeries are broadly categorized into 4 types. Flexible endoscopic surgery is performed on intraventricular lesions, and surgery using a tubular retractor is for intraventricular or intraparenchymal lesions. Endoscopic keyhole surgery is useful for extraaxial lesion or skull-base lesions, and endonasal surgery is, performed for paracellar and skull-base lesions. Today, I will make a presentation about endoscopic transtubular retractor surgery. Although the idea of using a tubular retractor for neurological surgery has been proposed from 100 years ago, this surgical method is not so popular even now in the world, I guess. But actually, this type of surgery is very familiar to Japanese neurosurgeons. We operate an intraparenchymal or intraventricular hemorrhage using a small transparent tubular retractor when the patient meets the surgical criteria. In this surgery, single bar hole is made in the patient's forehead, and a small tubular retractor, 6 mm in diameter, is inserted into the hematoma. Then we evacuate the hematoma and stop bleeding by a monopolar suction coagulator. And after removal of hematoma, we confirm hemostasis by irrigation. Pull out the tubular retractor and finish. All of procedures can be finished within 1 hour. That's very simple and safe method. So that's provided by Japanese National Health Insurance. I also started endoscopic hematoma evacuation at 2004 and progressively expand the surgical indication to cystic lesions and tumor cases. More than 200 cases have ever operated in these 15 years. Transparent tubular retractors are roughly separated into 2 groups, small and large. Small tubular retractors are products of Japanese companies. It is 6 to 9 mm in inside diameter. Large one named Viewsight is an American product, which lumen is oval-shaped and over 12 mm in diameter. Maximum size of tubular retractor we use is 70 mm in diameter. 21 or 28 mm view sight is too large, too invasive for human brain, I guess. We categorize the transtubular retractor surgeries into 2 types, one-hand surgery and two-hand surgeries. One-hand surgery means single instrument surgery using a small tubular retractor via a single bar hole. Mainly suction forceps and straight scissor are used. Surgical style is similar to endoscopic hematoma evacuation. And another is two-hand surgery. This large tubular retractor named view site allows us to do microsurgical technique with both hands. For example, we can control hemorrhage using suction by left hand and coagulate the B cells using bipolar coagulator by right hand. So, one-hand surgery is applied to soft and suckable tumors or cyst fenestration. Two-hand surgery is good at handling of surgical instruments and allow us to do more aggressive resection of the tumors. Preparation of surgical instrument is very important. Bipolar or monopolar coagulator and ultrasonic aspirator are available and should be prepared for tumor resection. Malleable or curved instruments are very useful to avoid the interaction with an endoscope. These malleable dissector and rotatable forceps are our original product for endoscopic surgery. Now, I will show you the representative cases of transtubular retractor surgery. First, endoscopic transcortical approach. This is most popular surgery for us to operate the intraparenchymal tumors or regions located around the lateral ventricle. Second, endoscopic transcolloidal approach for third ventricular region. Third is endoscopic transsulcal hyperietal approach for thalamus and trigon of the lateral ventricle. And last, endoscopic subtemporal approach for brainstem lesion. First, this is an illustrative case of endoscopic transcortical approach. Large intraventricular tumor suspected of glioma which involves the left thalamus straight vein. In this case, I deem the approach from lower frontal lobe along the bottom of the tumor to be reasonable to prevent avulsion injury of the thalamus straight vein. I planned to do two-hand surgery using 70 mm in diameter view site by a 3 cm craniotomy through 4 cm forehead wrinkle incision. This is an intraoperative video. Forehead wrinkle incision was performed and 70 mm tubular retractor was inserted to the left lateral ventricle. This is the endoscopic view. Compared to microscopic intraventricular surgery, endoscope provides wide viewing angle, close-up image even in deep and narrow space like this. Now I'm looking for the thalamus straight vein involved in the tumor. I detach the bottom of the tumor from caudate head and thalamus. Thalamus straight vein was exposed carefully and preserved. The tumor was divided into 3 pieces and removed piece by piece. Presumably, here is the origin of the tumor. This is final view. Preserved thalamus straight vein is running here. Postoperatively, tumor resection and the patient's condition was good, and we could confirm the preservation of anterior caudate vein and thalamus straight vein here. This type of surgery can be applicable in various regions. Posterior fossa, fenestration of a cystic lesion, and shallow interparenchymal tumor, and deep interparenchymal tumor. In this case, I assumed the tumor has two compartments and inserted two tubular retractors in each compartment along the long axis. Next, transtubular retractor surgery also can be applied to subventricular lesion. This is the case of colloid cyst with obstructive hydrocephalus. When we approach to the third ventricle, if foramen Monro becomes significantly wide, we are able to gain the third ventricle directly through foramen Monro. But if foramen Monro is narrow by compression by the lesion, we have to enlarge the surgical corridor by interfornicial approach or transchoroidal approach. There is a risk of damaging bilateral fornix and internal cerebral veins in interfornicial approach. So basically, I choose transchoroidal approach. In transchoroidal approach, the choroidal fissures and the roof of the third ventricle are opened by dividing the tenia fornicis that attaches the choroidal plexus to the lateral edge of the fornix. In other simple words, it is a surgical technique to enlarge foramen Monro posteriorly. This is a video. In this case, foramen Monro was very small due to compression by the choroidal cyst, and the cyst wall was too thick and hard to do fenestration. So I divided the tenia fornicis from the posterior margin of foramen Monro to widen the surgical window. This is tenia fornicis and ICV. Tenia fornicis was divided between fornix and choroidal plexus. In this case, anterior septal vein was cut. Most of the wall of the lesion was resected. Also, it was very thick. After finishing the procedures by rigid endoscope, flexible endoscope was used to wash out hematoma and to confirm the normal structures in third ventricle. Here is the aqueduct, and we can observe the residual wall posteriorly. Postoperatively, most of the wall was resected. Patient condition was good. Next one is transcervical approach at the eloquent cortex. For the lesions located in thalamus or trigon, interhemispheric transcallosal approach or transcortical high parietal approach is chosen. The advantage of interhemispheric transcallosal approach is absence of damage at the surface of cortex. However, surgical field is limited at the medial and the contralateral side. Moreover, there is a risk for injury of bilateral cingulate gyrus or bridging veins. On the other hand, motion axis in transcortical high parietal approach is relatively flexible compared to transcallosal approach. But surely, cortical damage eloquent cortex become the biggest problem. Therefore, I am actively engaged on transcervical approach instead of transcortical approach, especially at eloquent area like parietal lobe. To divide the sulci for a long length is a little difficult and complex. So is compatible with transcervical approach because it requires less space than microscopic surgery. According to a previous research, long association fibers and axon terminal connect to subcortical nuclei of gyrus rather than the sulcus. And perforating arteries are also rich at the surface of the gyrus compared to the bottom of the sulcus. So transcervical approach is expected to reduce subcortical damage, not just the cortical injury. Over 10 mm lateral to midline and medial to intraparietal sulcus to avoid injury of SLF2 and cingulum. The choice of the target sulcus is key factor to prevent functional disorders. This is an illustrative case of transcervical approach for thalamic tumor. Although he is young male, unfortunately, pathological diagnosis based on previous biopsy was IDH wild GBM. After coagulation of surface of thalamus, I started suction removal of the tumor. We are able to use bipolar coagulator and scissors in 12 mm view site. Underwater observation is useful to confirm anatomical landmarks such as posterior horn or calcaire. After resection of the tumor, the cavity and the ventricle were washed enough. Transparent tubular retractor was pulled out, and the ventricle wall plasty was done to prevent subdural hygroma. There is no damage to surrounding cortex and veins. Surgical corridor is small. Arachnoidoplasty was also performed. Pre- and postoperative MRI. Local tumor control has been achieved over 15 months. Last case is brainstem lesion. He is a small boy who complained gait disturbance. We suspected pilocytic astrocytoma in brainstem and started observation in the outpatient clinic once. However, the tumor had gradually grown and I decided to do surgery. In the supine lateral position, his head was rotated to the right. S-shaped skin incision on his temporal base was planned. Actual surgery, after the skin incision, small craniotomy was made on his temporal base. I exposed a tendonium cerebelli by subtemporal approach and cut it carefully. We can observe the lateral side of brainstem, SGA, and trochlear nerve. This is oculomotor nerve and trochlear nerve. And now I'm checking the corticospinal tract by intraoperative MEP. Six millimeter small tubular retractor was inserted from safety area. This is an endoscopic view via a tubular retractor. Tumor was soft, less vascularity, and easy to suction. That was very soft tumor. Now I'm doing the underwater surgery by continuous irrigation of saline. Underwater surgery is one of the unique advantages of endoscopic surgery. We can prevent shrinkage of the cavity and keep operative field clean without hemorrhage. Tubular retractor was pulled out. This is final view. Postoperative course was uneventful. Gross total removal of the tumor was achieved, and his symptoms had improved. All told, the advantage of transtubular retractor is to distribute the pressure and reduce damage on surrounding white matter. And the bright, close-up, wide viewing angle images of endoscope are compatible with small and long corridor of a tubular retractor. Of course, the length of corticotomy can be shortened. The largest problem of endoscopic surgery is interference between endoscope and surgical instruments. We have to prepare various instruments and select an adequate size of tubular retractor for each patient. Most of neurosurgeons worry about arterial bleeding and hemostatic procedures. So I will show you an example case of severe bleeding. This is biopsy surgery for intraventricular tumor. Intraoperatively, massive arterial bleeding occurred. Blood overran from the view site like this. This situation is similar to premature rupture of aneurysm in clipping surgery, I think. So I used two large suctions. One is for evacuate hematoma and another is for identification of bleeding point. After identification of bleeding point, hemostasis was done by coagulation and Sagicell cotton. That's the same procedure as microsurgical technique. Actually, massive arterial hemorrhage can be handled by usual microsurgical technique in 12 or 70 millimeter view site. Conclusion. Endoscopic surgery using a tubular retractor is a useful surgical option with several advantages. We should choose adequate approach route, select enough size of tubular retractor, and prepare various instruments for safe surgery. Thank you very much, everyone.
Hello everyone, my name is Yusuke Nishimura and I'm a staff physician and the chief of neurosurgical spine team in Nagoya University Hospital, Japan. I am very honored to give a lecture at this great meeting. The topic of my talk is postoperative kyphotic deformity following resection of spinal tumor. First, please let me introduce myself to everyone. I graduated from Nagoya University in 2001. After finishing my PhD project, I was relocated to Toronto to do clinical fellowship in University of Toronto from 2011 to 2013. I spent an excellent and wonderful time there with my family, and I had a great experience of spinal surgery under my great mentor, Dr. Howard Ginsberg. I also joined a basic research project of neuroregeneration under Dr. Michael Feddings. I am keeping in touch with my mentor, Dr. Ginsberg, and I have been continuously sending my juniors to University of Toronto for clinical fellowship. I would like young neurosurgeons to broaden your horizons and go into the new world beyond the border of your country. That will be a great experience and it would change your life for much better. Okay, I go back to today's topic. Postoperative spinal kyphotic deformity is a huge issue, particularly for pediatric populations. There is evidence supporting concomitant fusion in spinal interdural tumor resection. However, nowadays, less invasive technique is adapted for spinal tumor resection to avoid postoperative kyphosis. The incidence and predictors of postoperative deformity progression following less invasive laminotomy or laminoplasty are poorly understood. Laminectomy is complete removal of lamina and the spinal process with posterior ligaments. Currently, many surgeons adapt a less invasive technique like osteoplastic laminotomy or laminoplasty. Osteoplastic laminotomy consists of en bloc removal of posterior element complex, including lamina, spinous process, and the ligaments, and the procedure of putting it in place following tumor removal and dural closure. Laminoplasty is widely used a surgical procedure to preserve posterior elements. Several different techniques are developed as described in this article. Sorry, described in this slide. We conducted a study to analyze the incidence and predictors of postoperative cervical spinal kypholic deformity following cervical tumor resection with less invasive technique as described earlier. Total of 40 consecutive patients having cervical posterior approach with osteoplastic laminotomy, laminoplasty, or partial laminectomy for cervical spine intradural with or without extradural extension were retrospectively investigated. We excluded metastatic tumor and bone tumor. All 40 cases were assigned to different groups. Group K consists of patients with kyphosis progression of more than 10 degrees. Group N comprised patients with kyphosis progression of less than 10 degrees. We investigated patients' demographics and C-spine alignment, such as C27 cover angle and segmental angle of operated levels. We assessed neurological symptoms using modified McCormick scale, abbreviated as MMS. We also evaluated the presence or absence of motor myelopathy, sensory myelopathy, and radiculopathy. We assessed tumor types and affected levels, the number of operated levels, the number of muscle dissection levels, and muscle dissection length. The presence or absence of C2 and C7 involvement during the surgical procedure was also investigated. These slides show patients' demographics. There were significantly younger patients in Group K compared to Group N. There were no significant differences in preoperative C27 cover angle and segmental angle of operated levels. Cases of Group K has significantly kypholic C27 cover angle postoperatively. both of preoperative and postoperative modified McCormick scale is significantly higher in group K, indicating patients of group K have more severe neurological symptoms. Motor myelopathy is more likely detected in group K. Cases of group K have larger tumors with wider extension compared to group N. Residual tumors are more likely to seen in group K than group N, indicating tumors in group K have more infiltrating nature. Muscle dissection length is significantly longer in group K than group N. C2 laminoplasty is more likely to be seen in this surgical procedure in group K. This is the summary of cases of group K. Patients are young and have large tumors extending multi-levels. Most patients have severe neurological symptoms. Furthermore, most cases have surgical procedure with C2 involvement. We perform univariate logistical regression analysis, which reviewed younger age, high-grade modified McCormick scale, severe myelopathy, large tumors, and surgical procedure with C2 involvement was significantly affecting kyphotic deformity. This is an illustrative case who is a 25-year-old male and has multiple dumbbell schwannoma associated with neurofibromatosis 2. He already had kyphotic C-spine alignment preparatively, tumor removal with C3 to 7 laminoplasty was performed. This is X-ray obtained 1 week after surgical procedure. However, kyphotic deformity started to appear and progressed with time, and myelopathy came back again. Therefore, C2-7 instrumented fusion via posterior approach with pedicle screws were conducted. Postoperatively, he has been very well. This is another illustrative case who is a 5-year-old girl and has dumbbell meningioma without genetic background. She showed vertical C1-2 subluxation following tumor removal. Therefore, this is X-ray obtained 6 months after surgery. Therefore, occipital and C4 instrumental fusion with pedicle screws and lateral muscle screws were conducted. Postoperatively, she has been very well with normal physical development. These are risk factors for postoperative cervical spine deformity demonstrated in the present study. Among them, pediatric population is generally accepted, and one of the most important factors for postoperative spinal deformity. Then we worked on further investigation, focusing on pediatric population. 31 spinal tumor cases aged under 20 were retrospectively analyzed. Their average age was 13 plus minus 4.8 years old. This slide shows breakdown of patients' population by age or tumor location. 6% of all patients are in 0 to 6-year-old age group. 48% of patients are in 7 to 14 age group, and 36% are in 15 to 19 age group. Extradural tumors are seen in 11 cases, 35%. Intradural extramedullary tumors are in 11 cases, 35%. And intermedullary tumor were observed in 9 cases, 29%. The tumors were widely and equally located throughout whole spine. There are 9 cases of cervical spine tumors, 9 cases of thoracic spine tumors, and 10 cases of lumbar spine tumors. 1 case was located in cervical thoracic region, and 2 cases were in thoracic lumbar region. This graph shows neurological symptoms at initial presentation. Motor weakness is the most remarkable symptom. This is probably because small kids cannot complain of subjective sensory symptoms. Therefore, maybe sensory symptoms could not accurately be evaluated, which could lead to delayed and incorrect diagnosis. This is the most difficult problem in diagnosis and treatment of the spinal tumor of pediatric populations. This graph demonstrates the comparison between preoperative and postoperative spinal alignment. Lordosis is shown in negative values and kyphosis is shown in positive values. Postoperative cervical spine and lumbar spine alignment was not changed significantly. However, thoracic spine alignment became significantly more kyphotic postoperatively compared to preoperative alignment. This graph demonstrates comparison between patients with kyphosis progression of more than 10 degrees and patients with kyphosis progression of less than 10 degrees. In terms of 4 variables, such as age, number of operated levels, radiation therapy, and chemotherapy. There were no significant differences between 2 groups. Therefore, these variables did not affect the postoperative spinal alignment. In summary, from the present study of patient populations, we identified thoracic spinal lesion was associated with kyphosis progression. Previous reports also advocated thoracolumbar junction, receiving radiation therapy, and preoperative spinal kyphosis were responsible for postoperative kyphosis progression. So, in order to prevent the postoperative kyphotic deformity following spinal tumor resection. We should pay attention to items as described here. First, we need to know the risk factors for kyphosis progression. Most of all, patients' lifestyle education is the most important, and high-risk patients should be carefully informed of the importance of postoperative immobilization and which activity could make alignment worse. In terms of surgical strategy, target surgery and two-staged surgery may be necessary for large tumors. In surgical procedure, minimum lateral muscle dissection with subperiosteal dissection is vital. If the tumor involves C2 level, the muscle attaching C2 needs to be preserved as much as possible. And the patient needs to be instructed to wear cervical brace and other types of orthosis. This is the conclusion and the take-home message. Identification of high-risk patients for postoperative kyphotic deformity is very important. We need to do patient lifestyle education. We needed to pay great attention to muscle dissection. We needed to do imaging follow-up on a regular basis in outpatient clinic. Furthermore, developing surgical techniques for reconstruction of kyphotic deformity is also important for surgeons who are in charge of patients with spinal tumors. Thank you very much for your listening.
Good day. I'm Dr. Aaron Sara from the Neuroscience Center in Harare. I'm going to talk about the future of neurosurgery in Zimbabwe, the reflection on the past and the present as we look into the future. Zimbabwe is a landlocked country in southern Africa, the southern part of the continent Africa. According to the United Nations, as of 2021, Zimbabwe has a population of 15,174,155. If the WHO recommended number of 1:1,000 neurosurgeons for population densities to be achieved, Zimbabwe will need about 152 neurosurgeons to offer adequate services to its population. In the history of neurosurgery in Zimbabwe, in 1957, Professor Lawrence Fraser-Levy came into Zimbabwe, having trained under Professor Wilder Penfield in Montreal, Canada, and he had also spent some time in New York. He came and introduced neurosurgery then. Zimbabwe at that time was still called Southern Rhodesia. So at that time he was covering Zimbabwe, Malawi, Zambia, and Mozambique. I'm using the present day names of these countries, though they were called by different names then. He also was seeing a few patients from as far as Nairobi in Kenya as well. He was joined later on by Mr. Carol Octeloni in 1967, and later on by Mr. Makarau in 1982, before Professor Kazadi Kalangu joined the team in 1987. These are the pioneers, or what we refer to as the fathers of neurosurgery today in present day Zimbabwe. Neurosurgery was mainly practiced at Harare Central Hospital, which was then called the Salisbury Hospital, and also at the Perinatal Hospital. And there were some visits to Mpilo Hospital in Bulawayo. Now, this is a map of Zimbabwe. The number of neurosurgeons registered with the Medical Council in Zimbabwe at the present moment stands at 14. There are 6 more neurosurgeons from the class of 2020 who will be shortly added onto the register to bring the number to 20. This gives a surgeon population ratio of 1:758,708. There's currently only 1 female neurosurgeon in Zimbabwe. So in terms of women in neurosurgery, there are efforts underway to correct this discrepancy through increased admission of female students into the neurosurgery training, such that there are 4 female trainees currently undergoing training. In terms of the availability of facilities in Zimbabwe, neurosurgery is currently practiced in 3 cities. So there is Harare, which is the capital city with the bulk of the number of neurosurgeons, which will be housing 14 neurosurgeons as we enter into the new year. And there is Bulawayo, which is the 2nd largest city, which has got 2 neurosurgeons. Then we've got Mutare, which will be housing 2 neurosurgeons as well. The presence of these 20 neurosurgeons and being distributed through 3 cities in the country is actually an improvement from the situation from 7 years and going backwards, whereby services were only available in the capital city, which is in Harare. Anyone else who wanted neurosurgical services would have to be transferred to Harare. Now, CT scan services availability in Zimbabwe at the present moment. CT scan services are currently available in 5 cities or towns across the country. So Harare, Bulawayo, Mutare, Masvingo, and Gweru do have CT scan services. The bulk of CT scan services in Zimbabwe are located in Harare. When you talk of Harare, we are incorporating Chitungwiza as well into it. So in Harare, there are 2 public sector CT scans, one located at Harare Hospital and another at Parental Hospital. And there are 12 private CT scan services available in Harare. And in Bulawayo, there are 2 public sector CT scans available at Imperial Hospital and UBH Hospital. And there are 2 private CT scan services in Bulawayo. In Mutare, there is 1 private and there is 1 public sector CT scan available. While in Masvingo, there is 1 CT scan service which is in the public sector, and in Gweru, there is 1 CT scan service which is available in the private sector. So when we look at the total number of CT scans available, there are now 16 CT scan services available in the private sector compared to 6 CT scan services in the public sector. In terms of MRI scan services, these are only available in 2 towns, that's in Harare and in Bulawayo, with the bulk being private. 5 MRI scan services in the private sector in Harare, and there's 1 MRI service in the public sector. There's also in Bulawayo 2 private MRI scan services and 1 public sector MRI scan service. So the rest of the towns, Mutare, Masvingo, and Gweru, which had CT scan services, do not have MRI scan services. Fluoroscopy is available in Harare with 5 units of fluoroscopy in Harare being in the private sector and 3 units being in the public sector. While in Bulawayo, there are 2 in private and in the public sector respectively. In Mutare, there is 1 in the public sector and 1 in the private sector respectively. And in Gweru, there is 1 in the public sector and 1 in the private sector. In Masvingo, there is currently no fluoroscopy service available. There is currently no digital suppression angiography service available in the whole country. So we largely depend on CT angiography. That's what's available in MRI angiography. High-speed drills are only available in Harare with 2 centers in the public sector having high-speed drills. Sorry, 1 public sector center with high-speed drill and 3 private sector centers which have got high-speed drills. The rest of the towns I was referring to do not have high-speed drills. In terms of operating microscopes, in Harare, there is 1 public sector hospital which has got a microscope, and there are 2 private hospitals which have got operating microscopes. In Bulawayo, there are 2 private sector hospitals with operating microscopes, and there are no operating microscopes in the public sector. In Mutare, there is no neurosurgical operating microscope service available. In terms of endoscopic services, neuroendoscopy in Harare, there's one private center which offers only endoscopy for transsphenoidal work, while there's the public sector, one hospital which offers endoscopy both for transsphenoidal work as well as for doing ETVs. ICU bed availability. ICU beds have recently become readily available in most towns since the acquisition of equipment in anticipation of a heavy toll of COVID-19. With COVID not having had as huge a challenge as had been anticipated in our country, the equipment is available and there. Therefore, in terms of availability of equipment and beds for ICU, we have some beds in all of the towns referred to. At the moment, the present big challenge is getting adequate nursing staff who can take care of patients. And this is largely because of the migration which is occurring to higher income countries where they are paid better salaries. In terms of medical education, training centers for undergraduate education available in Zimbabwe are 4, with all the 4 being government-owned, that is, they are in the public sector. And 2 of these have been established for some time now, with graduates having come out of the programs. These are from the University of Zimbabwe and from the National University of Science and Technology. We have younger 2 centers, the Midland State University and the Great Zimbabwe University. These 2 have started recently, and with the MSU having started much earlier than the Great Zimbabwe University. Therefore, they haven't released their first graduates as yet. We hope the MSU will be doing so soon, since they started earlier, maybe this year. In terms of postgraduate neurosurgery education, the University of Zimbabwe offers postgraduate neurosurgery education of the MED program. This is a 5-year structured teaching course, which at completion, one is awarded the MED degree. We also have the COSEXA neurosurgery training, which offers a fellowship in neurosurgery. This is a 6-year course. One of the challenges we have in terms of our neurosurgery, we have a challenge from low investment in healthcare, largely because being a nation with a large communicable disease burden, there tends to be shift of focus and finances being channeled more towards managing communicable diseases, so that the super specialty of neurosurgery and other specialties do not get as much allocation, and therefore this results in poor infrastructure with lack of consumables and materials for service delivery. There's a lack of consistency in service availability, so the patients may not get the services right on time as needed. This is largely to do with the model of funding of health, whereby the moment for CT scan services to be done, a patient has to pay upfront, unless it's a medical emergency in a government service. Otherwise, payment is done first before a CT scan service is made available. Now, With the low incomes which our people do earn, this creates a challenge whereby consistency in service availability becomes a challenge as well. And also the erratic sometimes supply of materials in the public sector means reduced materials for use. And with reduced materials for use, therefore, there tends to be a delay in this delivery of service needed. There's also a challenge of old equipment and old technologies. For example, the MRI scan available in the public sector is a 0.3 Tesla MRI scan. This is an old technology with so many generations of MRI scans available after it. Walking into the future, what can the future be like for neurosurgery in our country? There's a need for a citizens' initiative with doctors leading in establishing healthcare centers that meet acceptable standards. It's very important for doctors to appreciate that often governments follow on citizens' initiatives in various sectors of the economy. And the government activities then follow after a citizen's lead. And in my opinion, the citizen's leadership is rather inevitable if we are to have a future with improved services in neurosurgery delivered. Private medical education led by the private sector or a public-private partnership, which can be done through programs like the COSEXA program and any such other programs which may be adopted. It's one thing that needs to be considered. If we are to meet the numbers that are needed while maintaining or improving on the quality of graduates who will be coming out and making sure they are fully trained to handle the needs of our community. There's needs for members to embrace research and development, not just into the understanding of disease, but to include development of new technologies, starting with basic items. I will talk a little bit more about this shortly. This will work well in conjunction with other countries in order to facilitate knowledge transfer so that we don't have to reinvent anything which has already been invented. But what we need is to get knowledge transfer coming through so that we can improve our neurosurgery with that. There is a need for taking part in international activities. You can only know what you need to improve on when you are aware of what others are doing and when you can tell your own deficits. And awareness comes with travel. So taking part in international activities is an inevitable, it's a requirement which must be fostered. There is need to actively take part in both local and international meetings on knowledge sharing. There is need for embracing international collaboration and twinning efforts with different hospitals and universities, as well as accepting or taking part in student exchange programs and fellowships. There is need for promoting the development of support staff services that include neuro nursing, neuro rehabilitation, equipment technicians, or biomedical engineers. To just have neurosurgeons without the support structure for supporting them, we will not be able to bring the required improvement in quality of service delivery that is needed, because these are critical elements in promoting good and highly powerful services. I come back to my point. There is need to introduce or to reintroduce the manufacturing of basic items and scaling up from there. There is a need for doctors, for neurosurgeons to embrace the generation of patents. This is the critical step in our allowing our neurosurgery to go forward. Zimbabwe had gone forward before, but we've moved backwards. We had started on the manufacturing of shunts, sloppies, patties, and even some instruments like we had what used to be called the copper suction system. This worked for many years, but we had a challenge. These things were started by Professor Levy, and at that time, there were no proteges. There were no graduates coming out of the program. So there was no handing over of this work. We can talk about the Harare shunt, how the Harare shunt was inserted on so many children and adults, and how so many patients today still have what the Harare shunt in. But the Harare shunt's production has not been able to continue on because with the death of Professor Lawrence Fraser-Levy, there are no documents for patents available. We've looked for them, trying to see how we can resuscitate this work. We could not find them. We visited the company which was involved in the manufacturing of this product, and we've realized the technicians who had been trained in this work have since left the country for greener pastures. And this is a challenge which we have, but we need to take it on and start again and have the manufacturing of basic items, and we move forward from there. These pictures you have here, this is the Harare shunt, which was being made in Harare, and was a very useful tool. Thousands of patients at VP shunts inserted using the Harare shunt. This is cotonoids and patties which were made locally. And there is more which can be done. Looking at especially systems of knowledge transfer, which can be acquired through fellowships, through various visits. We need to appreciate that progress comes by improving from what the predecessors started, not by starting all over all the time. The future of neurosurgery is wrapped in our efforts of today. We have been moving, yes, but we need a paradigm shift from where we have been. We need to take our first step. We need to give it a try. Yes, we have done what we have done so far. We are looking at the successes of moving from one neurosurgeon to talk of 20 neurosurgeons today. We have moved and we talk of about 20 trainees who are in the program, but we risk losing the trainees to immigration, like what is happening with other programs, if we do not start now thinking and planning ahead, because we need to improve other services that support what we are offering. I want to thank you for for listening to my presentation. I present to you the mighty Victoria Falls, a falling sheet of water, 109 meters high. Say, welcome one of these days to come and have a look. Visit us, see our neurosurgery, and also take time to visit the Victoria Falls. I thank you.
Hello. It's a great honor for me to be invited in this important session, and I want in particular to thank Professor Yoko Kato for his great contribution to the education in the world and for inviting me often to help in this important topic. I will talk about pediatric AVMs because they are one of the top 10 causes of death in children, and 20% of the AVM are diagnosed during childhood and or adolescence. So they are a very important topic in kids, and many of them present with bleeding. One of the most important thing of the AVM is to understand that they are not congenital. They are something that can evolve over time. So the doubt that Giuseppe Lanzino poses in this important paper is already an acquired definition. So it seems to be evident now that AVM are not a congenital lesion, but they are acquired, and there is probably a genetical abnormality behind them, but there should be a second hit or something else that happened during growth and adolescence, during growth of the brain. So there is something acquired, not very dissimilar to what happened in the dural arteriovenous fistulas. This is not a new topic. Of course, Yazagil, that Professor Yazagil, that said about almost everything about neurosurgery. He already in the 1980s postulate the possible non-congenital origin of the cerebral AVM. Although at that time it was not accepted as a statement. Moreover, we know that there are no developed over time, and we are private from state geography appear, they change over time. More than one half of the AVM increase size, and some of them, very few of them, also decrease or disappear. We also have evidence that some AVM could disappear over time. These are our numbers. This is the patient we observed in the last 9 years. This is a little older. It's 3 years ago, but this is a database we still collect, and this is number of 560 patients in this database. Now is 700, but what we show here is that most in how they appear, they come to our observation. But among them, among all these patients, the rupture age, more frequent rupture age is around 30. So although we observe a peak of observation around 40, around 30, many of them present around the age of 30 as rupture. And if we compare the presentation toward the numbers, so how the relation between ruptured and age of the presentation, so the two curves that I already showed you before are compared, and present the percentage of a patient ruptured. We can see that the age of the pediatric age present as, in many cases, with rupture, and also the old age present with rupture. So the middle age is not, as a percentage, not the one where we have more ruptured AVM. So the children more likely to come to the clinical attention due to hemorrhage more than the adult. And mostly because many of them are located in the central, they are deep located, and so they may not cause epilepsy or other symptoms, but because they have deep draining vein, they can bleed in most of the cases as a presentation. And finally, it's well known that the diffuseness is a problem in pediatric AVM, because diffuseness poses some therapeutic problem. Normally, we think that the idea is that AVM do not contain brain tissue. The AVM is a nidus, pathologic nidus, where we have no interposed brain. While when we have a diffuse AVM, we have a margin of the AVM which is not clear cut, and so we can have tissue be within the vessel. So it's very difficult from a surgical point of view, because it's very difficult to find the right dissection distance around the AVM, because you can be you risk to be too close to the nidus, and so leave behind an abnormal portion of the nidus, or you can dissect too far from the nidus, which can remove clearly the AVM, but you can remove more brain tissue than is necessary. This is a case, a diffuse AVM in a child. As you see here, the boundary of the nidus are not very clear. The AVM is a typically diffuse AVM. And this is the angiography, as you see here. Also here, you have a foggy boundary of the AVM with not a clear definition of the nidus. And in fact, after resection, this is the angiography after resection, and you can see here that there is a remnant, and this was due to the fact that the resection was within the plane, the surgical plane of white matter, but this was responsible for this left a part of the AVM more deep, and there was some white matter within the vessel. So what I thought it was just a feeder, and so I coagulate the feeder, in fact, left some AVM behind it. So it's very the end of surgery, possibly with angiography, which is not easy to have, but you have to be sure not to leave some AVM behind. So an AVM like this is something that is different than the one we have in adult. You can see here that the AVM like these leaves are very diffuse. There is something that is not very definite, and so the definition of diffuse AVM is not very clear. What is it? Are they immature AVM, and will they change over time? Will they mature? We don't know. We know that AVM are not congenital. We know that they can change over time. They will grow. Will they disappear? But will they change over time, being something that will mature over time? There is a classification of diffuseness. This is a paper from Frizzoli that said that there is diffuse AVM, intermediate AVM, and compact AVM. And so this is a compactness score, which substantially is reliable, and it showed in inter-rater reliability between a radiologist and neurosurgeon. So we evaluate our database in the patient below the age of 40. So we kept 238 patients below the age of 40, and we catalogate them in these three category: diffuse, intermediate, and compact. And then we put it together, diffuse and intermediate, because the numbers are very small. And so we dichotomize the category in diffuse plus intermediate versus compact. And as you see here in this plot, you can see that the diffuse and intermediate are much more frequent below the age of 25. And this seems to be a clear-cut a cutoff below the age of 25. There is something different. The frequency is different, and over the age of 25, they are mostly compact. And this is something that has a p-value very high, and the result is really significant. Also, if we keep only the true diffuse and put the intermediate versus the compact, the truly diffuse AVM are also here below the age of 25. And so also here, the p-value is good, and the significant is the result is significant. So the age of 25 seems to be cut off, which is probably different, because this paper of Lawton say that there is no statistically significant difference between sharp and diffuse in children or in adults. But the problem is that they use the age of 18, which is a classical cutoff between pediatric and adult. But we know that the brain is not complete. The process of growing of the brain is not complete at the age of 18. There is growing until the age of 25. So 25 is a good age to define the difference between a brain which is growing and a brain which is already grown. So probably that there is no difference between the age group said by Lawton is only due to the fact that the cutoff was not the age of 18, which is probably different. Moreover, concerning diffuseness, it's difficult to understand exactly what is diffuseness and what is recruitment, because we know that on many AVM we have an image like this that seems to be a diffuse AVM, but all these vessels you see here are not white matter AVM, but they are pial AVM, not white matter vessels, but they are pial vessels on the surface, like this. This is vessel. They are vessels coming on the surface on the pial vessels, and so they are much easier. They are superficial. They are more easy to calculate. While the real diffuse AVM has vessels coming from the deep white matter, and so more fragile, difficult, and we know that they are more difficult to treat. Also, this one seems to be a very diffuse AVM, although the nidus seems to be compacting in part, but we have a very foggy surface, a very not clear boundary of the contour of the. But this was not an AVM. This was a proliferative angiopathy, which is a kind of development malformation that is just superficial pial vessels without a clear-cut nidus, which is something different. We operated, but we didn't find a clear nidus, but just a hypertrophic superficial pial vessels. So after this long introduction, the indication to treat a kid with an AVM is still controversial. Of course, there is no doubt regarding ruptured AVM, but for unruptured AVM, there are two different positions. One is let them leave without harming them, and the other is do something to prevent a future damage. We did 5 years ago, we did the European Consensus Conference on the AVM with the participation of several European and neuroradiologists, neurointerventional, and neurosurgeons to try to understand, especially this was due, we did that after the publication of the Aruba study that create a big problem in the treatment of the AVM. But this was a publication that among several other evaluation, several other consideration concerning a young patient, there was a consensus of suggesting surgery and treatment for young patients, young kids. Also because it seems to be that the enlargement of the AVM seems to alter the adjacent brain. Functional MRI showed that the presence of the AVM in an eloquent area may be associated with the migration of the function to the adjacent cortex and or to the contralateral hemisphere. So it's experience that we all had that operating young kids leads to a very good outcome because the capacity of the kids to compensate a surgical and eventual surgical lesion is much higher than the adult. Also, another indication is that the fact that in many cases the seizure is something that require treatment. More than half of the patient that had seizure before surgery are seizure free after surgery. So seizure in kids is something that really impact on the quality of life. So also if they did not bleed, it's very important that they have to treat the seizure. And finally, there seems to be on the neuropsychological evaluation, it seems to be that they do not have an impact of neuropsychological performance after surgery. This is another paper we evaluate on 500 treated surgically treated AVM, and this was a multi-center study. We published it several years ago, and we evaluated the ruptured versus non-ruptured AVM. And as you see, the outcome of the unruptured AVM, at least concerning score, Spencer-Martin score of 1 to 3, is good. we have 95.8% overall patients that had a good recovery, while among the ruptured AVM, the 95.8 patients in unruptured AVM treated surgically, while in treated AVM in ruptured patient, only 2/3 of them had a good recovery. So the evaluation of the risk of keeping an AVM untreated, or and how could they evolve over time, if we consider that 2% of risk of bleeding will lead to among 100 patients after 20 years, 33 of them had bled. The outcome of these will be different. If they are treated after surgery, after bleeding, the 1/3 of them will have a permanent neurological deficit. While if you treat them before they bleed, after an initial neurological deficit that will be compensated and overcome at least in a few months, 4.5% of them will have a permanent neurological deficit. So if the two curves will overlap in 6.5 years, so if the expectancy of life will be more than 6.5 years, and in a kid it is, of course, the advantage of treating them before bleeding is evident. In our experience, you can treat, if you treat a kid, you can leave him without seizure, and if it have a permanent deficit, the capacity of compensation is very high. And if you consider that most of them present with bleeding at the age of 30, is, in our experience, it's better to prevent this event. And finally, pediatric AVM also must consider the following, because there is a recurrence which is in pediatric not so low. So it's important to consider the pediatric in a pediatric series to do a follow-up. In 14%, we had recurrence. This is an example. This was a patient that was operated when she was 9 years old, and with a big hematoma. We don't have the angiography, but this was the MRI, and this was the MRI they did 1 year after. There was no evidence of AVM. If you see also here, no evidence of any AVM. And this was the AVM she had when she was 28 years old, 19 years later. And so this was the same patient in which the AVM regrow and came to our observation for this AVM. And this was the angiography. As you see also here, fairly diffuse and a big AVM. And this was the surgical result after the surgical resection. So thank you. AVM are still something very mysteriously, and so as you I think I showed you, not everything is completely clear concerning the AVM. In kids, we think that treatment has to be suggested, and also in unruptured AVM. Thank you very much. And thank you to Professor Yoko Kato.
Thank you very much for your kind introduction, Mr. Chairperson. My name is Kurosaki from Tottori University, Japan. Today, I would like to report our surgical procedure and strategy for cellular lesions, focusing on transsphenoidal surgery. Tottori Prefecture is the western part of Japan here, and Yonago is the western part of Tottori Prefecture. Here, Yonago is our hometown. As you know, transsphenoidal pituitary surgery combined with operating microscope and intraoperative fluoroscopy was established by Dr. Hardy in the 1960s. He performed sublabial approach. The other corridor is through a single nostril, namely endonasal approach, which is less invasive. In 1990s, endoscope was applied to the transsphenoidal surgery. Dr. Joe has reported a series of patients who have undergone endoscopic endonasal transsphenoidal surgery. One of the main advantages is excellent panoramic visualization of the cellular and supracellular anatomy, like this. This yellow circle indicates the range of view under the microscope. You can see the cellular flora here, and this is endoscopic view. You can identify the easily and carotid arteries and optic canals here, and also optic carotid recess and endoscope view. National data from USA shows the endoscopic transsphenoidal cases increased from 2003 to 2013, while microscope cases decreased. However, the number of the microscopic procedure is still larger here. Stark reported the outcomes of TSS for acromegaly by experienced pituitary surgeons do not differ between endoscopic and microscopic techniques. However, the recent report indicated the patients treated via the endoscopic approach were more likely to achieve endocrinological remission for non-invasive macroadenomas. Now, transsphenoidal surgical technique is classified into these three groups, that is, microscopic and endoscope-assisted microscopic surgery. We introduced the endoscope into transsphenoidal surgery about 25 years ago. At that time, endoscope-assisted microscopic surgery has been done. Recently, we gradually moved to endoscopic approaches after getting the high-definition type endoscope. From November 2012 to nostrils for hands technique with the collaboration of ENT surgeon has been applied. This slide shows the external view of whole hands approach in our operating room. We use the high definition type, digital endoscope, and the navigation system. The ENT surgeon holds the endoscope, allowing the neurosurgeon to use both two hands and the two surgical instruments. Multiple viewing monitor here. Multiple viewing monitors provide comfortable viewing for surgeons and operating room staff. Recently, we have used 4K ultra high definition endoscope or 3D endoscope during TSS. According to the recent survey-based study, endoscopic transsphenoidal surgery has become established. The surgical procedure which was performed by a neurosurgeon and an otolaryngologist so-called team has become familiar. And to the endoscope has been most commonly used as visualization methods. Now I will present illustrative cases. Follow-up MRI after aneurysm clipping had incidentally revealed the cellular lesions here. The tumor, including hematoma, slightly complex the optic chiasm upward. Endoscopic transsphenoidal surgery was performed. 1 centimeter vertical curved linear incision is made on the mucosa of the nasal septum, and the anterior wall of the sphenoid sinus was widely opened. Bomber bone was removed and blocked like this. Then you can see the cella flora, which was opened widely, drilling. After cutting the dura, at first hematoma was identified in this case. And resecting the small pieces of the tumor. Finally, the expanded diaphragm, arachnoid membrane, normal pituitary gland was identified after removal of the hemojuvelin deposit. Postoperative MRI indicate a complete removal of the tumor. Cabergoline has been widely accepted as the primary treatment for prolactinoma because it has higher efficacy in normalizing prolactin levels and reducing tumor mass. But surgical treatment is reserved for a selected group of patients. The patient with procrastinomas are recommended to discontinue the cabergoline treatment after pregnancy is confirmed. The important thing is the risk of symptomatic pituitary tumor enlargement was relatively high in patients with macroprolactinoma. This 21-year-old woman had been treated with cabergoline. The tumor, including hematoma, has decreased considerably in size. In course of such a treatment, she became pregnant, then the cabergoline was withdrawn. In the 34th week of pregnancy, she was admitted to our department for symptoms suggesting pituitary apoplexy. She presented with severe visual disturbance, almost blind. MRI imaging demonstrated intra and supracellular lesion with a large cavity displaying here fluid levels. Endoscopic TSS was performed after her baby was delivered by cesarean section. After cutting dura, xanthochromic fluid or brown liquid hematoma spurted out and aspirated. And small pieces of the tumor were resected. After debulking of tumor using irrigation suction system, residual adenoma was dissected from the normal pituitary gland. Finally, normal pituitary gland and diaphragm descended into the cellar. She followed a satisfactory post-operative course and her visual disturbance was alleviated. Post-operative MRI showed no residual tumor. In this article, the authors described surgical techniques in which the histological shoot capsule is used as a surgical capsule during pituitary surgery. Intensive dissection of the microsurgical shoot capsule is essential to accomplish endocrinological remission for acromegaly. If you performed intracapsular resection like this of this tumor, tiny adenoma here would remain and endocrinological remission would not be achieved. The extracapsular resection has been recommended. This 43-year-old man was admitted to our hospital with acromegaly. The pituitary adenoma is depicted clearly here as a less enhanced area surrounding the normal pituitary gland on post-contrast T1 weighted images. The tumor was entirely removed by the endonasal approach and endocrinological remission was achieved. In this case, so-called extracapsular resection was performed and the endoscope. Now you can see here the cavernous sinus through the dura. Dural incision was made. The interface between the tumor and normal pituitary gland was identified. Dissection at the interface of tumor capsule was performed. The adenoma was dissected from the normal pituitary gland or the medial wall of the left side cavernous sinus. Small lesions identified around the inner membrane of the cavernous sinus and then removed. Now you can moved by the endoscope transsphenoidal surgery. So-called extracapsular removal of the tumor was performed. Histopathological examination revealed the TSH-producing adenoma. After developing the soft component of the tumor, extracapsular removal was performed. The tumor was relatively fibrous and sticky. Arachnoid membrane was now peeled off. The tumor was dissected from the medial wall of the left cavernous sinus using this Schütte capsule. The adenoma was dissected from the normal pituitary gland. And supracellular fragments, including Schütte capsule, was removed. Then the transparent and thin pituitary tissue descends down with pulsation. In the last decade, the classic transsphenoidal surgery has undergone further transformation, so-called extended transsphenoidal surgery. Among them, precellular transplanum transtuberculum approach is most popular. This slide shows the important anatomical landmark of the cellular lesion after anterior sphenoidectomy. Lateral optic carotid recess here corresponds to the optic tract and important landmark. And also another OCR, so-called medial OCR optic carotid recess, has become an important landmark for endoscopic approaches to paracellular and supracellular lesions. This slide shows the endoscopic endonasal view of the subchiasmatic area. Superior hypophyseal arteries are exposed and should be preserved. Here. These are stepwise views of surgical anatomy for the transplant approach. This approach is appropriate for the craniopharyngioma to be operated. This video shows the cadaver dissection of precellular transplanum approach. The specimen has precellular type of sphenoid sinus. Then the reading is needed to be expose the cellular flora. Now right side optic canal is exposed. Then left side cavernous sinus exposed here. And wide sphenoidectomy is the important procedure. After cutting the dura of the tuberculum area, chiasm, pituitary stalk, and SHA was identified. Then, inserting the endoscope deeper, you can find the important landmark, such as mammillary bodies, BA, PCA, SCA, and oculomotor nerves. The nasoseptal flap has an important role in the development of endoscopic extended transsphenoidal surgery. The flap is pedicled on the sphenopalatine artery. The flap is an effective barrier for the prevention of CSF leaks from cranial base. We usually use the sinus balloon for week. This MRI shows the mass lesion in the sphenoid sinus and the crevasse region. Biopsy examination through the nostril revealed the neuroblastoma. Then radiation was the treatment of choice due to advanced age. Although the tumor was shrunk 1 year after radiotherapy, she was transferred to our hospital because of somnolence and CSF line layer. On admission, CT showed this extensive pneumocephalus. The tumor was subtotally removed via transcribal approach, and repair was performed using nasoseptal flap. She had a satisfactory postoperative course. This elderly patient presented with visual disturbance. MRI shows the large cystic mass here, craniopharyngioma. The patient and his family hope to undergo transsphenoidal surgery. Then I decided to perform the endoscopic transplanum approach because he has never suffered from diabetes insipidus. Pituitary stalk should be preserved. Posterior ethmoidectomy is important procedure during this approach. At first, nasoseptal flap was made on the left side nasal septum. Following posterior ethmoidectomy, wide sphenoidectomy was performed like this. Then you can see the sella flora and planum sphenoidale. Sphenoidectomy was added at the lower part. Now I'm exposing the optic canal and right side medial OCR. Then after coagulating and cutting the anterior intercavernous sinus, dural incision was added. After cutting the arachnoid and opening the cyst wall, tumor was removed. Cyst wall was dissected from the superior hypophyseal artery here. You can find the basilar artery and oculomotor nerves. Because cyst wall was adherent to pituitary stalk severely, partial removal of the cyst wall was performed. Fascia was inserted into the cell floor, followed by nasal septum mucosal flap. Then sinus balloon was inserted and inflated. This patient has suffered from headache due to hydrocephalus. MRI imaging demonstrated cellular and supracellular cystic lesions with calcification, and the tumor extended into third ventricle. Preoperative diagnosis, craniopharyngioma. Now I am cutting the dura of the cell flora. Then, after coagulating and cutting the anterior intercavernous sinus, dural incision was added. And intracranially, after opening the cystic chiasmatic system, the tumor, including calcification, was identified and removed piece by piece. Here you can see the SHA, superior hypophyseal arteries, and debulking of the tumor was performed. And you can see the pituitary stalk and the SHA and the chiasm here. After debulking of the tumor, opening of the third ventricle was found. Cyst wall was dissected from the surrounding structures in the third ventricle. Then Finally, tumor capsule was totally removed and through the left nostril. And you can see the foramen Monroe fascia was inserted into the cella and suture to the dura, and followed by a nasal septal mucosal flap. This is a PGA sheet and nasal septal mucosal flap. Then sinus balloon was inserted and inflated. Post-operative MR images showed no cystic mass. In conclusion, our experience of transsphenoidal surgery with endoscope was reported. The main advantage of the endoscopic transsphenoidal surgery is excellent panoramic visualization. A forehand approach with the collaboration of ENT surgeons is a feasible and effective surgical treatment in TSS. Using extended transsphenoidal surgical technique is one of the treatment options for suprasellar lesions like craniopharyngiomas. Thank you very much for your attention.
called Asian Congress of Neurosurgical Nurses, ACNN, was started in 2019 with the aim first to enable more neuro nurses from developing countries to participate in ACNN with a lower cost. Secondly, to educate to improve knowledge and skill of neuro nurses from developing countries on handling neuro patients. Third, to encourage more neuro nurses to participate in neuro nursing research and neuro nursing innovation. Last but not least, encourage networking among neuro nurses in the developing countries. This is the committee of ACNN with Professor Yoko Kato as the patron of ACNN. Our activities such as first ACNN was held in Indonesia, organized by Professor Eka on the 21st of August 2019, followed by second ACNN was held in Chennai, India on the 1st February 2020, organized by Professor Krish Sridhar. And the third, which is the first feature ACNN, also held in Chennai, India by Professor Krish Sridhar. And the fourth ACNN, which was the second feature ACNN, organized by Professor Krishna Sharma, Nepal, on the 5th and the 6th of August 2021. The next one will be March 2022 in Shanghai, China. The organizer will be Professor Bing Su. Hope there will be more participation from the nurses. Other activities such as educational webinar, and we are starting our first educational webinar on the 20th November 2021, followed by the second on 19th February 2022. We do have our joint event. That is the first hemorrhagic stroke nursing update organized by Nursing Division, Department of Neurosurgery, Kuala Lumpur Hospital, Malaysia, in cooperation with ACNN very recently, 29 October 2021. I do hope there are more joint events coming up in the near future. Thank you.
It is my great pleasure to welcome all of you to join our educational activity, the Latin America and Africa Web Seminar 2021. So this seminar is the very last educational activity of the ACNS for all young neurosurgeons. So this time I'm very happy to introduce the patron from Latin America. One is from Venezuela, the Professor Fernando Veleda Alonso. And one more very important person from Ecuador, Professor Byron Salazar. And also the African patron, the sponsor and great teacher is one is Kazate Kalangu from Zimbabwe, and also the Mohammed Freshi from Kenya. So both of them is a very important person from Africa, and a very great leadership for all young neurosurgeons. So one another is no need to introduce is a Professor Nazir El Gandon. So all three, the big, the sponsor and teacher, and also the patron is to support all over your educational activity in the next 2 days. I wish that all of you will have the great the learning, and also this time is not enough for hands-on or like the surgery, but so in the future we can prepare for all of you to have such a nice chance. Please enjoy. Thank you very much.
On behalf of the Venezuelan Society of Neurosurgery, we'd like to welcome you all to this scientific summit because you are the ones making possible this day to be shared with the scientific knowledge from international professors. Being this knowledge beneficial bidirectionally for our country and enriching for our specialists and residents formation. Thank you so much. Enjoy yourselves.
Good evening, good morning to you all. Professor Yoko Kato, President of Asian Congress of Neurological Surgeons, distinguished guests and colleagues from Latin America and African Neurosurgical Societies. I'm very honored to participate on this international education event, and I thank Professor Kato for her kind invitation to share this special occasion with the understanding that this program will help to integrate and bring together our partnership of neurosurgical education to a higher level of performance and development around the globe. The lecture I will talk about is related to ergonomics in neurosurgery, and I hope this theme will achieve its goal, which is to promote the best care of our patients.
Good morning. I think we
Hello.
should. Hello.
Hello.
Hello, everyone. I think we should start this live session. This is Alberto Feletti speaking, and I am very happy today to join the webinar and have, first of all, with me, my co-chair, Dr. Sharon Theophilus.
Yeah. Hello. Good morning, everyone.
Hello, Sharon.
Hi.
So today we have two great speakers. I have the pleasure and the honor to introduce our first speaker, Professor Rokuya Tanikawa. I really believe Professor Tanikawa does not need any introduction, but just briefly, I want to remind all of you that he works at the Department of Stroke at Teishinkai Hospital, Sapporo, Japan, and he is a world-renowned neurosurgeon. His main expertise being, of course, cerebrovascular surgery and cranial-based surgery and vascular reconstructions for both arteries and veins. Actually, today, Professor Tanikawa is gonna talk about microsurgical approach and vascular reconstruction for intracranial aneurysms. So thank you, Professor Tanikawa, to join the webinar, and please, you can start your talk.
Okay. Thank you very much for your invitation to ACNS educational webinar. It's my great pleasure to talk my experience. And today, I'll show you my experience about the vascular reconstruction and the microsurgical approach, how to do appropriate approach to the lesion, intracranial lesion. Can you see it? Can you see my slide?
Yes, we do.
Okay. So I always think about the accuracy of the surgery. Everybody knows accuracy of surgery based on the bloodless operative field, confirmation of anatomy, and the exposure and the decision. Just a moment. Can you see it? Oh.
Yes.
Yes, we can.
So the accuracy of the surgery is, these factors are very important. Bloodless operative field, exact knowledge of anatomy, and sufficient and appropriate exposure of the lesion. And the decision is very important. For example, preserve or sacrifice the object, extend or not, to do to continue the surgery with the extension of the surgical field or not, or whether we should revascularize or not, we should do a bypass or not. If we have something trouble, the injury or occlusion of the original parent artery, something. This decision is very important, but again, the bloodless operative field is quite important. This means that the operative field is clean. Then we can see any object in the operative field clearly. So the hemostasis is the most important thing in the surgery. We have to understand the hemostasis is the most important, most strong priority in the surgery. And the appropriate dissection, for example, Sylvian fissure dissection, separation of Sylvian fissure without blood, complete separation of a Sylvian fissure widely especially longitudinally widely, of course, just horizontally widely, but the frontal and the temporal lobe must be separated without injury. As well, if we try to do an interhemiscale approach, the relatively interhemiscale fissure is difficult to separate, but if we achieve the skill to separate the interhemiscale fissure atraumatically, this makes an ideal operative field to approach the ACOM complex. The anatomy of ACOM complex is sometimes very difficult because of anomaly of the anatomy. For example, the ACOM fenestration and Artigos ACA. This anomaly makes the aneurysm dissection or exposure difficult. So the interhemiscale approach for ACOM aneurysm is very strong and efficient approach to expose it and to clip it. When we finish the micro manipulation under microscope after clipping or after tumor removal, always we have to close the dura. The dural closure is very important, especially to do watertight closure. But everybody knows the watertight closure is not easy. And I always tell my young colleagues, because it is common to close the dura mater is the young neurosurgeon's residence work. And the young neurosurgeon's residence has relatively inferior skill to stitch anything. So for them, even dural closure is difficult. But if the watertight closure of dura can be achieved, it makes the neurosurgeon well to stitch the microvasculature, especially intracranial arteries or veins. So the daily dural closure is a very important, very efficient training for young neurosurgeons. Of course, then we can perform the microvascular anastomosis. The neurosurgeon who cannot perform the watertight closure cannot perform the microvascular anastomosis. This is a principle. This is an example of a complete hemostasis of a front temporal craniotomy. Now the temporal muscle is elevated, the front temporal craniotomy is performed, and then the breathing from a dura mater and bony surface is completely stop the hemostasis, the breathing. We can get the complete hemostasis. Then you can open the dura. Without complete hemostasis, we can't open the dura. This step is very important to perform the appropriate micro approach, like transribbian or interhemiscale approach or micro anastomosis bypass. Another example, this is a middle fossa exposure in left side. Now you can see that I am doing temporal rhomboid and skeletonizing internal auditory canal, cochlea, superior semicircular, and GSPN. Under GSPN, we can expose the C6 carotid again. here, this is a very important anatomy. This is a very important anatomy of the middle fossa. Here is foramen ovale, everybody knows. Here is a spinosum. And this is a famous anatomy of a temporal rhomboid right here. V3 posterior border, GSPN, arcade eminence, petrous edge. This rhomboid is so-called temporal rhomboid, is very important. And we can drill the temporal rhomboid and skeletonize the IAC. And here, this is a C6 internal carotid. Here is a C6 internal carotid just beneath the GSPN. You can confirm the Doppler sound of a C6 internal carotid artery. And you can skeletonize the internal auditory canal. Just anterolaterally, there is a cochlea. Posteriorly, there is a superior semicircular. In this case, the mastodectomy has already been done. So the lateral semicircular, posterior semicircular has already skeletonized. And here, the internal auditory canal. And this part is a course of a fission to the GSPN. So this anatomy in the middle fossa is very important anatomy. But why I'm showing you this anatomy? In a middle fossa dissection, when we elevate the dura mater, we have much bleeding from the cavernous sinus from the bony surface after detaching the dura mater. So to confirm, to detect the normal anatomy like this, we need a complete hemostasis from the cavernous sinus and bony surface with the appropriate way of hemostasis. Not only cauterized, not only a cautery, but also sagittal packing, sagittal attaching, gel form attachment, fibrin glue gel form attachment, fibrin glue sagittal attachment. We need to know the way of hemostasis. And again, dural closure. This is an example of dural closure. I always force my young colleagues to close the dura under microscope like this. Because the whole layer penetration of dura mater is very important. Under microscope, you have to confirm whether the stitching needle can penetrate the whole layer of dura mater. This is an important principle to perform the exact stitching of the dura mater. And this connects to a microvascular anastomosis. So this is the principle of a dural stitching, dural closure. If the thickness of a dura mater was large T, the stitching bite of a dura mater should be twice of a large T. Then this distance should be 4 times of the dura thickness, and the stitching interval should be 4 times of dura thickness. This is a principle. This is so-called square stitching. With the stitching, basically we have no leakage in between the stitching intervals. This is very important. And this is the principle of microanastomosis. The important principle is fishmouth trimming. The intimal layer in each side, each vessel, donor and recipient should be attached to each other like this. If the vessel wall was inverted like this, this causes acute thrombosis of the anastomosis, and this makes occlusion of the bypass. So the everting of the vessel wall is quite important. To achieve this situation during microanastomosis maneuver, especially in end-to side anastomosis, the Fishman storming is very effective to achieve the everting. I always recommend you to perform the Fishman storming at the donor end with a 60-degree oblique cut, and the same length should be cut up like this. So the total stitching length in Fishman storming end-to-side anastomosis, this length is 4 times large D. Large D is a shrunk diameter of the donor. This can be calculated pi r divided by 2. And this length should be 4 times of large D divided by root 3. This can be calculated approximately 2.3 times of large D of the shrunk diameter of the donor. This is a very important basic dimension of the Fishman storming. When we perform the end-to-side anastomosis or microanastomosis, the donor and the recipient should be attached to each other like this. And again, this is the principle. If the wall thickness was here, the stitching bite should be twice of wall thickness. And the interval should be 4 times of wall thickness. This is a principle. With this stitching, you have no leakage, no blood leakage in between each stitch. This is a principle. We need to train as an off-the-job training. We need it to train. We using a synthetic tube, something, or if you have a laboratory, you can try to do a end-to-side anastomosis with the rat carotid, internal carotid, or common carotid. But the synthetic tubes, recent synthetic tubes are very excellent. It is good enough to do a training. This is a illustrative expression of the everting like this. This is drawn by my colleague Cosmo Noda. He's not only an excellent illustrator, but also a very excellent neurosurgeon. Anyway, with Fishman storming, it is easy to do a everting condition like this. And this is a drawing by my mentor, Professor Kamiyama. This drawing approximately made 40 years ago. This shows the side-to-side anastomosis. The Professor Kamiyama, he designed the symmetrical inner curved arteriotomy like this when we perform the side-to-side anastomosis. In the bottom side, everybody knows we can do a running suture like this, but you can realize that in the bottom side running suture, the vessel wall is not inverted, is not everted. This is inverted. This means that the bottom side vessel walls attached attached in adventitia layer in each side. This means that the cutting edge of the vessel wall, it contains a collagen fiber, and this is exposing inside of a vessel lumen, and this may cause acute thrombosis after the reflow of the parent artery. So this is the drawback of the side-to-side anastomosis. Bottom side cannot be averted, but the superior wall can be averted like this. So to prevent acute occlusion in side-to-side anastomosis, we need to make the orifice bigger. To make the orifice bigger, we need a long arteriotomy. So I always recommend when we perform the side-to-side anastomosis, I recommend at least 3 times longer arteriotomy of the vessel parent artery diameter. For example, if the parent artery diameter was 2 millimeter, arteriotomy should be 6 millimeter. This is the principle in side-to-side anastomosis. This is an example of the transribian approach. This is an unruptured PCOM aneurysm. This is a left side transribian approach, distal transribian. With the highest magnification, you can separate the Sylvian fissure with the confirming the microanatomy. We can cut only arachnoid trabecula. Any vessel should be preserved. This is the right side, and you can see in the Sylvian varicula along the M1 horizontal segment, the arachnoid trabecula between M1 segment and the temporal inner surface is connected. The arachnoid trabecula can be incised, and uncus and the oculomotor nerve is attached with the arachnoid trabeculus like this. The arachnoid trabecula between the oculomotor nerve and the uncus should be incised. Then you can decompress the oculomotor nerve with the temporal uncus retraction. And with this approach, we can confirm the medial part of a neck of an aneurysm and confirm the anterior term perforating artery and PCOM. Here, you can see the cisternal oculomotor nerve. Here is the tentorial edge. Here is the oculomotor foramen. And this is a so-called anterior temporal approach, securing the operative field in retrocarotidy space, like this. This blue triangle indicates retrocarotidy space. I'll show you an example of a retrograde suction decompression technique for large ophthalmic aneurysm. Now I am cannulating a 5 French infantile tube into a superior thyroid artery. This is a left side neck exposure. After inserting the 5 French infantile tube into a common carotid through the superior thyroid artery, this is a M4 segment of the left MCA, and I am trying to do STA M4 bypass. This is a backup bypass for prevention of the ischemic complication during a temporary occlusion of an internal carotid. Because I expected the temporal occlusion of an internal carotid should be longer during surgery. So the prior to temporary occlusion of the internal carotid artery, I put the STM cell bypass. By occlusion of a common carotid, external carotid, and the distal ICA, distal to the aneurysm, through the suprathyroid artery, you can suck the blood in aneurysm. Then here, after the anticrinoidectomy, here is the distal dural ring expanded by the aneurysm itself. I am detaching the distal dural ring from the aneurysm neck. Here is a optic nerve left side, and the aneurysm is attaching to an optic nerve. But with the retrograde suction decompression, the aneurysm is well decompressed, and it is easy to detach the aneurysm from the optic nerve, and it makes easy to put a clip on the aneurysm neck. Now you can remove the temporal occlusion from the common carotid and distal ICA, distal to the aneurysm. Now, still I have a doubt the aneurysm is still alive, so I incise the aneurysm, and I am removing the inside thrombus. It looks dead, but you can see gradually the arterial bleeding is coming from the aneurysm. This means that the medial part of aneurysm has a thin wall, so I am putting the fenestrated straight grip to close the only medial thin part of aneurysm, and I'm putting additional grips. This is a straight grip on the lateral part of aneurysm, thick part, to close the aneurysm completely. The post-operative CT scan and the CT angio shows a good patency of the internal carotid and no change of the brain. The patient visual acuity recovered well. Nothing happened. The next case, this is a 36-year-old female kissing aneurysm of PCOM and choroidal artery. This is the left side. You can see the choroidal aneurysm is right here. In this case, I decided it is very difficult to separate the aneurysm without retrograde suction decompression. So I opened the neck and cannulated the tube into a suprathyroid to do a retrograde suction decompression. Now, PCOM and the distal ICA and the common carotid is occluded, and the retrograde suction decompression is performed. The slight injury of the aneurysm dome is happened, but nothing problem. This is the first clip to the anterior choroidal artery aneurysm, and this is a second dissection of the PCOM aneurysm, which is attaching to the oculomotor nerve. Again, I am confirming the most proximal first branch of the PCOM, so-called anterior terminal perforating artery, and put a grip completely, not to make the remnant the aneurysm. I can skip this. So even in such a regular size aneurysm, not only a big aneurysm, the retrograde suction decompression technique for clipping is very useful, and it makes operation easier and safer. I'll show you an example of anterotemporal approach. This is for basilar SCA aneurysm, unruptured one. This is a left side unruptured basilar SCA aneurysm. In this case, the middle meningeal artery feeding the ophthalmic artery. And ophthalmic origin is aplasia from the internal carotid. So that we have to be careful not to injure the middle meningeal artery and meningo orbital artery. In this case, the sphenoparietal sinus joining to the dura very early, so it is difficult to separate the fissure. So I am detaching the sphenoparietal sinus from the cavernous lateral wall by incising the dura, but I injure the venous wall like this. So in this case, I am repairing the injured point with the direct stitching using a 10-0 suture. This is a so-called single hand stitching technique using a sucker. This is a very useful skill to control the bleeding and to stitch the injured point. Even if we have something bleeding from the aneurysm or aneurysm neck or something premature rupture happened, the continuous sucking control and we can stitch the injured part. This is a very important skill to repair the injured vessel. Anyway, now the sphenoparietal sinus can be detached the cavernous sinus at the inner reticular layer of a cavernous sinus. Now, it can separate the distal cerebral fissure, the temporal side to the superficial cerebral vein. And in this case, here, the oculomotor nerve can be observed in the depth of the operative field, but at the superficial part, there is the bridging vein interfering the operative field. Here you can see the temporal side vein is connecting to a superficial cerebral vein, frontal side. I'm confirming the temporal side superficial cerebral vein has a good collateral, so I decided to separate here with a temporal occlusion of the bridging vein. Then you can extend the approach as an anterior temporal approach to extend the retrocarotid space. Here is an arachnoid membrane between the oculomotor and the temporal uncus, the superior cerebella, oculomotor nerve, basilar trunk, and aneurysm can be exposed. Here is the origin of ipsilateral P1. And under the oculomotor nerve, we can secure the basilar trunk. And then we can confirm the anatomy that I'm putting a temporal clip on the contralateral P1. This is the ipsilateral PCOM origin is occluded to soften the aneurysm, to decompress the aneurysm. The dome of aneurysm is attaching to a P2 segment like this, PCOM P2 junction. This adhesion should be separated sharply using the micro scissors like this. And additionally, very important perforators are attaching to the aneurysm. These perforators must be preserved. And here is the distal neck, and here the behind aneurysm neck. Then in supraoculomotor space, we can try to put the tentative grip on the neck. Here, the tip of a grip blade is not occluded completely, the aneurysm. Now I am adjusting the tip of a clip blade not to occlude any perforators, then this is appropriate clipping. Then you can remove the temporary clip from the contralateral P1, ipsilateral P1, and basal trunk. The IC green shows a good patency of all the perforators, and any of them is completely obliterated. This is an example of the anterior-temporal approach. And after the neck clipping, separated the bridging vein between a temporal superficial cerebral vein and the frontal superficial cerebral vein can be stitched as an end-to-end anastomosis. This is a 6 o'clock stay suture. And this is a 12 o'clock stay suture. Then, the step by step, we can stitch the venous wall meticulously. And this is the other side. With the highest magnification, we can confirm the vessel wall appropriately, exactly. Then here, you can open it. We can reconstruct the even vein. The icy green shows a good patency of the reconstructed part. Then you can close the door. Okay, I think it's almost time. So in conclusion, the clean and bright operative field is necessary. It's important. Hemostasis in every step is it's a must. And the highest magnification of microscope is important to see tiny structures. We can cut only arachnoid membrane. We should preserve not only arteries but also veins. The distal cerebral separation between the frontal and temporal lobe is a basis of a microsurgery, especially for microanastomosis. This is a basic skill to perform the microanastomosis. Without bloodless cerebral dissection, the exact microanastomosis is impossible. As well, the watertight dural closure is a must. We should master the skill of the dural closure. So that's all. Thank you for your attention. Thank you very much.
Thank you so much, Professor Tanikawa, for this wonderful presentation. I am sure there will be many questions for you. Probably we have to go ahead with the second talk and save the last 15 minutes for questions and answer. So, Sharon.
So our next speaker is Professor Ibrahim Spey. He's currently practicing in the Farah Medical Campus, Neurosurgical Department in Jordan. He graduated from the University of Alexandria with honors and attained his FRCS Surgical Neurology with distinction gold medal. Currently, he's a member of the Skull-Based Surgery Committee of WFNS. He has held numerous distinguished posts previously, including the president of the Pan-Arab Neurological Society. He's the pioneer of breakthrough of skull surgery in Jordan. He's also achieved the first lumbar microdiscectomy in Jordan and the first gamma knife surgery in Middle East and Africa. He has numerous research and publications in renowned journals, which is a tribute to a successful and his dedication to neurosurgery. It's truly an honor to now welcome Professor Ibrahim to present his topic, sphenoorbital meningioma.
Thank you very much indeed. I will just share my screen. Thank you very much for the invitation. It's a great pleasure and honor to be with you here today. And I'm being asked by the organizing committee to present myself. You've done that already, but just to go through some of the slides that I prepared for you. And also I've been asked to say a few words of wisdom to our young residents and neurosurgical colleagues, which I will also attend to. So this is me graduating from Alexandria University. I was not a nerd. I was playing football, and I was actually one of those hippies at that time. I finished from Alexandria and I went to train in the neurosurgical practice at the Atkinson Morley Hospital, which was established back in 1868 as part of St. George's Medical School. Indeed, it is one of the finest brain surgery centers in the world. I was privileged to work there. It is part of St. George's University and Hospital. And there at Atkinson Morley back in 1971, for people who don't know, the first CT scan was invented by Godfrey Hounsfield, as you know, Hounsfield numbers and CT, and by Jamie Ambrose, the radiologist. So an engineer and radiologist combined efforts to produce the first CT scan pictures back in 71, for which Godfrey Hounsfield got the Nobel Prize for his achievement. At that center, the Atkinson Morley Hospital, giants of neurosurgery worked. Just to mention a few of them, Sir Wiley McKissick, Norman Dutt, who actually worked with Harvey Cushing, and Alan Richardson and David Utley, who was the first skull-based surgeon in England, and I was privileged to work with him too. I graduated from the Royal College of Surgeons of Glasgow and the Royal College of Surgeons of Edinburgh with FRCS degree in general surgery and FRCSSN in surgical neurology. I came back to Jordan and I became the president of the Jordanian Neuroscience Society, and then became the president of the Pan-Arab Neurosurgical Society. And I joined the forces of ACNS from very early years, very strong relations with the ACNS over the years. This is my friend Yoko Kato, a closer friend of mine, a family, she's a family actually. Joined also the AOSPS and the American Association, the Congress of Neurological Surgeons, and the WFNS, where I became a member of the skull-based committee back in '99, so it's almost 22 years, 23 years. And my center in Jordan was recognized as a skull-based training center. Of course, I joined many other committees of the World Federation, skull-based oncology, education, initiative, and fundraising. I established my own cadaveric lab in Jordan, which attracted attention from the Arab world and the other surrounding areas. We have held so many courses. This is Vinko Dollins and Ali Kresh and others. I became the vice president of the WFNS for 4 years. And we dared to compete with South Korea back in 2013 to host the Congress. We just lost for South Korea then. Also, I was elected part of the prestigious World Academy of Neurosurgery. I'm married. This is my wife. She is highly educated and she is a TV presenter with a high degree in public relations and in TV. I have one son and 4 girls. Also, I'd like to take a few minutes to introduce my country, Jordan, to you. Jordan is surrounded by Israel, by Egypt, Saudi Arabia, Iraq, and Syria. This is Petra of Jordan, one of the world wonders. Wadi Rum, which is a famous place in Jordan, a touristic place. It is like moon-like terrain and marsh-like terrain. So it's so beautiful, and so many films have been filmed there. Just to mention a few: Lawrence of Arabia back in '62, David Lane and Omar Sharif, Indiana Jones, The Martians, and others. The last one was Aladdin. In Jordan, you have the Dead Sea, which is the lowest point on earth. It says here 420 meters. That was all time. Now it's about 460 meters below sea level. And there you can just float on the surface of the water without any movement. You just read your newspaper. And this is the famous mud treatment. This is the capital Amman with so many amphitheaters. And this is Amman, where I live, and we have snow every year. In fact, we are expecting snow tomorrow. Baptism site on the River Jordan is a UNESCO World Heritage Site where St. John the Baptist baptized Jesus Christ at the Jordan River. It's a touristic place, it's a religious place, respected. And this is Pope visiting us. And this is the Basilica Church of Trinity there. This is Mount Nebo and the famous mosaic maps. This is the city of Jerash, the very old city of Jerash, which is only second to Rome with its amphitheaters and antiques. Famous Jerash festival every year. And in Jordan, we are very careful about eco-tourism and adventure tourism. This is the Black Iris symbol of Jordan. Jordan is also a medical hub in the Middle East. The first heart transplant was performed back in 1985. The first CT scan, we were the first country in the Middle East to have the CT scan. We were country number 8 in the world to acquire a CT scan back in 78. First tested tube baby in Jordan was 1986. And the first neurosurgeon in Jordan is Anton Tarazi back in 1962. He trained in Toronto, in Canada. He came back to Jordan and established the first neurosurgical unit at Augusta Victoria Hospital in Jerusalem, which was part of Jordan then. And the neurosurgeon in Jordan is practiced at all levels, at all the disciplines. Words of wisdom that have been asked to tell our young generation. I tell them, please remember the giants of medicine. Hippel, Lindau. There are 2 people, not 1 person. Hippel and Lindau. Arnold Chiari, 2 people. We have to know these facts. House Brackman of the facial paralysis. House and Brackman. Mikkel's Cave. Aqueduct of Sylvius. Phenomenon of Monroe. Broca's area. His name is written on Eiffel Tower in Paris. Carl Wernicke. Brodmann's cortical areas. Corbinian Brodmann. Vein of Labey, Charles Labey. And Paget's disease by Sir James Paget. And Perinault syndrome, a French neurologist. Other words of wisdom, I ask them to read from textbooks. Have to choose textbooks to read from all your life, to be your companion till the day you die. I already chose that. I decided that my textbooks would be Yezergil, Roten, Osborne, and pathology books, neurology books, and pathology books, and so on. Don't read from handbooks. Greenberg is a good book you keep in your bucket just to read as you are doing rounds, to just say a few points, but don't make it your textbook. Start your documentation early. I've done that. This is a boy I operated upon back in the year 2000. I followed him out till now, 2021. I followed him as he grew up without radiation, without any shunt procedures, whatever. It is a great pleasure. It gives you great pleasure, and it's happiness, actually, that you feel when you look at these pictures. And also documented every case I treated with cranial angiomas. So every case I do, every case I come across, I document. And when you do discharge summary, please write it in details, not just a flimsy piece of paper. Speak about all the details, put all the information that you need, and the operative notes, they must be typed, not handwritten. So when you do that, it is a high level of performance, which is good for your patient and for yourself. Also, I asked my younger colleagues to start writing papers early in their career. I've been given this advice as a resident, when I was a resident, and I did that. And these are the papers I published in my training, 84, 86, traumatic cavernous fistula, epilepsy after surgery for aneurysm, surgical treatment of cryptic AVMs, and so on and so forth. So when you have these, this would give you the the power that you have these papers under your belt. And for me, because of what these publications have done, I am on the advisory or editorial board of these 7 journals. The medical Jordan Medical Council, Arab Journal, Asian Journal, Surgical Neurology, International Neurosurgery, and World in Neurosurgery. I would not have been chosen to be on the advisory board or editorial board if I did not publish enough. Other words of wisdom to them: travel, visit, and meet the leaders in neurosurgery. I've done that early as possible. I went around the world and visited most of the centers that were famous for certain surgeries so that I would learn more. And those people became my closest friends. Also, I advise you to empower women in neurosurgery. The number of neurosurgeons in the world is little, and the number of women in neurosurgery is very little. So we have to empower women. I've done that already. I've tried my best to empower women from the Arab world and from all of the Arab world, Iraq and Sudan and everywhere, and including my daughter. She was keen on neurosurgery, and she just finished, and she's the first neurosurgeon graduating from the medical services, military services here in Jordan. And here she is visiting Professor Majid Sami. Last words of wisdom: do not give up. The sky is the limit. I came from a poor family. My father was a truck driver. My mother was a housewife. In spite of the difficulties and the hardships that we had, I made my way, so don't stop at all. So back to the presentation, sphenoorbital meningiomas, personal experience. What is the sphenoorbital meningioma? It is sphenoid wing meningioma, but with very specific characters. Sphenoid wing meningiomas with significant tumor extension into the orbit. So this is a distinct subtype, which originates from the dura, somewhere here along the sphenoid wing, and then involve the sphenoid wing, and then go to the orbit to go to everywhere, cavernous sinus, anterior middle fossa, and it is associated either with a carpet-like tumor or a big tumor intracranially. The problem with the sphenoorbital meningioma is that the publications are very few, so it is difficult entity to learn about. This is a famous paper by my friend William Caldwell about the recurrence. This is the difficulty of these tumors, the recurrence, the high rate of recurrence. So this is the pre-op, and this is the post-op, and this is the recurrence after 5 years. So the recurrence is between 5 to 10 years. I also been asked to give some surgical anatomy of the topic. So we are talking about the sphenoid orbital. So we'll talk about sphenoid bone and the orbit, the sphenoid wing with the body, the lesser wing, the greater wing, and here is the pterygoid process, giving pterygoid plates. If you add the ethmoid on it, if you add the frontal bone on it, if you add the maxilla and the palatine bone and the zygomatic arch, then you get the orbit itself. Relationship of the anterior clinoid with the Euro procedures for the sphenoorbital meningioma. You should learn it by heart, the types of anterior clinoid, the aeration, etc. The course of the third nerve into the sphenoorbital fissure, the ophthalmic artery course underneath the optic nerve, the variations of the origin of ophthalmic artery, extradural or intradural, or even it goes through the supraorbital fissure rather than through the optic canal. So all these informations are necessary. This is the orbit, and we have the rule of 7 bones. That's the frontal, the ethmoidal, the lacrimal. Here is the palatine, and this is greater wing of the sphenoid, the zygoma, and the maxilla. 7 bones, 7 arteries, 7 nerves, and 7 muscles, and so on. Rule of 7. This is the supraorbital fissure, and you cannot appreciate the course of the optic canal. You have to rotate it to see it like this. So you have to know these anatomical features by heart. Here is the roof of the orbit, the bone, and the relationship of the orbit with the ethmoid, very close. If you are not careful, you can cause CSF leak. If you are not aware of this relationship, here, if you remove the bone, you will come across the periorbita. Through the periorbita, you can see the frontal nerve, the scapular nerve, the lacrimal nerve underneath the periorbita. And you can, from there, go to the medial compartment or to the lateral compartment. Of course, either you push the superior rectus and levator palpebrae superioris this way, or push it this way to get into your field. This is the view of the skull base and the relationship of the orbit to all that. So here you pull the muscle, you do the lateral orbitotomy, you get into the periorbita and see the lacrimal gland and the periorbita, lacrimal gland, lateral rectus, inferior oblique, inferior ophthalmic vein, and the other anatomical features at the apex of the orbit. Also, the annulus of Zen, the structures passing through the annulus of Zen, the structures that are passing outside. You cannot miss them: frontal nerve, lacrimal nerve, and trochlear nerve with the superior orbital vein. The others are all within the annulus of Zen. And so this is how the apex looks like, the optic nerve and the ophthalmic artery, and the annulus of Zen and the muscles coming out from it. Again, here the superior rectus and levator palpebrae superioris has been removed, the muscles. So we have 7 muscles. In addition, 6 muscles, as you are know: superior rectus, inferior rectus, medial lateral, superior oblique, inferior oblique, and the levator palpebrae superioris. So 7 muscles, 7 arteries, 7 nerves, 7 veins. And you have to appreciate the relationship of the levator palpebrae superioris above the superior rectus when you are operating. And the superior rectus is supplied by the 3rd nerve, the levator palpebrae superioris is supplied by the sympathetic nerves. Also, you have to be aware of the meningio-orbital band, the location of it, and how you open it so that you would reach to the cavernous sinus. And the previous speaker alluded to this in a beautiful fashion. This is the way to open the meningio-orbital band to get into the cavernous sinus, foramen rotundum, foramen ovale, and foramen spinosum. So the relationship of the cavernous sinus with the orbit has to be learned perfectly well, because you will come across these structures. You have to master the anatomy there, and the cavernous sinus is not really difficult once you know it. So the 10 triangles of the cavernous sinus should be known by heart. So back to the personal experience. I have 55 cases, mostly females. Average age is 38. Mostly on the left side for no known reason for me. They were bilateral sphenoorbital meningiomas in 2 patients, as you can see. And 4 of those patients were on hormonal therapy, which, as you know, is one of the causes of meningiomas. And 2 cases had meningiomatosis, that is sphenoorbital meningiomas and other meningiomas. The main presentation in my series was progressive proptosis. Of course, other manifestations like optic nerve involvement, cranial nerves involvement, and seizures were there, but the majority were progressive proptosis. And proptosis, if you look just in the face of the patient, you cannot appreciate the proptosis unless it is massive, like in these cases. So the best thing is to look at the proptosis from the back of the patient, and you just hold the head of the patient, and look tangentially. So this way you can see it because it's big. But if it is small like this, it has to be tangential. And then you can compare it pre-operative and post-operative to know the progress. We do visual feeds, visual score, fundoscopy, ophthalmological assessment for all patients. And we use the German Ophthalmology Society, combining visual acuity and visual defect to get the score. We do OCT, optic computerized tomography, to see the atrophy of the nerve fibers, and we sometimes go for VEPs. We do the assessment of the proptosis by using the Frankfurt plane. And for all my patients having brain surgery, I insist on having psychological assessment, including Karnofsky Performance Scale and others. Images in my series, I'm not going to put any images, I'm just going to put the images of my series. This is the CT scan showing you the extent of the bony involvement, and you can use the 3D to appreciate that. Also, you can want to appreciate the anterior clinoid process aeration, whether it is type 1. Of course, the aeration of the anterior clinoid comes from the sphenoid sinus, and it has 3 types. This is type 1, type 2, and type 3. Because if you want to drill the anterior clinoid, you have to be aware of this variation. You can compare pre-op with post-op to see whether we have done a good job or not. Here we have done a good job removing all the involved bone. Here we have removed the anterior clinoid and opened the optic canal. MRI will show you the extent of the tumor. You can see the dural tail of the tumor. And if you use the Fiesta modification, you can see the tumor in relation to the optic nerve. MRI angiography here shows the ophthalmic artery jumping over the optic nerve laterally and then on top of the nerve to go immediately to be posterior ethmoidal and anterior ethmoidal. Here is different because there is a tumor. Angiography could be conventional, it could be MRA. Venography is the same. Here is just a picture of a beautiful venography by 7 Tesla. I use the isotopes if I'm in doubt. I've used it in 2 patients and it was very useful. The structures involved in my series, I will show it to you. You can find that the tumor is involving the orbital roof, the lateral wall of the orbit, the orbital apex, the severe orbital fissure, as you can see here and here, the anterior clinoid process, optic canal, orbital fat. All of the orbit has been involved in this case. Cavernous sinus involvement, frontal bone involvement, temporal bone, temporalis muscle, completely invaded, and I'll show you some histological slides of that. Subcutaneous tissue, even the skin can be involved. Middle fossa floor, you can see here, you can see that you are going to the foramen spinosum, rotundum, and ovale, and very close to the cavern, to the petrous carotid artery. So the floor of the middle fossa can be involved. Infratemporal fossa can be involved. You have to come through the floor into the infratemporal fossa. You can go to the pterygopalatine fossa, pterygoid process, and plates are involved. As I said, these are all my cases. The sinuses, the air sinuses can be involved: frontal sinus, ethmoid sinus, sphenoid sinus, and the maxillary sinus. Brain invasion can occur. So this is a very aggressive kind of tumor that you have to be careful with. And here, in this miserable case, invasion everywhere. The surgical approaches depend on the type of orbital invasion, which I showed you. So you have to tailor your approach according to that. The main approach I used was terional approach, although I used the others, fronto-orbital and transbasal. I use the image guidance because I do believe that osseous tumor is difficult to distinguish sometimes from healthy bone intraoperatively. So image guidance would help you. Here we're using it in one of those cases. The principles adopted in the surgery of sphenoorbital meningiomas basically are extradural approach, intradural approach, and reconstruction. For extradural approach, you have to drill anterior clinoid process, open severe orbital fissure, open optic canal, rotundum, ovale, and then you go to the periorbital and intraorbital, all this extradural, and then you can do the clinoidectomy extra or intradural. The steps of surgery, I'm showing you some still pictures from my series. This is the craniotomy, and sometimes the bone is invaded, so you have to drill it. So you drill the greater wing of sphenoid until you come very close to the anterior clinoid process. You cut the meningioorbital band. You cut the middle meningeal artery from the spinosum. And then you go from an ovale here, from an ovale, and from a rotundum. And then you go to the cavernous sinus. Here you're checking with the Doppler that we have reached to the petrous carotid. And then you open the roof of the orbit. When it is involved, you get to the periorbita. You open the severe orbital fissure. You drill as much as you can from the anterior clinoid process. Here you have opened the severe orbital fissure. And then you go into the periorbital, open it if it is involved, go into the orbital content and excise the involved tissues. And sometimes you cannot tell which of which, so putting the stitch in the lateral rectus and pulling on it can help. And this is the tumor that had been removed from inside the orbit. And then you go into the intracranially, open the dura, and then you get into this tumor, and then relationship of this tumor to the vessels, middle cerebral artery, anterior cerebral artery, optic chiasm. So this is a case where the carotid artery, anterior cerebral, middle cerebral, and this is tumor involving all this. And then you can go intracranially, open the anterior clinoid process, open the dura over the anterior clinoid process, drill the anterior clinoid process, remove the last piece, and then you are on the roof of the cavernous sinus, seeing the clinoidal segment of internal carotid and distal ring. And then you open the falciform ligament. So this is opening the canal. After opening the falciform ligament, you can see the canal, the optic nerve in the canal, and intracranially, this is the carotid. This is the right side, the nerve is here. This is tumor still around it. And this is the carotid ophthalmic artery surrounded by the tumor, lateral, medial to the optic and lateral to the optic. And then removal of the dura involved by the tumor and the tuberculum celli. And then finding all the tumor tissue on this triangle. Internal carotid, anterior choroidal, posterior communicating, and so on. So this is the final picture. The cavernous sinus wall, the sphenoparietal sinus, the middle cerebral vein, superficial, pecum, icon, and optic nerve. Reconstruction is either for the orbit or for the dura or for the bone. If there is no periorbital resection, there is no reconstruction. Periorbital resection, you may need rigid reconstruction. People here differ, controversy about this. Many authors like Maroon, De Monte, Talashi said in 200 cases in Maroon, 56 cases De Monte, 47 cases, there's no need for rigid reconstruction. However, some people do, and these are the material used in this reconstruction. Dura either closure directly or using a graft, dermis patch, fasciolata, dura sealant. You may add fat graft on top, and then you do the bone reconstruction using the titanium mesh. This is one of the cases that we have done. So titanium mesh for reconstruction of the bone. Grade 1 in my series was the majority, 32 cases, but grade 3 were 3 cases. And this is grade 1 cases. You do all the immunostaining. Sometimes you will find bone invasion that doesn't make it worse. And here in this grade 3, the tumor is invading the bone completely. And here the tumor is invading the brain directly. And here you can see meningioma cells within the skeletal muscles. We published this paper in the American Academy for Pathology about our last consecutive 250 meningiomas, and we have found that the higher Ki is the worst prognosis, the higher P53 is the worst prognosis, and the lower progesterone is the worst. And we found that in males, the category 3 was more than females. Vision result. Some people did not have any change in their vision. 3 patients got worse and 30 improved. And again, as I said, you can compare the proptosis before and after, but usually proptosis is the best to improve. Ocular paresis is less, 40%. I had no mortality in my series. I have achieved gross total resection in 34 cases, subtotal resection in 21. I had 15 recurrences, 3 recurrences in the gross total, 12 recurrences in the subtotal, and those occurred within 3 to 10 years. What did we do with the recurrences? The 15 cases we observed, we don't jump on them immediately. We found that there is no progression in 3 cases, while there was progression in 12 cases. We used gamma knife in 2, conformal radiotherapy in 3, surgery followed by radiotherapy in 3, 4 patients refused any further surgery. As been said that we have acquired the first gamma knife in the Middle East and Africa back in 96, and I've treated the first 10 cases then. Some of the illustrative cases, then I'd finish. This is the bilateral sphenoorbital meningioma, medial and lateral. Sorry, this is unilateral. Sorry, this is one-sided sphenoorbital meningioma. She had recurrence here. I followed her up for 8 years, and she had no progression, and I gave her no radiation whatsoever. Complications in my series, usually oculomotor nerve is affected, temporary in 3, permanent in 1, deviator palpebral, timber in 3, permanent in none. And this is an example of the ptosis that occur postoperatively and the recovery. In this case, ptosis and recovery. So we wait on them for 3 to 4 months and they recover. The usual complication of any craniotomy, the subgaleal collection, wound infection, CSF fistula, etc. Extradural abscess, venous infarction, CSF leak. Variations of radiotherapy and radiosurgery that has been used according to your requirement. And this is the gamma knife, as I said. Some of the cases, this is the bilateral sphenoorbital meningioma. It was more on the right side, so we operated on the right side. We left this for observation, and we've been observing here for many years without any problem. You can see how much bone involvement is there. And this is the post-op, very good results. Opening of the optic canal and removal of the anterior clinoid process. And 9 years follow-up did not show any recurrence, did not show any further increase on the left side of the sphenoorbital meningioma. Another case from Iraq with this large sphenoorbital meningioma. And this is the post-op and follow-up for years. Another case from Yemen with this extensive tumor. You can see that the intracranial component is very large. So it is not always the in-plaque meningioma. It can be a very large component. So we did the surgery for her, and here she is, post-operative. Another case with this, again from Iraq, with this extensive tumor, which we treated and successfully excised. Another case with this extensive tumor, again, we've done as maximal resection as possible, and then we gave her Novalis radiosurgery, and we followed her for 7 years without any recurrence. I'm not going to show you the videos for the sake of time. I'm going to give you the conclusions. I believe that aggressive removal of sphenoorbital meningioma is critical for a favorable outcome and tumor control. Residual tumor in the orbital apex cavernous sinus remains a problem. For this, you give radiotherapy. Thank you for listening, and I'm happy to take your questions.
Thank you very much, Prof. Ibrahim. A very interesting talk there. Alberto, is there any questions?
So I think we have time, limited time for questions, at least organizers told us. So maybe we can accept one question, maximum one question for each of our speakers. If there are questions from the audience. I have a question. Okay, I can see a raised hand. Please.
Hello, good morning, Professor Ibrahim, Professor Tanikawa. Greetings from Ecuador. First of all, it was an excellent lecture, an outstanding lecture, very didactical, and I really appreciate that you can share your experience with us. I had a question. I think that there is now a trend to try to embolize meningiomas to facilitate removal. And we know that these kind of meningiomas get their blood supply from anterior, posterior ethmoidal arteries, and maybe some branches from PCOM. And has been demonstrated that there are a lot of complications with preoperative embolization. I was wondering, in your experience, in what cases would you recommend to actually do a pre-op embolization?
Right. Let's take embolization in general for meningiomas and then apply this for the sphenoorbital meningiomas. Basically, maybe 80% of applications are against embolization of meningiomas, including meningioma people like Nifty and Coldwell and the others, or some people would advise embolization. I only give embolization for meningiomas in general when there's really very huge blood supply that I want to decrease. But for sphenoorbital meningiomas, and you said is exactly the reason why you shouldn't, It's most of the blood supply is coming from the ophthalmic artery via the anterior and posterior ophthalmic arteries. And if you embolize, you can have the risk of blindness because of closure of the central artery of retina supplied by the ophthalmic artery. I've never used embolization in the sphenoorbital meningiomas. I've used it in very few cases, either in parasagittal meningiomas or clinoidal meningiomas also.
Thank you, Professor Sbey. We have time for one question for Professor Tanikawa. If nobody has, I have many, but I can ask one question to Professor Tanikawa. I was very impressed by the possibility you have shown us to do suture, microsurgical suture also for veins. About the case you showed, before cutting that vein, the bridging vein, you placed temporary clips and just to make sure there was a compensation flow. So why, if there was a compensation flow, you decided at the end of the surgery to suture that vein? More generally, my question is, how often do you think it is really necessary to suture veins? Thank you, Professor.
Yeah, thank you. It's a good question. Yeah, basically, the original structure is the best. But during surgery, we can confirm whether the original structure can be sacrificed or not by such examination like IC green angiography, something. Of course, without reconstruction at the end of the surgery, in that case, nothing happened. But if, for example, nothing happened. But the one reason why I reconstructed is that is a good training for us. And the end-to-end anastomosis of veins is not easy, and such an opportunity is very rare. Even for me, that type of reconstruction is very rare. I have a very limited several cases, not so much. So I wanted to do that.
Yeah, it was a good opportunity.
Yeah. So, but if the IC green shows no collateral risk, absolutely we have to do that.
Okay, thank you very much, Professor.
Thank you very much. That's the reason why. Yeah.
Thank you very much to both our speakers. Sharon, if you want to have some closing remarks.
Yeah, thank you very much. I think both presentation was exceptional, very eye-opening for the young neurosurgeons. I think very good coordinated kind of presentation. Thank you so much, Prof. Takinawa and Prof. Ibrahim. It was so great to have you in our live session today.
It's my pleasure.
Thank you.
Thank you.
Okay, bye.
Bye-bye. Thank you. Thank you very much.
Hello dear friends of Zimbabwe and Congo. I'm Kazumichi Yoshida from Kyoto, Japan. First, I'd like to show my deep appreciation for Professor Karangu and Kato to give me an opportunity to present my work in this ACNS webinar. I graduated from Kyoto University Medical School in 1994, then started neurosurgical residency. Since 2020, I'm an associate professor. This is the clock tower of Kyoto University, and they are the members of Kyoto University neurosurgical team. Now Tokyo is the capital of Japan, but Kyoto is a former capital of 1000 years from 794 to 1868. In spring, there are beautiful cherry blossoms along the walkside near the Kyoto University Hospital. This photo shows one of the major summer festivals in Japan. And this is an old temple with beautiful colored leaves in autumn. Kyoto City is covered with snow in winter. Anyway, I'm looking forward to having a chance to welcome you, friends in Zimbabwe and Congo in future after this COVID-19 pandemic. I was requested to give message to my friends, young neurosurgeons in Africa. So I think to become a good neurosurgeon, training for surgical skills and study for surgical anatomy are surely essential. But I think most important point is attitude to your work or your profession. Please always treat your patient as if they were your family. Thank you. So start my presentation. Today, I'd like to talk about carotid endarterectomy CEA technique aiming for zero ischemic complication. First, I will talk about brief history and current guidelines of CEA for carotid artery stenosis. Then, I will show basic procedure for CEA. And finally, I will demonstrate tips of CEA for zero ischemic complication. CEA is a long-established vascular surgery, and this slide shows the first case report by Professor Dobeki, famous vascular surgeon of Baylor College of Medicine in the United States. This case report was published after a 19-year follow-up of no recurrent ischemic stroke due to the left carotid artery stenosis. Then, what patients receive benefits from CEA? Let's see current consensus of indication for CEA. This slide shows the guideline for managing patients with symptomatic carotid artery stenosis, published in 2018 by European Society of Vascular Surgery. CEA is recommended for symptomatic high-grade stenosis. However, perioperative complication rate should be below 6%. And also, CEA should be considered in patients with symptomatic moderate stenosis. Next, let's see the guideline for asymptomatic carotid artery stenosis. The indication of CEA is somewhat different between symptomatic patients and asymptomatic patients because medical treatment for asymptomatic patients have been strikingly improved in the recent 20 years. Therefore, the guideline says indication of CEA for asymptomatic patients should be considered carefully. So, for asymptomatic patients, CEA should be considered if patients not only have moderate to high-grade stenosis, but also have imaging characteristics suggesting high risk for future ischemic stroke. Imaging features suggesting high risk for future ischemic stroke include CT or MRI detected in ipsilateral silent infarction, ultrasound detected stenosis progression, large plaque volume, predominantly echolucent plaques, and MRI detected intraplaque hemorrhage, and so on. I'd like to move on to the next topic. I illustrate basic procedure for CA in the following slides. Not only CA, but in all surgeries, securing shallow and wide operative field is a basic point for safe procedure. The skin incision for CA is demonstrated in the left figure. The dashed line is recommended in the many traditional textbooks for CA. I prefer solid lines because it is easy to dissect between parotid gland and sternocleidomastoid muscle, SCM. To gain wide operative field, I think it is most important to dissect the SCM along the anterior margin over the entire length of the skin incision in the early stage of CA. In dissection from the proximal part of the SCM along the anterior margin to the distal portion, pay attention not to cut into parotid gland, and dissect precisely between parotid gland and SCM. This is the case with right side carotid artery stenosis. This is SCM, and this is a greater occipital nerve. This is parotid gland. White vessel tape is pulling up the common carotid artery, the yellow vessel tape, external carotid artery. The two-stage lifting method is very useful to gain a shallow and wide operative field. Two-stage lifting method consists of, first, tie between carotid cyst and the skin with surgical sutures, and second, pull up the skin with a surgical retractor. Then carotid artery is lifted, and it makes easier for the following CA procedure. From skin incision to securing of carotid arteries, I perform CA macroscopically and uses operative microscope for the following steps. I'd like to show macroscopic procedure from skin incision to carotid artery exposure with operative video for left carotid artery. And now dissecting the carotid cyst superior thyroid artery, and this is external carotid artery. Also, carotid cyst of ICA, internal carotid artery, and skin is tied with surgical sutures. Now finally, now securing the distal internal carotid artery. And the cross clamping is completed. Now you can see the two-stage lifting method is useful to gain a wide operative field. And now cutting the vessel wall and dissect vessel wall and the plaque. Carefully dissected between the plaque and the vessel wall, not to injure the vessel wall itself. And now removing the plaque. The stamp of the plaque is as far and also as neatly as possible. Primary closure of the carotid artery is completed by running sutures from the both sides. And first, the crimp of the superior thyroid artery is released, and each crimp is transiently released to wash out possible debris to superior thyroid artery. Finally, ICG video angiography is performed to confirm the good patency. When removing the plaque, the ideal dissection planes between plaque and media, but part of the plaque often embedded into the media itself. So in the dissection of the plaque, the point is to keep in mind that media with circular fibers should be preserved in the vessel wall as far as possible. I'd like to demonstrate again the ideal dissecting plane with successive intraplaque pictures. This is the circular fibers of media. When you wonder where to dissect, you should preserve these circular fibers to vessel wall. The stump of the plaque is sharply cut with micro scissors. It is especially important for distal plaque end in the internal carotid artery to avoid post-operative thrombotic complication. slight difference in the level on the lumen can be eliminated by weak bipolar cautery. If you dissect the plaque in the ideal plane, the plaque is removed with a smooth transition like upper pictures. However, when you go deeply into media, like lower pictures, you will leave somewhat large difference in the level on the lumen. After primary closure of the carotid artery, the following procedure is macroscopically performed. Now closing carotid cyst with absorbable surgical sutures. Then suture the sternocleidomastoid muscle. And now suturing together the divided platysma muscle. And finally, doing a subcutaneous suture with absorbable surgical sutures. So this is a final view of left carotid endarterectomy. This is a picture obtained 6 months after the surgery, and you can see the obscure skin incision. I'd like to move on to the final topic, surgical tips for zero ischemic complication. The benefit of CEA for carotid artery stenosis has been widely proven by several major clinical trials, but the absolute benefit of CEA is limited by the morbidity and mortality. One of the leading causes of complications is ischemic stroke during CEA. Major causes of ischemic stroke are hypoperfusion during cross-clamping and embolic infarction during surgical procedure. Hypoperfusion in patients with insufficient intracranial collateral circulation can be dealt with by using shunting. Concerning measures against embolism during CEA, it is often emphasized that meticulous surgical dissection is very important, but there have been few papers describing concrete risk reduction measures against embolism. Before presenting my thoughts regarding surgical tips against distal embolization, what step during CEA carries the highest risk for distal embolization, or when should we take great care for prevention of embolism during CEA? Studies of transcranial Doppler monitoring during CEA offer valuable insight into this question. Wolf reported that the rate of microembolic signal at each step during CEA was 97% during the clamping, 69.7% with shunting, and 45.5% with surgical dissection of the internal carotid artery. But significant correlation between microembolic signal and postoperative diffusion-weighted image regions was found only with dissection. So he describes the step of surgical dissection of the internal carotid artery as the most vulnerable stage of CEA. Based on the report about transcranial Doppler monitoring, I thought that early flow control of the carotid artery will be effective for prevention of embolization during internal carotid artery dissection. This slide shows the surgical procedures of conventional CEA and so-called flow control CEA. This gray shaded area illustrates the carotid sheath. In conventional CEA, cross-clamping is established after entire carotid sheath covering common carotid artery, external carotid artery, and internal carotid artery is dissected. On the other hand, in flow control CEA technique, proximal common carotid artery, superior thyroid artery, and external carotid artery are carefully dissected then clamped. Special attention is paid not to extend surgical dissection over the internal carotid artery at this stage to avoid great stress on the internal carotid artery enclosing fragile plaque. Then exposure and isolation of distal internal carotid artery was completed under flow control by proximal vessel clamping. This picture shows a setup of CEA for left internal carotid artery stenosis. I use an internal shunt selectively depending on the intraoperative dual monitoring of near-infrared spectroscopy and somatosensory evoked potentials. I'd like to show flow control CEA with operative video. First, superior thyroid artery is clamped. Then common carotid artery is clamped. And this is external carotid artery. After flow control by proximal vessel clamping is established, then start internal carotid artery dissection. And now the cross clamping is completed. This is another case of flow control CEA with an internal shunt. Now proximal vessel clamping is completed, then start the dissection of the internal carotid artery. During IC dissection, the amplitude of somatosensory evoked potential monitoring reduced to 30% of the control level. Then I decide to use an internal shunt at this point. Now cross clamping is completed. Then small incision is made on proximal common carotid artery and distal internal carotid artery. And now introducing an internal shunt. Then blood flow in the internal shunt is confirmed by ICG video angiography. Study for post-operative new infarct of my consecutive 67 CEAs consisting of 29 conventional CEAs and 38 flow control CEAs. There was no symptomatic infarct, and asymptomatic diffusion-weighted image lesions were found 7 of 67 CEAs, approximately 10%. As shown in this figure, most of the asymptomatic DWI lesions were a small high-intensity spots in the ipsilateral hemisphere. Postoperative DWI positive rate in patients with conventional and flow control CA was 20.7% and 2.6% respectively. These results apparently show the benefit of flow control CA against intraoperative embolization. Today, I presented 3 topics for CA. First, the brief history and current guidelines for CA, and I showed basic procedure for CA. And finally, I demonstrated surgical tips aiming to zero ischemic complication, that is, flow control CA. This is a garden in an old temple in Kyoto City in this season. I hope this chaotic situation by COVID-19 pandemic will end as soon as possible, and I'm looking forward to talking with you African friends in person in near future. Thank you for your attention.
There are many crucial steps for successful clipping surgery for cerebral aneurysm, from preoperative planning by imaging studies to cranioplasty and skin closure. Because of the time constraints, I would like to focus on these steps this time. Number 9. Complete exposure of the aneurysm by detaching adhesions between aneurysm and surrounding structures. Number 10. Appropriate selection of clips for each aneurysm. And number 11. Precise clip application to the optimal closure line for each aneurysm. If you have this situation, clip application to the neck of the aneurysm is a straightforward procedure, but it is supposed to be a rare case. Dome of cranial aneurysm adhere to the surrounding structures, including dura mater, cranial nerves, and normal vessels, especially in large or giant aneurysm. For appropriate clip application and avoiding branch stenosis or nerve dysfunction by tension, these adhesions should be detached in many cases if possible. Professor Hadeishi reported how to detach the fibrous adhesion. They are consist of 3 steps. First, dissect the loose adhesion in the center using jeweler's forceps to make space. Second, pinch the tight adhesion at the margin of emboss, the fibrous adhesion. Finally, sharply inside the embossed adhesion with micro scissors. Detaching the adhesion between nerve and aneurysm is also possible by this technique. I will share with you the techniques using my video afterwards. Each aneurysm has an orifice from its parent artery. Clipping of aneurysm is aimed to obliterating the 3-dimensional orifice of the aneurysm and recreating the curved or straight line with the base of the aneurysm clip. We call the line ideal or optimal closure line. Professor Ishikawa classified the ideal closure line of MCA aneurysm into 3 groups: the bifurcation type, the truncal type, and the combined type. The bifurcation type is the most common type in MCA aneurysm. This type originated from the curved linear cleft at the bifurcation of the arteries, with an orifice forming a deeply curved rhombus. In this case, we should apply aneurysm clips in perpendicular fashion to the arteries. Of course, one clip is enough in some cases. The second type is truncal type. This type appears to originate from loss of tunica elastica on one of the afferent arteries, with an orifice forming the flat rhombus on the parent artery. In this case, we should apply aneurysm clip in parallel fashion to the arteries. Of course, one clip is enough in many cases. The third type is the combined type. In this type, the growth of the aneurysm destroys the tunica elastica of the continuous vessels with a subsequent enlargement, with an orifice forming a curved trapezoid. In this case, we should apply clips in cross fashion. We must know the aneurysm clipping closing forces. The most important component of aneurysm clip selection is subjective preference, though objective decisions based on the closing force may be relevant. Professor Hongo reported the closing forces of all of tested clips linearly increased from tip to base of the clip brace. So you should know that an incomplete closure of the far side neck would happen when you use a long clip for a large aneurysm. And you should know not straight clips are weaker than straight clips. We must know those characteristics of each clips and use appropriately considering the closing forces. Clipping for recurrent aneurysm after initial endovascular coembolization is technically challenging. Dissecting and clipping of small aneurysm with sufficiently large neck remnant is a straightforward procedure. On the other hand, in larger aneurysm, the fundus is thrombosed and mechanically enforced by the coil mass and sclerotic wall, rendering manipulation and exploration more difficult. Like case above, despite angiographically sizable neck remnants, collapsing the aneurysm wall at the neck and clip application can be very difficult. Previously coiled aneurysms are difficult to clip, partly because coil loops and mass inside can prevent the clip brace from complete closing. There must be residual flow in the aneurysm after a single clip is applied, because of inadequate closure of the far side neck by the obstacles. Hence, a tandem clipping method using a fenestrated clip in combination with another type of clips is a useful technique for complete closure. The former can be applied for closure of the far side neck, the latter for the near side. When you apply an aneurysm clip to the neck, you should make a fine adjustment for appropriate application to its optimal closure line. Professor Takanori Fukushima introduced the 5D application technique of the aneurysm clip for me. In this case, D does not mean dimension, but direction. First, you go with clip in and out. Second, left and right. Third, up and down, including blade tip up and blade tip down. And clockwise and counterclockwise rotation around the clip axis. And around the neck of the aneurysm. We should do a fine adjustment with this 5D application using adequate time. I usually spend for 3 minutes on average for each clip application. Here is a case study. A 57-year-old woman presented with unruptured right MCA aneurysm. Her preoperative CT angiography and intraoperative finding revealed the aneurysm type is a bifurcation type. The first straight standard clip was applied in perpendicular fashion to the parent artery. This results in dog-ear residual neck. Therefore, a second clip was placed under the primary clip. The post-operative imaging studies revealed complete obliteration of the aneurysm and no complication. Here is another case. A 66-year-old woman presented with unruptured right MCA aneurysm. Her preoperative CT angiography and intraoperative finding revealed the aneurysm type, the truncal type. The first standard curved clip was applied in parallel fashion to the afferent artery. In this case, one clip was good enough for complete closure of the neck. The post-operative imaging studies revealed complete obliteration of the aneurysm and no complication. A 65-year-old woman was diagnosed with unruptured ACOM aneurysm. Her preoperative CT angiography and intraoperative finding revealed that the aneurysm originated from right A1-A2 junction. You see hypothalamic artery branching from right posterior of the neck of the aneurysm. The first lateral angle clip was applied in perpendicular fashion to the A1-A2 junction. Visual inspection revealed small residual neck in posterior part, so I performed a fine adjustment using 5D application method. This results in dog-ear residual neck in anterior aspect. Therefore, a second L-shaped clip was applied under the primary clip, result in complete closure of the neck. The post-operative imaging studies revealed complete obliteration of the aneurysm and no complication. This 55-year-old man was diagnosed with ruptured ACOM aneurysm. Because his preoperative CT angiography revealed the aneurysm relatively high-positioned one, so we selected anterior interhemispheric approach in this case. You see the hypothalamic artery branching from left side of the neck of the aneurysm, and careful inspection revealed the tight fibrous adhesion was located between the dome and the perforator. First, we dissect and pinch the fibrous adhesion in the center with microforceps in order to emboss the adhesion and the temporary occlusion of right A1. Then, the embossed adhesion was inserted sharply with micro scissors. The first standard straight clip was applied in perpendicular fashion to the right A1-A2 junction. This results in dock-ear residual neck. Therefore, a second angle mini clip was placed under the primary clip, resulted in complete closure of the neck. The post-operative imaging studies revealed complete obliteration of the aneurysm and no complication. A 52-year-old woman presented with unruptured left IC-PCOM aneurysm. Intraoperative findings revealed the tight adhesion between the dome and the left free edge of the tentorium. Under proximal control of the left ICA, the tight adhesion was dissected by incising the tentorium side along the edge. The dome was freed from the free edge of the tentorium using the micro scissors. After the procedure, the straight standard clip was applied in parallel fashion to the PCOM. The post-operative imaging studies revealed complete obliteration of the aneurysm and no complication. A 61-year-old woman presented with unruptured left IC PCOM aneurysm. Intraoperative findings revealed that the head of the aneurysm dome moderately compressed the right oculomotor nerve. The dome was carefully detached from the oculomotor nerve by sharp dissection using micro scissors, and the valve was detached by blunt dissection. After the procedure, a standard straight clip was applied in parallel fashion to the PCOM. Her post-operative course was uneventful, without oculomotor nerve palsy. The post-operative imaging studies revealed complete obliteration of the aneurysm and no complication. A 70-year-old woman presented with unruptured left BASCA aneurysm. We decided subtemporal approach in this case. We made a stitch between free edge of the tentorium and middle fossa dura. This procedure enabled us to gain a good surgical corridor to the basilar artery for proximal control. The dome was carefully detached from right oculomotor nerve by blunt dissection with microprobe and microforceps. Under temporary occlusion of the basilar artery, the adhesion between dome and perforator was carefully detached. First, we dissect and pinch the fibrous adhesion in the center with microforceps in order to emboss the adhesion. Then the embossed adhesion was incised sharply with micro scissors. After the procedure, the bayonet clip was applied in parallel fashion to the afferent artery. The visual inspection revealed a complete closure of the aneurysm with preservation of perforators and the afferent arteries. She experienced temporary oculomotor palsy, but recovered completely. The post-operative studies revealed complete obliteration of the aneurysm without complication. A 52-year-old woman presented with unruptured left BASC aneurysm. We decided subtemporal approach in this case as well. The first light curved clip was applied in perpendicular fashion to the afferent artery. And this results in a dog ear residual neck in the posterior aspect. Therefore, a fenestrated right angle clip was placed across the primary clip. Visual inspection revealed small residual neck, so I performed fine adjustment and this resulted in complete closure of the neck and preservation of perforators and the afferent arteries. Her post-operative course was uneventful without oculomotor palsy. This case has recurrent right PCOM aneurysm after initial coil embolization. Coil mass inside the aneurysm was seen through not only the wall of the dome, but the wall of the neck. First, we applied straight type titanium clip, but the tip of this clip slipped toward to the PCOM, so we removed this clip. Then we applied fenestrated elysial clip in partial occlusion of the neck. ICG video angiography revealed a patency of ICA, PCOM, and anterior choroidal artery, and non-filling of the aneurysm dome. We added straight clip in parallel fashion to secure the complete obliteration of the aneurysm. A 48-year-old female was brought to our emergency department with disturbance of consciousness. The computed tomography revealed a diffuse subocular hemorrhage lateralized to left sylvian fissure. The CT angiography showed left anterior wall C2 aneurysm. The patient was diagnosed with ruptured left C2 blister aneurysm. Nowadays, we treat this kind of patient by ECM2 bypass using radial artery graft followed by trapping of the aneurysm, though we decided direct clipping in this case. We thought the clip-on wrapping method would work because the aneurysm projected anteriorly and laterally. We exposed the aneurysm completely and we put Teflon tape around the ICA. And we applied L-shaped clip to the aneurysm together with the Teflon tape, which avoids slipping out of the clip and blowing away the blister aneurysm. The Doppler revealed the good preservation of antegrade flow of the ICA. Her post-operative course was uneventful, without symptomatic vasospasm. The post-operative imaging studies revealed the complete obliteration of the aneurysm and no complication. A 62-year-old male presented with our emergency room with right-hand paralysis. The diffusion-weighted image revealed a lacunar infarction on left paramedian pons. The MR angiography showed partially thrombosed fusiform basilar trunk aneurysm. We decided to follow up by starting antiplatelet therapy. 3 days after admission, he suddenly fell into coma, and CT at that time showed subarachnoid hemorrhage, which was especially thick in right prepontine cistern. We performed bilateral ventricular drainage as neuroresuscitation. His conscious level gradually recovered. Cerebral angiography at that time revealed fusiform basilar trunk aneurysm, which under BREP on right superior aspect. So we determined from the imaging studies that subarachnoid hemorrhage was caused by the rupture of the BREP of the aneurysm. We decided to perform direct clipping surgery through anterior petrosal approach in aim to avoiding re-rupture of the aneurysm. We performed drilling right petrous apex, the rhomboid. We exposed the aneurysm, right ICA, proximal basilar artery, right SCA, and distal basilar artery. After the temporary occlusion of the basilar artery, we applied the long straight clip in parallel fashion to the basilar artery and occluded the rupture point. And then we applied the fenestrated straight clip parallel to the first clip in order to enforcement of closing force at far side of the closure line. At last, we applied the straight clip in parallel fashion to the previous clip for reinforcement of the closure at the near side. This resulted in occlusion of the rupture point and preservation of parent artery and branches, including important perforators. His post-operative course was uneventful without symptomatic vasospasm. The post-operative imaging studies revealed complete obliteration of the rupture point and no additional complication. As I mentioned at the beginning of my talk, there are many crucial steps for successful clipping surgery for cerebral aneurysm. Today, I presented the steps just around the aneurysm, how to expose the aneurysm completely, appropriate selection of clips, and concept of optimal closure line. I'll be glad if this presentation is of help to anyone. Thank you for your attention.
Hello, everyone. My name is Yasushi Takagi from Tokushima University, Tokushima, Japan. My theme is surgical management of AVMs. I'd like to start my presentation. This is my CV. I graduated from Kyoto University and 2017 I moved from Kyoto University to Tokushima University. Tokushima is located in Shikoku Island. Shikoku means 4 districts. Tokushima City is located near Kansai district. This is the landscape of Tokushima. Tokushima City is famous for Bizan Mountain and summer festival. Our Odori Dance Festival is very famous Japanese summer festivals. In the suburb of Tokushima, Naruto City is famous for fire pools. On the mountainside district, Oboke Valley is very beautiful place. Tokushima is originally famous for Japanese indigo around 100 years ago. So I want to move to my topic. This is a schema of pathology of AVMs. See, this is superficial drainer, and this vessel superficial feeder, and around the needle, parial feeder, and this vessel mean deep drainer. This is historical milestones in the treatment of AVMs. Preoperative embolization is developed from 1950s, and microsurgery is developed firstly on 1960s. Stereotactic radiosurgery is started on 1960s. We now using these modalities to treat AVMs. So this is a pathological aspect of surgical treatment for AVMs. See, this is the normal brain. Here is a drainer of the nidus. So we have to dissect these brains, AVMs from brain tissue. Thus, minimum neural injury is required. This yellow line is ideal dissection line. Based on HA scientific statement, surgical indication is described here. The discussion of treatment options with patients should include consideration of these risks weighted carefully against relative risk of different intervention strategies and life expectancy. I think the surgical concept of AVM, that dissection and removal of a very hemorrhagic vascular region from normal vascular component using gliotic brain tissue with minimum normal neural injury. We think important points during surgery is one is control of hemorrhage and the other is protection of eloquent area. So we want to focus on pre- and intraoperative imaging assistance in the surgical treatment of AVMs. We use three-dimensional analysis software to assess the three-dimensional component of AVMs. We now use Synapse Vincent softwares. This is a 3D fusion image using Amira software. Using this software, we can make these images from 3D DSA and MRI. So, based on these images, we can realize relationship of feeder and nidus. This is a 3D fusion image. Preoperatively, we can recognize 3D relationship, feeder, nidus, and drainers. So, using these modalities, we think important points is that location of feeders entering points in the nidus and extent of nidus in the white matter. We usually use preoperative embolization before nidus removal. We perform preoperative embolization 1 day before direct surgery. We request interventional radiologist to deep feeder should be embolized, and then protection of eloquent areas. About craniotomy, a large craniotomy is necessary because of during surgeries often occurs brain edema, and we have to dissect or define the area of nidus, so large craniotomy is necessary. During surgeries, we prepare non-stick bipolar coagulator. We think secure coagulation of tiny feeders like this in white matter is very important during AVM surgeries. In addition, intraoperative blood flow assessment is important. ICG video angiography, portable DSA. Now we can use hybrid operation room. ICG video angiography using Kinebo microscope. Using these modalities, we can recognize reduced blood flow in the nidus and drainer. Using ICG, intraoperative angiography can confirm complete nidus removal in the deep white matter and ceased blood flow of drainer. This is the steps of AVM surgery. We can seize AVM nidus. Firstly, we dissect arachnoid and confirm drainer and feeder. Firstly, we clip superficial feeders to reduce blood flow in the nidus. Then we confirm using ICG video angiography nidus flow. Then we start to dissect the superior part of the nidus. This is the nidus dissection. And finally, we coagulate drainers. We remove the nidus. So, based on operative findings, we can decide the extent of dissections. In this figure, about compact nidus, we can easily set the extent of dissection. But this AVM have diffuse part. We can set the extent of dissection or based on angiography and operative findings. We published several papers about usefulness of ICG video angiography. This paper we published in Neurosurgery Journal 2012 about IV ICG. This is about IA ICG published in Journal of Neurosurgery on 2020s. Using IA ICG, we can get several time point of ICG image because of early washout. This is a video of IV ICG. If the nidus is buried in the brain parenchyma, we can assess nidus blood flow or confirming flow speed of drainer here. This image is about transarterial ICG video angiography. From CCA, we can see the feeders from CCA. From VA transarterial ICG video angiography, we can see the feeders from VA. Then we introduce illustrated cases. Case 1, 43 years old unruptured cases. This case is related to first confirm the we highlight This is operative video. Firstly, we clip feeders to reduce blood flow in the nidus. Confirm the nidus flow based on ICG video angiography. Then we started dissection of the nidus. No flow in the nidus. Then we can remove nidus without hemorrhagic complications. Case 3 is 23 years old ruptured case. This is grade 4 AVM. This is operative video. Firstly, we confirm the nidus flow based on ICG video angiography. And we coagulated several feeders to reduce blood flow in the nidus. Then we start to dissect nidus. See, this tiny feeder hematoma cavity was opened. Finally, we clip main drainers and coagulate. Case 4 is 13 years old ruptured cases, grade 3 AVMs. Firstly, we confirmed nidus blood flow using ICG video angiography. This is the nidus of AVMs. Decreased blood flow in the nidus was confirmed. Finally, main drainer was clipped and removed the nidus. So this is my take-home messages. In the surgical treatment of AVMs, control of hemorrhage and protection of eloquent area are essentials. Assessment of blood flow in the nidus and understanding of three-dimensional construction of nidus help us to perform safe surgeries. Thank you for your attention.
My name is Kojiro Wada from National Defense Medical College, Japan. I'm talking about moyamoya disease. It's very popular in Japan and Asian people, and it's bypass surgery today. Moyamoya disease is a cerebrovascular disease in which the carotid artery in the skull becomes blocked or narrowed, reducing blood flow to the brain. Tiny blood vessels then developed at the base of the brain in an attempt to supply the brain with blood. The condition may cause a transient ischemic attack, stroke, or bleeding in the brain. It can also affect how well the brain functions and cause cognitive and developmental delays or disability. Moyamoya disease most commonly affects children, but adults may have the condition. Moyamoya disease is found all over the world, but it's more common in East Asian countries, especially Korea, Japan, and China. This may possibly be due to certain genetic factors in those populations. Moyamoya disease is characterized by diagnostic angiography showing progressive stenosis and or occlusion in the terminus portion of the intracranial intercarotid artery and development of a network of anastomosic collaterals at the base of the brain. Moyamoya disease was named after the pathognomonic appearance of the angiographic findings. Moyamoya disease occurs at an incidence of 0.54 people per 100,000 population in Japan. The disease is more common in female. The male-female ratio reported 1 to 1.8. As genetic factor, RNF213 or GCCY1A3 are reported. Familial moyamoya disease reported 10%. A bimodal peak consisting of a major peak in the first decade of life and a moderate peak in the late 20s to 30s. In children, ischemic type is more popular than hemorrhagic type. Different symptoms in adults and children. In children, the first symptom is usually a stroke or recurrent transient ischemic attack. Accompanying signs and symptoms related to reduced blood flow to the brain include headache, seizures, weakness, numbness or paralysis in face, arm or leg, typically on one side of the body, visual disturbances, difficulties with speaking or understanding others, cognitive or developmental delays, involuntary movements. These symptoms can be triggered by exercise, crying, coughing, straining, or fever. Moyamoya disease can detect by magnetic resonance imaging. Left axial images reveals multiple signal void in the basal ganglia. Right corner image reveals well-developed basal moya-moya vessels in the bilateral basal ganglia. For the diagnosis, cerebral angiography is such as magnetic resonance angiography and/or digital subtraction angiography is essential. Diagnostic criteria are stenosis or occlusion of the terminal portion of the intracranial internal carotid artery or proximally portions of the anterior and/or the middle cerebral artery. Second, abnormal vascular networks in the vicinity of the occlusive or stenotic lesions in the arterial phase. Third, bilaterality of findings 1 and 2. Stage classification by Dr. Suzuki based on the cerebral angiographic findings is well known and used popularly in Japan. On the other hand, a classification based on the MR angiography findings has been proposed. In this system, the stage is determined by simply assigning scores to the MR angiography findings and then totaling the scores. Evaluation of the cerebral hemodynamics by single photon emission CT and/or positron emission CT is useful for diagnosis and assessment of the severity of cerebral ischemia. Hemodynamic cerebral ischemia is defined as rest cerebral blood flow is under 80% and cerebral vascular reserve is under 10%. In patients with moya-moya disease, there are 3 types of moya-moya vessels. Figure A shows basal moya-moya, which is formed from a group of vessels with dilated vaginal perforating branches. Figure B shows ethmoidal moya-moya, which anastomoses with the cortical branch of the anterior cerebral artery from the ophthalmic artery via the ethmoidal artery. And figure C shows bold moya-moya, which anastomoses with the cortical branch of the brain surface from the middle meningeal artery. Basal moya-moya, especially periventricular anastomosis detected with MR angiography, can be scored is associated with hemorrhagic presentation at onset in moya-moya disease, and colloidal collaterals are reported as a bleeding source with a high risk for hemorrhagic recurrence and a predictor of re-bleeding in hemorrhagic moya-moya disease. The IV sign is a characteristic magnetic resonance imaging finding frequently encountered in patients with moya-moya. It can be observed both in post-contrast T1-weighted images and fluid-attenuated inversion recovery images. While this sign manifests in the form of contrasting on the cortical surface due to the formation of left meningeal collateral development and increased number of piral vascular waves on post-contrast images. In FLAIR images, it originates from the slow arterial flow in the left meningeal collateral vascular structures. Medications may be prescribed to manage symptoms, to reduce the risk of a stroke, or to aid in seizure control, including antiplatelet to prevent strokes, calcium channel blockers managing symptoms of headaches, and anti-seizure medications for those who have had seizures. There are two types of revascularization surgeries, direct and indirect bypass surgery. In direct revascularization surgery, surgeons anastomosis the supraspinal temporal artery to the M4 or middle cerebral artery to increase blood flow to the brain immediately. Direct bypass surgery may be difficult to perform in children due to the size of the blood vessels to be attached, but is the preferred option. This intervention can be performed safely and with high efficacy by an experienced surgical team that treat moyamoya patients on a daily basis. In indirect revascularization, the goal is to lay over the brain surface blood-rich tissues to increase blood flow to the brain gradually over time. Indirect revascularization alone is almost always ineffective in adult patients. Types of indirect revascularization procedures include encephaloduro-arteriosynangiosis or encephalomyosynangiosis or encephaloduro-periosteal synangiosis, or a combination of these. I will show two moyamoya cases. First case is 5-year male admitted to a hospital presenting the paralysis of the left hand and loss of consciousness during an athletic event. Figure A, FLAIR MRI images shows the flavoid signs at both basal ganglia. Figure B, FLAIR image shows tiny infarction in the right frontal lobe. Figure C shows MRI angiography shows bilateral stenosis of C1 and discontinuity of M1 and basal moyamoya. But ACA, anterocerebral artery, and posterior cerebral artery are normal. MRA stage is 3 in both sides. Right carotid digital subtraction angiography shows stenosis of the right middle and internal carotid arteries and thick and distinct moyamoya vessels. Angiographic findings suggest right side Suzuki stage is 3. Left carotid angiography shows dilated anterior cerebral artery, middle cerebral artery, and narrowed internal carotid artery bifurcation with moyamoya change. Angiographic findings suggest left side Suzuki stage is 2. Single photon emission CT using IMP shows the left cerebral blood flow of both hemispheres has been reduced. First operation of right side, which was symptomatic, was performed. Right frontal branch of superficial temporal artery was harvested from the skin and anastomosed to the M4 portion of middle cerebral artery. Then, inside the right front temporal dura was anastomosed to the galea with parietal branch of superficial temporal artery. Another frontal craniotomy was performed. The frontal lobe, dura, was cut and box shape and inserted frontally. The dural defect was anastomosed with post-periosteum of frontal bone. 3 months after operation, right carotid angiography shows stenosis of the right middle and internal carotid arteries and thick and distinct moya-moya vessels. Transdural indirect and direct anastomosis from superficial temporal artery are developed. Angiographic findings suggest right side Suzuki stage is 3, same as preoperative stages. Left carotid angiography shows dilated anterior cerebral artery, middle cerebral artery, and narrowed internal carotid artery bifurcation with moya-moya change. Angiographic findings suggest Suzuki stage is 2, same as preoperative stage. Single photon emission CT using IMP shows blood flow in the right cerebral hemisphere has been improved, while blood flow in the left cerebral hemisphere, especially in the frontal lobe, is still reduced. Second operation of left side was performed. Left frontal branch of superficial temporal artery was harvested from the skin and anastomosed to the M4 portion of left middle cerebral artery. Frontal dura is cut, thickened arachnoid is cut, and find recipient artery of M4 of middle cerebral artery. Branch of recipient artery is coagulated and cut. Recipient vessel is harvested, approximately 10 mm. Place a rubber seed under the recipient vessel. Mark the recipient vessel with a skin marker pen at the area of approximately 5 mm. Donor vessels, superficial temporal artery is skeletonized using forceps and micro scissors. The tip of the donor vessel is formed into a fish mouth shape. Cut 60-degree angle first, then elongate a linear incision to the dull side. Inside the donor vessel is flushed using heparinized saline. The tip of the donor vessel marked with a skin marker pen. Recipient vessel is clipped and cut and flush inside with heparinized saline. Then a arteriostomy is performed. Stage sutures are placed on both sides using 10-0 nylon thread. Five to 6 stitches are sutured between stage suture in one side. Then, opposite side also sutured as same manner. After sutured, clip was removed. Indocyanine green videography confirmed the patency of the bypass vessel. Then, incised left front temporal dura was anastomosed to the galea with parietal branch of superficial temporal artery. Another frontal craniotomy was performed. The frontal dura was cut as box shape and inserted frontally. The dural defect was anastomosed with periosteum of frontal bone. After second operation, consciousness disturbance has not occurred since the surgery, but the patient is still experiencing the left hand weakness for a few seconds, about once a month. MR angiography shows moya-moya stage progression, but more prominent old moya-moya from superficial temporal artery, and MRI does not show any new ischemic lesions. The second case, 5-year female patient referred to our hospital with transient weakness of the left hand while playing the harmonica. Figure A, MRI flare image shows many flopoid signs at both basal ganglia. And figure B, MRI flare image shows IV signs in the right hemisphere. Right carotid digital subtraction angiography shows disappearance of the right middle and anterior cerebral arteries and thick and distinct moya-moya vessels. Angiographic findings suggest right side Suzuki stage is 3. Left carotid angiography shows disappearance of the left middle cerebral artery and thick and distinct moya-moya vessels. Angiographic findings suggest left side stage is Suzuki 3. The right side was considered to be more advanced in stage than the left side. IMP single photon emission CT shows widespread hypoperfusion of the right cerebral hemisphere. First operation was performed both direct and indirect bypass. First, superficial temporal artery to middle cerebral artery anastomosis is performed. Then, Galea with parietal branch of superficial temporal artery anastomosed to the dura. At the frontal bone, another craniotomy was performed, and the dura was inserted to the frontal lobe surface, and the periosteum was anastomosed to the frontal dura. 3 months after first operation, right carotid digital subtraction angiography shows transdural indirect and direct anastomosis from superficial temporal artery and developed. And the number of basal moya-moya, including choroidal moya-moya, is decreased. Lateral view shows bald moya-moya of frontal portion is developed. Angiographic findings suggest the right side Suzuki stage is 3, same as preoperative stage. Left carotid angiography shows disappearance of the left middle cerebral artery and thick and distinct moya-moya vessels. Angiographic findings suggest left side stage is still 3, same as preoperative stage. Second operation of left side was performed. Left frontal branch of superficial temporal artery was harvested from the skin and anastomosed to the M4 portion of left middle cerebral artery. The tip of the donor vessel is formed into a fish mouth shape. The tip of the donor vessel marked with a skin marker pen. Frontal dura is cut, arachnoid is cut, and find recipient artery of M4 of middle cerebral artery. Place a rubber seat under the recipient vessel. Mark the recipient vessel with a skin marker pen. Stage suture are placed on both sides using 10-0 nylon thread. Five to 6 stitches are sutured between stage suture in one side. Then another side also sutured as same manner. After direct bypass surgery, Doppler ultrasonography, also indocyanine green videography, confirmed the patency of the bypass vessel. Then, inside the left front temporal dura was anastomosed to the galea with parietal branch of superficial temporal artery. Another frontal craniotomy was performed. The frontal dura was cut and anastomosed with periosteum of frontal bone. The patient no longer suffered transient ischemic attack after the bypass surgery. She has been able to go on to regular elementary school and keep up with her studies. The IV sign of flare on postoperative MRI disappeared after 2 years, and there was no new cerebral infarction on MRI after 4 years. Thank you very much for your attention.
Hello everyone. My name is Yoshitaka Narita from National Cancer Center in Japan. Today, I will talk about awake surgery for gliomas. Prognostic factors of glioblastoma is age, KPS, neurological function, extent of resection, and as biomarker, MGMT promoter methylation status and IDH1/2 mutation is very important. The first step of the treatment of glioma is maximal safe resection. The gold standard therapy for glioblastoma is still maximal safe resection with radiation therapy with temozolomide. This is a case of thalamic glioma. After emerging temozolomide, some patients with glioblastoma have complete response by radiation therapy with temozolomide. MGMT promoter methylation is the most important favorable biomarkers in glioblastoma. Patients with MGMT promoter methylation is approximately 30 to 40%, and patients with IDH1/2 mutation is less than 10%. As shown in figures, GBM with MGMT promoter methylation have a longer survival than patients with MGMT promoter unmethylation status. Similarly, glioblastoma patients with IDH1/2 mutation have a longer survival. This is a result of AVAGLIO study. This study proved that treatment with bevacizumab prolongs independent time in patients with glioblastoma. This is our treatment strategy of glioblastomas regarding to chemoradiotherapy. After maximal safe resection, the patient with a KPS 80 or greater has radiotherapy with temozolomide, and the patient with a KPS 70 or less has a radiotherapy with temozolomide together with bevacizumab to maintain performance status. This is a classification depending on KPS and MGMT promoter methylation status. Half of patients have a KPS 70 or less. Generally, 30% of patients have MGMT promoter methylation. Finally, only 50% of patients of glioblastoma have favorable prognostic factors with high KPS and MGMT promoter methylation. Actually, 5-year overall survival rate of glioblastoma in temozolomide era in Japan is 16%. Gross total resection is possible in 50 to 60% of glioblastoma patients by intraoperative monitoring, awake surgery, and intraoperative MRI. Actually, from brain tumor registry of Japan, approximately 20% of patients underwent gross total resection, and 40% of patients had resection more than 95%. To achieve maximal safe resection, dissection of tumor, neuronavigation, intraoperative monitoring, awake surgery, and intraoperative MRI are important. (5-ALA) is important for resection of gliomas. 5-ALA is converted into PP9 and the tumor shines red by laser. Resection by 5-ALA prolongs progression-free survival in glioblastoma. Intraoperative MRI is always used for resection of tumors. About 30% of patients had more resection of tumors after first intraoperative MRI. This case is a patient with left frontal oligodendroglioma. After resection of tumor under awake surgery, intraoperative MRI showed a small residual tumor, and then we removed the tumor completely. This paper shows the survival of patients with low-grade glioma, glioblastoma, and brain metastasis. Improvement of extent of resection by awake craniotomy prolongs survival of the patients than under general anesthesia. I will talk about the techniques of awake surgery. Regarding to indication of awake surgery, the tumor location is dominant hemisphere and a motor area. Importantly, a patient's language function is normal. The patient can participate in awake surgery without fear. The patient's function can be assessed correctly by required tasks. Surgeons must understand the anatomical language network in the brain. There are two important streams. As dorsal stream, SLF and arcade fasciculus are very important in phonological processing. As ventral stream, MDLF, ILF, IFOF are important in semantic processing. Frontal afferent tract is important in driving of speech. Assessment of cognitive and language function such as SLTA, WAB, and WAIS are necessary. The patient must have an anticonvulsant such as Keppra, levetiracetam, and classically phenytoin. Consider intraoperative tasks in advance. Preoperative explanation and simulation for a patient in surgical room are also very important. For local anesthesia and nerve block, using 1% xylocaine or 0.2% ropivacaine are subcutaneously injected in supraorbital nerve, auriculotemporal nerve, greater or lesser occipital nerve.
Also, local anesthesia are injected into site of pins at head fixation and surgical site of scalp. For anesthesia in craniotomy, propofol and rimfentanil are used using laryngeal mask. Dexmedetomidine is useful for mild sedation in tumor removal. This is our surgical room. Many medical staffs participate in awake surgery to support the patient. Around the patient, surgeons, assistant nurse, anesthesiologist, speech therapist, or psychologist, and medical engineer are there. Around the patient, there are many monitoring machines. EEG, video camera, simulator, echo, navigation, and QSA or Sonopet are there. We have intraoperative MRI here. Extubation is performed under BIS monitor and vital sign monitor. Aspiration from LD tube is important. We prepare a video airway scope for re-intubation just in case. In extubation, compress the brain with your hands to prevent swelling of the brain. You can see blood pressure elevates in extubation. As brain mapping, counting, visual naming test, and auditory comprehension test are used. We usually use 4 milliampere square wave pulse stimulation with alternative polarity for 5 to 10 seconds. EEG and navigation are also important when mapping.
どうですか？はい、力いこう。はい。1、はい。はい。はい。はい。5、はい。6、はい。7、はい。8、はい。9、はい。10、はい。出ますね。症状出ます。症状出ます。はい、大丈夫よ。ちょっと待ってね。はい、ちょっと一回休みましょうか。はい。今症状。15、はい。16、はい。17、はい。18、はい。19、はい。はい。20、はい。20、はい。出ますね。はい、大丈夫かな。大丈夫ね。ちょっとびっくりしちゃうね。ここは腫瘍の外だからね。現在がすぐにカルベさん。あれ、松山さん。今はね、言葉出なくなったところはね、腫瘍がないところだから。はい。これじゃあこれ何ですか。そうです牛だね。これ何ですか。
ブローカーエリア。
これ何ですか。オッケー、大丈夫だ。これ何ですか。これ何ですか。この辺見れば見えるでしょ。こう。ねえ、これは。ここら辺がいいね。そう、それで、これ。オッケー。じゃあこの辺だね。オッケー。
Each therapist shows the card and the patient answer it. Please look. This is examples of questions used to test auditory comprehension. For example, what is your name? What color is snow? What color is sunflower? What color is a crow? This figure shows a brain map for left frontal lobe. This patient with anaplastic astrocytoma underwent gross total resection. This MRI was 1 year from the surgery. We have to mind complications such as pain, seizure, nausea, and GI bleeding. When the patient complains of pain, we have to repeat local anesthesia and use acetaminophen and dexmedetomidine. For GI bleeding or gastric ulcer, proton pump inhibitor is used.
6、8、9、10、11、12、13、14、15、16、17、18、19、20、21、これ水？冷水かけて。敬礼します。耳広告。わかる？うん。ねえ、今大丈夫ですかね？これ収まりますからね、今からね。はい。はい、もっとかけてください。はい。まだ敬礼します。30秒ぐらい今。脳波は出てない？筋肉ない？脳波はね、ちょっとわかりづらいですけど、出てます。オッケーオッケー、田村さんいいや。ここのビデオに、大丈夫ですか？落ち着きました。1回以内に回復する。はい、わかります？はい。河内さん、声わかる？はい。自分の名前言ってみて。はい、河内彦。そうね、お年はおいくつ？72。そうですね。今日何月何日かわかる？5月1日。
For nausea and vomiting, metoclopramide, granisetron, serotonin receptor antagonists are used to avoid aspiration pneumonia. When the patient complains of nausea, press the brain with your hands to prevent swelling of the brain during vomiting. I will show the video. The patient complains of nausea. Aspiration is also important.
書きます。はい。書きます、小橋さん。はい。書きそう。書きそう。そう。ちょっとだけ。これ当ててるか。一応ね、ここ、そうです。はい、いいですよ。入ったっていいですよ。はい、ずら。全部入って。
Diffusion weighted image shows the ischemia of deep white matter. She had edrabon and recovered neurologically in 1 week. This figure shows the blood supply in deep white matter. Medullary artery originates from cortical artery, supplies blood in deep white matter, and therefore removal of the cortical tumor with very small medullary artery leads to ischemia in deep white matter. This patient had ischemia of arcuate fasciculus from medullary artery by removal of the tumor. Post-operative management of white matter ischemia, such as enough hydration and edrabon, are very important. Today, I talked about awake surgery. Awake surgery is a basic skill for resection of gliomas for glioma surgeon. Our society published online about the guidelines for awake craniotomy. This describes surgical maneuvers for awake craniotomy, anesthetic management for awake craniotomy, language assessment during awake craniotomy. You can download from website. Finally, I want to address the cure of gliomas. If you are asked from a patient, "Can you cure my glioma?" what will you answer? This case was the longest survivor in Japan and maybe in the world. She started the treatment in 1970. She had right frontal oligodendroglioma, and she has a strong cumulative therapy and survived 49 years. MMAC was 26 points and normal, but KPS was 60 because of femoral neck fracture. She finally died of heart failure, not of brain tumor. This case is glioblastoma, which we reported before. This patient also has a normal daily life for more than 25 years. From these patients, it is very important to know glioma patients' cure of disease. This is the staff in my department. Thank you for your attention. I will see you again.
Hello and nice to meet you everyone. I'm Dr. Kishida. Professor Kazadi-Kalang, thank you very much for inviting me to your web seminar. I really appreciate the valuable opportunity. I'm a neurosurgeon of Japanese Red Cross Society. My hospital is located within the middle of Japan, between Osaka and capital city Tokyo. I am specialized in neuroendoscopic surgery such as endoscopic transsphenoidal surgery, endonasal skull-base surgery, endoscopic keyhole surgery, and so on. So I will talk about endoscopic surgery for intracranial tumors and cystic lesions today. You know, there are two types of endoscope, rigid and flexible. Flexible scope is not available in certain countries by virtue of sterilization, though. Our endoscopic surgeries are broadly categorized into 4 types. Flexible endoscopic surgery is performed on intraventricular lesions, and surgery using a tubular retractor is for intraventricular or intraparenchymal regions. Endoscopic keyhole surgery is useful for extraaxial region or skull-based lesions, and endonasal surgery is, performed for paracellar and skull-based lesions. Today, I will make a presentation about endoscopic transtubular retractor surgery. Although the idea of using a tubular retractor for neurological surgery has been proposed from 100 years ago, this surgical method is not so popular even now in the world, I guess. But actually, this type of surgery is very familiar to Japanese neurosurgeon. We operate an intraparenchymal or intraventricular hemorrhage using a small transparent tubular retractor when the patient meets the surgical criteria. In this surgery, single bar hole is made in the patient's forehead, and a small tubular retractor, 6 mm in diameter, is inserted into the hematoma. Then we evacuate the hematoma and stop bleeding by monopolar suction coagulator. And after removal of hematoma, we confirm hemostasis by irrigation. Pull out the tubular retractor and finish. All of procedures can be finished within 1 hour. That's very simple and safe method. So that's provided by Japanese National Health Insurance. I also started endoscopic hematoma evacuation at 2004 and progressively expand the surgical indication to cystic lesions and tumor cases. More than 200 cases have ever operated in these 15 years. Transparent tubular retractors are roughly separated into 2 groups, small and large. Small tubular retractors are products of Japanese companies. It is 6 to 9 mm in inside diameter. Large one named Bucite is an American product which lumen is oval-shaped and over 12 mm in diameter. Maximum size of tubular retractor we use is 70 mm in diameter. 21 or 28 mm Bucite is too large, too invasive for human brain, I guess. We categorize the transtubular retractor surgeries into 2 types, one-hand surgery and two-hand surgeries. One-hand surgery means single instrument surgery using a small tubular retractor via a single bar hole. Mainly suction forceps and straight scissor are used. Surgical style is similar to endoscopic hematoma evacuation. And another is two-hand surgery. This large tubular retractor named Bucite allows us to do microsurgical technique with both hands. For example, we can control hemorrhage using suction by left hand and coagulate the B cells using bipolar coagulator by right hand. So, one-hand surgery is applied to soft and suckable tumors or cyst fenestration. Two-hand surgery is good at handling of surgical instruments and allow us to do more aggressive resection of the tumors. Preparation of surgical instrument is very important. Bipolar or monopolar coagulator and ultrasonic aspirator are available and should be prepared for tumor resection. Malleable or curved instruments are very useful to avoid the interaction with an endoscope. This malleable dissector and rotatable forceps are our original product for endoscopic surgery. Now, I will show you the representative cases of transtubular retractor surgery. First, endoscopic transcortical approach. This is most popular surgery for us to operate the intraparenchymal tumors or lesions located around the lateral ventricle. Second, endoscopic transcolloidal approach for third ventricular lesion. Third is endoscopic transsulcal hyperietal approach for thalamus and trigone of the lateral ventricle. And last, endoscopic subtemporal approach for brainstem lesion. First, this is an illustrative case of endoscopic transcortical approach. Large intraventricular tumor suspected of glioma which involves the left thalamus straight vein. In this case, I deem the approach from lower frontal lobe along the bottom of the tumor to be reasonable to prevent avulsion injury of the thalamus straight vein. I planned to do two-hand surgery using 70 mm in diameter view site by a 3 cm craniotomy through 4 cm forehead wrinkle incision. This is an intraoperative video. Forehead wrinkle incision was performed and 70 mm tubular retractor was inserted to the left lateral ventricle. This is the endoscopic view. Compared to microscopic intraventricular surgery, endoscope provides wide viewing angle, close-up image even in deep and narrow space like this. Now I'm looking for the thalamus straight vein involved in the tumor. I detach the bottom of the tumor from caudate head and thalamus. Thalamus straight vein was exposed carefully and preserved. The tumor was divided into 3 pieces and removed piece by piece. Presumably, here is the origin of tumor. This is final view. Preserved thalamus straight vein is running here. Post-operatively, tumor resection and the patient's condition was good. And we could confirm the preservation of anterior caudate vein and thalamus straight vein here. This type of surgery can be applicable in various lesions. Posterior fossa, penetration of a cystic lesion, and shallow intraparenchymal tumor, and deep intraparenchymal tumor. In this case, I assumed the tumor has 2 compartments and inserted 2 tubular retractors in each compartment along the long axis. Next, transtubular retractor surgery also can be applied to third ventricular lesion. This is a case of colloid cyst with obstructive hydrocephalus. When we approach to the third ventricle, if foramen Monro becomes significantly wide, we are able to gain the third ventricle directly through foramen Monro. But if foramen Monro is narrow by compression by the lesion, we have to enlarge the surgical corridor by interpolynicial approach or transcoroidal approach. There is a risk of damaging bilateral fornix and internal cerebral veins in interpolynicial approach. So basically, I choose transcoroidal approach. In transcoroidal approach, the choroidal fissures and the roof of the third ventricle are opened by dividing the tenia fornicis that attaches the choroidal plexus to the lateral edge of the fornix. In other simple words, it is a surgical technique to enlarge foramen Monro posteriorly. This is a video. In this case, foramen Monro was very small due to compression by the choroidal cyst, and the cyst wall was too thick and hard to do fenestration. So I divided the tenia fornicis from the posterior margin of foramen Monro to widen the surgical